Hola, ¿qué tal? Buenas tardes, buenas noches, depende de donde se encuentren. Gracias a todos por estar nuevamente con nosotros y bienvenidos a este nuevo bloque.
Hello, everybody. Welcome to SIMI 2020. Now, what is new? Is there anything new in this prevalent condition? Depending, right, on every country, but stroke is the common denominator of this part of the program.
We are more worried about the hemorrhagic than the
concerned about ischemic stroke than hemorrhagic stroke, and there are many endovascular
for the treatment of stroke.
objectives. Obviously, we use thrombectomy, but we have, of course, involvement of the dural sinus spasms, and of course, it is a stroke that is in front of us. What about time is brain, image is brain, right? Fortunately, everywhere in the world we have a problem which
aging
is
of the population and the tremendous cost this involves. Many governments have seen the need to prepare people and their health system for the treatment of acute stroke. There's a lot of evidence. We just heard the evidence that it's much more cost-effective to treat with mechanical thrombectomy and RTP, the acute stroke, and not wait for the patient to be disabled. So time is also money. We have been rather going up and down. We have gone from depression of 2013, where IMS-3, MR rescue and synthesis gave us a big blow, showing that we were not superior to conventional treatment. But fortunately, if we follow the evolution of society, knowledge and innovation, we've seen we have achieved very soon afterwards, 2 years later, we've gone to achieve evidence. We knew that treatment in the acute situation with endovascular treatments could be tremendously effective, but it took time to build the evidence. Fortunately, the evidence is here, hand in hand with these trials that, reinforced by DAWN, actually changed the horizon. They showed with DAWN that the number necessary to treat is 2 to 3, something fantastic in medicine. If you remember how many patients were required in coronary stenosis, like 200, or how many you needed sepsis, more than 200. If you look at what the DAWN proof is fantastic. The effect size is the highest in stroke so far. So today we are going to review all this. But what happened in the meantime? What did we learn? To do better thrombectomies, or what actually happened? The impact of technology was amazing. The last trials actually had the presence of cell retrieval and aspiration that actually clearly showed superiority of mechanical thrombectomy. So in Buenos Aires, we have worked in some of these developments during all this period. But what is left? The objective is, what is left to do? A lot is left to do. The future is bright. We know we still have problems in some issues. If we should do MRI, CT, local anesthesia, general anesthesia. Should we treat patients with NIH-SS5? What about, endovascular? Do we only do trials? Do we do aspiration? Do we do both things together? It's not in competition. Neuroprotection will probably be reviewed, and there are already some trials, about this issue. And the frontier we are addressing now, that we will review this afternoon, and direct transfer. Let's say, can we skip MRI or CAT scan? Can we have perfusion images? Yes, I think this is the step towards the future. This week we did a case with transfer that It took from door to needle 11 minutes. So this is essential to develop and to work on. Esteban, we are in the presence of a distinguished panel, and I'd like you to introduce it before we introduce our first guest speaker, who's Dr. Henkes, that I believe is ready. Esteban? Thank you, Doctor. Good afternoon or good evening. We are going to start with this panel of experts, in this case from right to left, the ladies first, the summit of this Dr. Sabine Sierra, who is a vascular neurologist to my right, Dr. Jose Francisco Pepe Vida, vascular neurologist of wide experience, Juan Cirio, another great vascular neurologist, everybody knows him, and in the back, Javier Lungus, who is interventional neuroradiologist. So, if Dr. Henkes is ready, we are going to start.
Hans is there, so we'll go straight forward. You know, we are keeping, I'm sure also it's your experience, Hans, more and more ICAT in the setting of the acute stroke. So we'll be delighted to have your knowledge about it. So please, go ahead and show us your ICAT and stroke experience, please. El Dr. Henkes está en la clínica de Stuttgart, en Alemania.
Again, I have to thank Professor Lylyk for the invitation to present during this SIMI meeting 2020 and to talk about the intracranial atherosclerotic disease in the context of endovascular stroke treatment. These are my disclosures. If you talk about the frequency of intracranial atherosclerosis and atherosclerotic stenosis in acute ischemic stroke, we have to consider some numbers. So we know that about 10% of all ischemic strokes are due to or at least associated with intracranial stenosis. And on the other hand, the risk of an ischemic stroke in a patient with a symptomatic intracranial stenosis above 50% during the following years after diagnosis is between 12 and 14%. These are significant numbers. That's not a rare phenomenon. Intracranial atherosclerosis is a major issue during this treatments. When do we expect an intracranial stenosis when we treat a patient with a stroke? Intracranial stenosis are more frequently observed in men than in women. They are more frequently found in patients 18 years old and of age and older. Intracranial atherosclerosis is associated with arterial hypertension, with hypercholesterolemia, diabetes, metabolic syndrome, and Alzheimer's disease. So under these conditions, we should be aware of having an intracranial atherosclerosis underlying the acute stroke. We can find angiographic clues, of course. These are, first of all, extracranial atherosclerosis, and second, extensive leptomeningeal collaterals. This is a patient. He came with this symptomatic cardiac occlusion on the right side, and it was eventually found to be due to a stenosis which got acutely thrombosed and occluded, but he had other atherosclerotic lesions like this proximal ICA stenosis on the left side and this high-grade stenosis of the basilar artery. Extensive collaterals are a reliable clue. This is a stenosis which acutely occluded, and you see here this patient has on the right side extensive collaterals from the anterior cerebral artery to the middle cerebral artery. So whenever you see more than the usual collaterals, it may raise suspicion of having an underlying stenosis as the reason for the stroke. Procedural clues, there are several. One of those is if we fail to catheterize the artery. This is quite obvious. It's either dissection or stenosis, but if several passages with the thrombectomy device failed, or if we observe, if we use a radio-opaque device, if we see that the device is not properly expanding in the target artery, all this might be a hint for an underlying stenosis. This is a patient, he 60 years old man. He came in was brought in a comatose condition, and on the right side we see that the vertebral artery is only supplying the pica and his extensive collaterals on the surface of the cerebellum, and on the left side we have this occlusion of the V4 segment and the very poor opacification of the basilar artery. This is now the thrombectomy. The stenotic segment is has been catheterized, and the preset 6x30 has been deployed. We retrieve the preset together with aspiration through a Sophia, and what we see is some residual thrombus and underlying an atherosclerotic plaque, which had caused the thrombus formation and had caused the occlusion of the vertebral artery and poor perfusion of the basilar artery. Now we dilate with the plaque. This is an enterprise which had been deployed afterwards, and this is a 2 years follow-up. The patient, being comatose in the condition, survived in a reasonably good condition, being modified ranking 1, 2 years after the treatment. And as you see here, the plaque is completely dilated, and we re-established normal perfusion of the posterior circulation. There are some procedural details which should be considered. We do these procedures never under local anesthesia. The intracranial stent PTA deserves and requires a general anesthesia. We usually give 500 milligram thiopental intravenously 5 minutes before we do the PTA in order to increase the tolerance of the brain for the even more reduced blood and oxygen supply. We give something between 500 and 1,000 milligram aspirin intravenously as early as possible. Once we realize this patient has a stenosis, we give a high dosage of aspirin. Be aware of the fact that even if you give aspirin intravenously, it may take more than an hour to have complete effect of aspirin. We give 100 milligram ticagrelor through a nasogastric tube as early as possible, and together with aspirin and ticagrelor, we give a body weight adapted bolus dose of eptifibatide or integralin at least 10 minutes before the PTA and the stent implantation. This is followed by a body weight adapted infusion of eptifibatide for at least 3 hours after the PTA, and once the stenosis is removed or resolved, we make sure that the patient is with a systolic blood pressure under 130 millimeter mercury in order to avoid reperfusion damage and reperfusion hemorrhage, first of all. So we have several technical options. First, balloon angioplasty without a stent. This is usable for middle cerebral artery, basilar artery, PCA. We try not to use balloon implantation for the A1 segment because there's always a risk of damaging the connection between the A1 segment and the distal internal carotid artery. We catheterize the target vessel with a portal wire or a synchro wire, exchange length 300 centimeters, and we sometimes use an Excelsior SL10 to stabilize the wire while we catheterize the target vessel. The first PTA we do with a small caliber or small diameter balloon. For the MCA and the posterior cerebral artery, we use typically a 1.5 millimeter by 10 millimeter or 15 millimeter pita, followed, and for the basilar artery, 2.5 by 15. And we use very slow inflation, let's say 1-2 minutes, very slow, very careful inflation, manometer controlled, not higher than 4 to 5 atmospheres. The second PTA, we use a larger balloon. We go with 0.25 or 0.5 millimeter increments to the point where we think we have reached something like 70 or 80% of the original diameter of the artery. This is a typical case. The patient presented with an acute occlusion of the right M1 segment. The first it was a known stenosis. The first PTA is done with a 1.5 millimeter balloon with 4 atmospheres. You see there is residual stenosis. So this is too much residual stenosis, it's not good to leave it like that. So we come back with a second balloon. Now we use 2 millimeter, again, formed atmospheres. And we see here sufficient recanalization of the artery, no dissection, no elastic recoiling. And that's just fine. There's no need to do anything else. And the patient had this little DWI spots, but no major infarct. What are the pros and cons of balloon angioplasty without a stent? It's technically relatively easy. It is there are infrequent issues of balloon passage. So we use typically PETA balloon, which has a very low crossing profile. There are several coronary balloons also available. The catheter kickback is very limited, so even if your guide catheter is not very stable, it may work. It's a very inexpensive procedure, and there is no long-term dual antiplatelet therapy required, 6 weeks or something like that. And follow-up examinations can be done with CTA or MRI. There's no need to go for DSA follow-up. And if you have to do a thrombectomy after the procedure, you can usually do it after balloon angioplasty. The cons, the insufficient, it can be insufficient in the case of vessel dissection. So if the underlying lesion is dissection, or if you observe elastic recoiling after balloon angioplasty, you have to go further and use a stent. And the frequency of restenosis after balloon angioplasty is actually a matter of controversy. I wouldn't say our results are not so bad. We don't see a high number of restenosis after balloon angioplasty. Balloon angioplasty can be followed by deploying a self-expanding stent. This, again, is well doable in the MCA, basilar artery, posterior artery, and again, not in the A1 segment. For the A1 segment, if we go for stenosis of the A1 segment, we will probably try to get away with the solitaire only. For the combination of balloon angioplasty and self-expanding stent, we start with a balloon angioplasty as explained, and deploy afterwards an enterprise stent, an atlas stent, or a solitaire stent. And the main drawbacks of the solitaire stent is it's a relatively high rate of instant stenosis, which we observe after the use of the stent. The Atlas stent today is our preferred stent. It is accepted by a 0.017-inch microcatheter and has a very nice wall apposition. The solitaire stent has a higher radial force than the other stents, higher than Enterprise, higher than Atlas. However, it can be relatively difficult to catheterize the artery again if you have to go through for any reason. This is a patient, 62 years old, sudden onset of right-hand hemiparesis, and you see he has this typical phenomenon of extremely well-developed leptomeningeal collaterals between the anterior cerebral artery and the occluded middle cerebral artery, and this is the previous stenosis, which is now occluded. Passage of the microwire supported with an Excelsior SL10. In that case, it was SL10 together with a synchro. First dilatation with a 1.25 millimeter PETA balloon, a long balloon. It's good to use long balloons, so you have an even distribution of the force over the vessel segment you want to treat. With this 1.25 millimeter balloon, we have no sufficient recanalization. You see the artery is still occluded, so we keep the wire in place and we come back with a 2 millimeter balloon. Again, 4 atmospheres, again a long balloon, 2 centimeter long balloon, and now the result is much better. However, we see that the artery appears not okay. The artery is maybe has a dissection or has a tendency for recoiling, and at least we didn't trust this artery, and we implanted an Atlas stent, in that case 3/21, with a very good result. You see how much revascularization we have achieved with this relatively simple procedure. The patient had a basal ganglion infarct, but no real cortical damage, and this is an angiographic follow-up 29 months later with a perfect reconstruction of the previously occluded artery. this is also a technically easy procedure. The acute phase results are very good. It is expensive. These stents cost between 2,000 and 3,000 euro. We need at least midterm dual antiplatelets. We usually give dual antiplatelet therapy for 3 or 6 months. The follow-up examination, if you want to really have high quality follow-up images, needs DSA. And if you need thrombectomy after stent deployment, it's, I think, not really possible. The chance to displace the stent or to damage the arteries is really high. And there is a significant rate, as previously mentioned, high rate of in-stent stenosis, which is 25% or higher for the endosurprise stents, for instance. We can also use, instead of a self-expanding balloon, a drug-eluting balloon expandable stents, again, for MCA basilar artery, rather not for the posterior cerebral artery, and certainly not for the A1 segment. Again, we start with a PTA, as explained, and then we go further with it for a drug-eluting stent. Our preferred stent is Coroflex ESA. It's a very flexible drug-eluting stent, and again, it's used only if the PTA alone doesn't appear sufficient. All drug-eluting stents, including the Coroflex ESA, are not extremely flexible. So to say, you need a very solid guide catheter. It's preferable to have an intermediate catheter like the Navion, and a stable microguide wire. The recently launched Synchro Support is very nice for this purpose. This is a patient with a chronic right MCA occlusion with pretty good collaterals and acute onset symptomatic is kind of stroke for the left hemisphere. It's not a total occlusion, it's more kind of a hemodynamic compromise with this Petrus segment high-grade stenosis, which was passed with a wire. We pre-dilated the stenosis, the Petrus segment, with a 3x20 pita balloon at 4 atmospheres, and we deployed a coronary stent. You see here it's a 3x9 millimeter coronary stent implanted with 10 atmospheres. This is the result. The stenosis is completely removed, and you compare here the vascularization of the left hemisphere before and after the stent deployment, and again you see how much better the perfusion is after the removal of this stenosis. Patient recovered very well at this little infarct in the basal ganglia area, but at a complete recovery. The balloon expandable drug-eluting stents are much cheaper than the self-expanding aneurysm stents, and we have good acute phase results and very good long-term efficacy. It's much better than with self-expanding stents, and there's a low rate of high-grade or at least hemodynamically relevant in-stent stenosis. The procedure is sometimes technically challenging. First of all, because, as mentioned, the stents are pretty stiff. You need at least midterm dual antiplatelet therapy for 6 or 12 months, and the follow-up examinations require DSA. Thrombectomy after stent deployment should not be done. Our numbers, we treated 203 patients since September 2016. Why this odd date? September 2016. For us, it's interesting because after this, the treatment of intracranial stenosis was only paid by the health insurance companies if the patient was either in the acute stroke condition or if medical treatment had failed and the patient had recurrent ischemia, at least TIAs, under documented dual antiaggregation. So since this time, September 2016, we treated 203 intracranial stenosis. These were 140 elective procedures and 63 procedures in the context of acute stroke treatment. The 140 elective procedures were done with good results. We had 132, which is equivalent to 94% uneventful procedures. We had 4 clinically irrelevant or temporary symptomatic complications, and 4 complications with permanent clinical deterioration of modified ranking 3 or worse, and 1 patient died within 30 days unrelated to the procedure. We had 46 acute stroke treatments where we combined mechanical and aspiration thrombectomy with a PTA procedure. This was in 91% or 42 of those patients uneventful. We had failed attempt or hemorrhagic complications in 4 patients. You see here a breakdown of their outcome. We had outcome data for 36 out of 46 patients, 42 with good results, 36 with poor clinical outcome, and 8 patients of those died. All these were acute strokes. In 17 of these acute patients, we used only stenosis treatment. There was no need for mechanical thrombectomy. 16 or 94% were uneventful, and had 1 failed attempt. In that case, I remember we couldn't have a passage through the stenosis. Outcome, good results in 33%, poor results in 46%, and the mortality of 21%. In conclusion, it's very clear that a comprehensive endovascular treatment of acute ischemic stroke requires the management of underlying intracranial stenosis. It's very important to early recognize the stenosis in the acute setting of an acute large vessel occlusion in order to avoid uncountable futile thrombectomy passages. The undersized low pressure balloon angioplasty is usually the first step, and if needed, we go ahead with either a self-expanding stent if the vasculature is very tortuous, or with a drug-eluting stent if we have straight vessels in front of us. Thank you very much.
Well, thank you, Hans. Very nice presentation. We're looking forward for question and answer as soon as we finish the other 2 presentations. So, es mi placer ahora presentar a un gran amigo de la Argentina y personal, el doctor René Chapó. René trabaja en Alemania, en Essen, es profesor de...
It's my pleasure to introduce Professor Chapó, who works in Essen. He is a highly committed man to innovation. Innovation runs in his veins. He's going to show something that is extremely interesting. And we've heard a lot about it, and I'm sure you will listen much more in the future. It's about mechanical thrombectomy in distal territories. So we are ready to listen to René. So René, are you there?
Okay, nice to see you too. So we are ready to listen to you and learn from you, actually. So go ahead, please.
Okay, thank you. So I'm going to share my screen, which is this one here. Okay, and now I put this on like this, and it should work. Okay, and I would like to share with you the experience we have found out in distal thrombectomies. So let's see the evolution of. It's amazing that within not so many years we shifted from no treatment to venous lysis, and then to mechanical thrombectomy after failure of lysis, and then mechanical treatment was started simultaneously with lysis because there was no need to wait for failure, and now we're discussing already mechanical without IV. And I mean, the question is indeed raised, do we really need to combine both, to combine venous lysis and mechanical thrombectomy rather than thrombectomy alone? And this may be the politically correct answer, to say everybody has a treatment to do, but we have no way to prove it, and the different papers that have been done, we published our results, but also together with the team of Bern or other studies that show that there is no difference, and probably not to achieve some first already came out, others are ongoing, comparing thrombectomy with and without lysis. So Japanese studies is maybe underpowered, but at least showed no difference in both groups. So maybe mechanical thrombectomy is going to be done soon without IV. Another step, and all this is important for distal thrombectomy, another step is mechanical thrombectomy with neuroprotection. And it's amazing to see that neuroprotection is a topic that has been presented for many years, where, a lot of rats have been doing very well with neuroprotection, but in human it does not work. And all studies failed, including the last one where we participated, Escape NA1, where it was disappointing to see that it failed, no benefit of NA1, but details. If you compare the groups which had lysis and no lysis, in the group with lysis, so have patients having thrombectomy, lysis, and neuroprotection, there was no difference. 65, 63%, it's the same. But in patients not receiving fibrinolysis, there was a very significant difference between the control group and the group receiving neuroprotection. 10% difference, 50 to 60% of good outcome, which means that probably another step, or the question which is going to be raised tomorrow, is the patients we treat for stroke that receive thrombectomy, should they receive neuroprotection or should they receive lysis? And lysis have a lot of contraindication and a low added value. Whereas neuroprotection, if the question which is going to be raised tomorrow is the patient. Okay, I hope connection is good. The neuroprotection has no restriction in time and seems to be efficient, is efficient only if thrombectomy is being achieved, which means if we stop to do lysis because it does not bring anything, and if we do neuroprotection in those patients, and there are a lot of data that support it, then we will need to do more than thrombectomies than we do today. So how far to go? And how far to go? This is a typical story with a proximal occlusion, where you have a carotid T occlusion, first pass fails, second pass fails too, third pass is a success, and then you're happy because this is opened, and you start to look at all vessels and you realize that the MCA is there. And why do you want to stop? This artery is extremely important too. So there's no reason to stop. You take the same device, which we had here. I think here was a solitaire. So we used it and we opened, and you see both branches here are there. But if you look in detail, this is what we reopened. But here is an abrupt missing. So there is another branch missing. So here we changed to a smaller catheter, to the echelon. We changed from solitaire to catch mini to go here. And this enabled to reopen the artery of the central sulcus, which is certainly very functional. So here another example, MCA occlusion. You reopened the first. Here it was occluded. Here it's reopened. It's still the inferior branch of MCA missing. And we created. So then after second pass, this is reopened. This is better between here and there, but here is something missing. Here is something missing. This is before, and this is now. So at this stage, you see the two arteries missing. You may say this is frontal brain, but it's better to have the brain than not to have it. So we tried to go there. We did not manage to navigate with a rebar 18. So echelon 10 did fail also, but the headway duo did the job. And once the headway duo did the job, here it's a tiger that we put inside, a small tiger, and you see we could reopen. And here's a piece of clot. So does it mean only because it works that this is the future? And unfortunately, I'm not able to predict future, but I think that it's something very important to consider. we just be at our results on distal thrombectomy, and the paper has just been accepted on the use of the tiger in the very distal vessels. So amongst the last 21 months, out of 2,000 procedures, 700 were thrombectomies, 115 had distal vessel occlusions. So 1 in 7 of distal thrombectomies. And out of those 115, we had patients with primary isolated distal occlusion. And this is an example of this young lady with a lot of risk factors: diabetes, hypertension, smoking, previous history of arterial occlusion, taking oral anticoagulation. And husband left home in the morning at 9, came back at 2, and found his wife hemiplegic, aphasic, NIH 10, increasing to 16 when arriving in our hospital, with a suspicion of clot in the common carotid and some other clear occlusions. No lysis, because supposed to be taking an oral anticoagulation. And this is the angio. And this is a poor angio. I mean, you cannot occlude the vessels proximally, but look at the distal ones. 1, 2, 3, 4, 5, 6. All the vessels are distally occluded. And what to do here? There is no good way. It's a very painful way to start to go inside the small arteries, as we did. And we reopened several of those vessels with different devices. And then I realized that I had a new clot. So at this point, I only found, so a bit too late was my mistake. I found only too late that there was a clot in the common carotid artery that I could not remove. So I put a stent on it. And then I continued to take the other clot out. You see in the meantime, the anterior already occluded with a double system and aspiration catheter to take this out. And finally, well, we did not reopen everything, but here those both are still occluded, but a lot was reopened. And this is a CT after 24 hours showing what we did not reopen was still there, but the other vessels are better. So follow up, she was sent back to a referring hospital a couple of days, initially NIH 16, but 3 months later, she has only a ranking of 1 with a Bartel of 90, which means she's independent, the speech is okay, she just have a limited mobility of the hand. So I guess that we certainly have been helping this patient. Another one, much more older. This happened to me to Easter. This Easter, I was on duty. This patient had an NIH of 6 when arriving, but doing super well. Otherwise, 2 hours of walk in the morning, he must be doing time set. So I took him directly for mechanical thrombectomy without lysis because of this hyperperfusion. And if you see here, you realize immediately where there is the occlusion, where we tried with one device, it did not work. So we took a combination, tiger here, solitaire there, to reopen this vessel. And you see here the before and after. Now everything is reopened with a patient that immediately recovered and was sent back home 2 days later. This is the early CT, and this is a CT of 24 hours. So part of those patients, 1/3 of the group had isolated distal occlusions. 2/3 of the group had remaining distal clots after regular thrombectomy. And this is a very frequent situation. You go on here to reopen the MCA. And mostly, but is there something missing? And well, difficult to see on those pictures. I must say it's not easy, but if you have a local anesthesia, of course you will miss it. But if you have the patient on a general anesthesia, you will realize that this is occluded here. And this is something which was already existing before we started treatment. And if you play with the windows to look at the parenchymogram, you see that a lot is missing there. And to go there with a small device and taking this clot out is not a big deal. Of course, under the condition that you have small devices, that you have a patient which is not moving, and that you can reopen everything. And the third group are patients where during elective procedures, we ourselves create a complication. When I treated this aneurysm here, this is before and after, and you see that something is missing here. So up there, and here I put again tiger to take out, despite the fact that patient is on dual antiaggregation, and it was reopened. And fine, before and after, this is a CT showing that, did we create something? You have very often those kind of pictures, but there was no hematoma. Or this patient here with an AVM that we occluded, but still created some little material here, some little onyx, and this onyx may induce some further occlusion. So I prefer to take it out and to take here the device and to take this stuff away, because you don't know at this stage whether the vessel is going to remain open or to occlude. Okay. So out of those patients, half of them received intravenous thrombolysis before me, number of passes between 1 and 2, and most of the time it worked. I cannot pretend that all the time we can reopen, but in 3/4 of patients we had a good, successful recanalization. We did not have any difference whether patients received venous lysis or not. But of course, there are some complications, which is a reason not to do it, potentially. And if you look at the cold beam CT, the number of subarachnoid contrast media extravasation is quite frightening. It's 45%, which means every second patient, if you go beyond the Sylvian point, will have a little bit of contrast agent outside the vessels, which means there was some minimal bleeding. We have also some more important complication, SAH due to wire or with either spontaneous resolution in 3, temporary coiling or definite occlusion, and 8 patients with symptomatic intracranial hematoma, which you can see here, differences. Most of patients are like this, where you have a bit of something to be seen on cold beam CT, which is normal next day. This is a patient here considered to have a complication as SAH, which of course is clinically asymptomatic. And I think it's better to have this SAH without stroke than not to have this. And these are the ugly situations where you may have more of bleeding, which may not necessarily be symptomatic, but which definitely is a complication that was created. And here's some examples. A patient here coming with an occluded inferior division branch of the MCA. By the way, you see that there's also an MCA aneurysm. Have to bypass to the division branch. We first had to stent here, the ICA, and after proximal M2 retrieval maneuver, this is still remaining. And do you really want to leave it? If you have small adaptive material, you can go there and bring, the first pass did not work, but the second pass did it. You see those vessels here, this and this were reopened. And here is the clot, which is being stuck inside the small retriever, a little bit of something on the CT, so which we must describe. However, this is not something relevant. Here, a more important complication where we went into the distal part of the superior division branch of the right MCA, and immediate CT is good, but here we created definitely a significant complication. So we see various results. However, the number of complications hematoma remains quite low. And obviously, the benefit of doing this treatment is not the same than the benefit of opening a large vessel. So it's more risky to go into the smaller vessels, and you have less clinical benefit and also a potential efficiency of venous lysis. But the number of patients that we are treating that do not receive a venous lysis is increasing a lot. So to reduce risk of doing distal thrombectomy, certainly we need to have smaller devices, and miniaturization is the goal to achieve. It cannot work with large things, and aspiration is a great technique for proximal large clots. But if you need to go into small arteries, create a large device inside the small arteries. And of course, for all procedures, and in many countries, a lot of procedures are done without general anesthesia. I think it's not adapted to do this procedure without general anesthesia. The experience of the operator is also something that must be taken into account, and we see that in the team. The less experienced operators have more problems, so it takes a couple of years to feel comfortable to do so. And this is where I will stop. So I still believe it's a very important thing and very important evolution, but we need to be able to prove it in further studies.
I think we lost you. So thank you. Can you hear me?
I'm sorry for this. Hello?
Yes.
Yeah, sure.
Okay. So this last slide.
Absolutely. Yeah.
Okay. Thank you, René. You put things together in a very difficult topic, so we are very happy to see that everybody has the same problems, and we are facing maybe a next frontier. So thank you very much. We will skip the questions for. Please allow me to introduce Adnan, and after Adnan, we will have questions and answers and comment. We have a panel here. We have also joining your friend from Brazil, from Vitoria, Modenesi Freitas is with us virtually. So will join us on the discussion right after. But now it's my pleasure to introduce Adnan Siddiqui from Buffalo. I hope it's not too cold there, Adnan. And thank you for being with us at SIMI 2020. We are really exciting. As everybody knows, Adnan is a professor and is a director of neurosurgery at Buffalo. They are working in a fantastic place. I tell you, the Jacob Institute. They have it's a privilege to work there. And I was visiting there with Professor Hopkins. So great place, great experience, great team. We are looking forward to learn from you about the tandem and strokes setting, Adnan. Welcome and thank you to be with us.
Thank you very much, Pedro. It's always my pleasure, and I am very much missing my steak and Malbec this year, but I hope that we'll be able to resume our in-person meetings in the not-so-distant future. And René, as always, a masterful talk. I always learn a few things from you every single time I listen to you. So my talk is on tandem lesions. So the lesions, here are my disclosures. So when you look at the data in terms of historical data for internal carotid artery occlusion, it was clear very early on, this is the meta-analysis done almost 8-9 years ago, that there was a significantly higher rate of favorable outcome when these occlusions were recanalized. Unfortunately, in the North American trials, these patients were excluded from trials, which was a major disservice because when you look at the data from Mr. Clean, it is clear that one of the greatest amounts of benefit that could be imparted on these patients was when there was an intracranial ICA or extracranial ICA with M1 occlusion, and that was almost 1/4 of patients. So this is a large population of patients that are potentially amenable to endovascular therapy. Almost 145 out of 500 patients in Mr. Clean were tandem occlusions. And when you look at the benefit, look at the amazing rate of benefit for thrombectomy with tandem occlusions. This is from the ESCAPE trial, which was the Canadian run trial, compared to all other cohorts. This is one of the greatest areas where we can actually impart benefit to patients. And I think this is a very sizable sort of value. Revascats, similarly, when you look at the benefit, it outpaced other areas of benefit when you had a tandem lesion. So what do you do? Well, stent retriever was the first one, and this is from Francis Sturgeman's group meta-analysis. They looked at 11 studies, 237 patients. They got in about an 80% recanalization rate, 44% favorable outcomes. Here's another series with about 83% recanalization, 46% good outcomes, with reasonable mortality and symptomatic hemorrhage rate. So there's no question that thrombectomy has favorable outcomes in the acute setting. And should we use TPA in this cohort? The problem is what to do about stenting, what to do about loading these patients and dual antiplatelet therapy, what to do about intravenous thrombolysis. Is the addition of TPA to thrombolysis problematic from a symptomatic hemorrhage rate? And then when do you do this cervical stenting? Do you do it pre-thrombectomy? Do you do it post-thrombectomy? And then what kind of stent do you use, closed cell or open cell? So I can share with you what we do, and I'll share some cases with you as well from that standpoint, is we rely on the original CT imaging that is done on all patients. We have a very standard protocol for all cases. There's a plain head CT done. Intravenous TPA, if it needs to be given, is given on the CT scanner. And then immediately, if there's a hemorrhagic case, there's no TPA, and you do a CTA of the head. And if it's non-hemorrhagic case, if they're eligible for TPA, they get TPA, and then we do a CTA of the arch to vertex and CT perfusion at the same time. So when we do CT perfusion, we generate a 4D CT angiogram out of that multi-phase CTA data, and that way we can tell if this is a tandem occlusion or it's an ICA terminus occlusion, because if you just do a non-time resolved CTA, you will not get contrast going up the cervical ICA in a delayed fashion, and you will mistake ICA terminus thrombus with a cervical occlusion. And so it's important to have that 4D CTA available. And the moment we establish that there is indeed a cervical occlusion, we load the patient up with aspirin and ticagrelor in the emergency room, even prior to rolling him up. If the patient's intubated, as has been the case for the last year because of COVID protocols, we'll put an NG and give the thing, otherwise we'll give this orally if needed, and TPA is unchanged. Now, what do you do first? The integrograde option has the value that you're addressing the primary causative lesion, because when you have a tandem occlusion, it's a ruptured plaque, and the ruptured plaque is the source of the embolus that has gone to the brain. And by doing that, you're reducing the risk of distal emboli that may continue to occur as you're performing the intracranial procedure, similar to what you would do for a symptomatic carotid, where you have to be really mindful of all the manipulations you're making in the neck, because all those manipulations are resulting in progression of embolism to the brain. And you're also improving collateral circulation immediately by restoring proximal flow. The value of the retrograde first is that you might have a shorter angiographic time to revascularize the intracranial occlusive lesion, and you're dealing with the symptomatic lesion first. So there are pros and cons of both approaches. And so we try to look at, in our own institution, as well as a few other partners' institutions, to see what was the best way, what should be done first. And what we found was that there was no real difference we could establish, primarily because I think our numbers were somewhat low. And so what we have really migrated, and I personally have migrated, is a 9 French femoral sheath, which recently, because of a new balloon guide called Walrus, I'm able to now do this through an 8 French balloon guide. And then I use a balloon guide catheter. I used to use the MoMA device before we had good cervical devices, and then cross the lesion under flow arrest. If I'm unable to cross the lesion with the 014 wire, then I'll switch to more hefty 5 French 035 systems as well, and then perform angioplasty and stenting under flow arrest, followed by aggressive aspiration. I rapidly typically do intravascular ultrasound if there's intraluminal thrombus before I restore anterograde flow, and then perform the intracranial procedure as you normally would. The advantage with balloon guides being you can deflate the balloon and then go across the stent and displace it a little bit farther up. So here's some quick cases to sort of make that point. This is a tandem occlusion. You can see there's a very, very high-grade stenosis along with delayed filling distally. So we are bringing our MoMA guide in this particular instance. We have extracranial access in the external carotid artery, and there we do an intracranial baseline run, and you can see there's some reflux, probably a tandem occlusion. The ECA balloon is opened first, followed by ICA common balloon, which is down here in your screen. And then we go up with stenting. I prefer to use plasty first now rather than stent first and plasty second, because I don't like the cheese grating that can occur because of inflating a balloon inside the stent. Obviously that, and now once you have done that, you can now deflate the balloon. With the MoMA system, the downside was that this external balloon becomes problematic. And so in this case, we are just going up with a 6 French long sheath through the structure. By using a simple balloon guide, we have eliminated that problem by not having to use 2 systems. And there you can see there's a terminus occlusion. And once we have identified the terminus occlusion, we can now go ahead and in this particular case, I'm using an aspiration system. And because the aspiration catheter was stuck on the ophthalmic, cross the lesion with a microcatheter and in standard fashion, go ahead and establish a microcatheter angiogram. There's the solitaire being deployed, being pulled into the stent retriever. It's important when you're using a stent retriever to make sure you don't pull it through the cervical stent because it can get entangled. Here, both of these are being locked in and then we are being pulled with a cervical guide. And once you have pulled this back together, you have you can establish flow with excellent revascularization established, and the patient ends up doing very well because of this, because you have now restored flow. I think this is a simpler way of doing it because you're dealing with, there's a cervical run at the end showing excellent recanalization of the entire circulation at this time. So this is another case which basically shows similarly. Let's see, I want to make sure I'm not missing. There we go. Yep, this is the one I just showed. So here is an ICA, another case with occlusion, slightly different technology here. This is my partner showing a case. This is now a 6 French guide, which is being brought. This is not a balloon guide. Initially, they do a run, and now you have a tandem occlusion, what to do in this particular instance. And now he switches it over to a balloon guide. This is not a MoMA, so there's advantage in there. And now he's treating this almost like a traditional carotid stenting, where he crosses the microcatheter system with a distal filter. There he has crossed it with a microcatheter, getting distal access. He had to use an MPA catheter to really direct the wire to go to the right place. Once he has that, he then exchanges it out for a distal filter system, such as the Spider, and then with the Spider filter establishing distal flow, then he deploys a distal filter, and with the distal filter in place, he's deploying the filter. You'll see in a second. Once the filter is deployed, then he does standard angioplasty followed by balloon, by stenting, and that is done first. He's going to follow that. You can see there's restoration of flow. There's some spasm in many of these cases. You can give verapamil as well. And that's why I like to do plasty first. Now you deflate the balloon, you have your wire, and now you can advance your balloon guide right through your previously placed stent. And that allows you to not have to exchange your system out like I used to have to. There you can see the balloon is up and it's being delivered right through the previously placed stent. Now you can do an intracranial. There is your M1 thrombectomy. You can appreciate that. And now that is being brought up to the lesion. Use a J wire to make sure we stay in the primary vessel. We are getting stuck at the level of the lesion. You continue to push till you have crossed it. Your aspiration catheter is right across, and now you can deliver your microcatheter run. You can do your stent retrieval, and this allows the very straightforward. This is the Trevo device being used here, and once you have it in place, again, sandwich technique with the aspiration catheter, and with that in place, you can now pull the whole system back, and again, with aggressive aspiration, pulling the back together, with balloon guide aspiration as well in place. And this is the immediate post-procedure run showing excellent recanalization established in this particular patient. And so this is another sort of case, a 60-year-old who presents with acute right side hemorrhage, last known well 6 hours. So this is not a TPA case. There is an M1 occlusion. The ICA looks like she has M1 occlusion. You can see there's distal occlusion as well. And when we do a cervical angiogram, we appreciate that there is good preservation. There's an old infarct already established. And here's a perfusion scan showing the entire MCA territory with a small core already established. And there is an intraluminal thrombus sitting right there in the cervical carotid. So what do? You could just say, hey, we can just go across this. My feeling is there you can see the glob of thrombus that's sitting in there. This is the kind of situation where with flow arrest, you are now able to place the distal filter if you wanted to. In many cases, I don't even bother with a filter. I think we have flow arrest with the balloon. We go ahead, trap the clot with the stent in place. And the advantage, again, I'm sure Renee is cringing looking at the awake patient moving around. I think with expertise, you're able to actually discern how to sort of deal with this fairly well and get the job done. And the stent is being deployed, making sure that we have we're just pulling back, deflating the balloon slightly to make sure that we can express the stent. The thrombus has already been trapped by this time. There you can see the stent is being deployed fully. And once the stent is fully deployed, then you go ahead and you look at the intracranial lesion, and now you can just go right across. There's the distal filter being pulled back, and once the distal filter is out, we again don't capture fully the filter because there could be thrombus sitting in there. Now we have gone through the stent. There is my balloon guide in there. There's my aspiration. Here is the microcatheter. And now it's a standard stroke case, nothing fancy. There you do confirm the microcatheter. There's your stent retriever. And now you have additional sort of occlusion that is still there. And you pull the stent back. And this is your final run after establishing flow. Now I have to say I'm extremely impressed with the distal cases such as the one that might be out here. I don't think I feel comfortable putting a 4 millimeter solitaire, but I think if we had the Tiger Retriever, the Mini Tiger, I think that would make a huge difference to the way we deal with these things. So in conclusion, really, almost 25% anterior circulation LVOs are associated with cervical ICA. I think revascularization is extremely beneficial in these cases, more so than even standard anterior thrombectomy. Particularly what that means in converse is that if you don't reopen them, they are much more likely to be devastated than other lesions. It's unclear which lesion to deal first, but I think of this the same way I think of symptomatic carotid. I believe we stent first and thrombectomy second. I'm not sure if TPA helps or doesn't. I'm ambivalent. I currently do not stop TPA in these cases. I think there's probably a slightly increased risk with the dual antiplatelet therapy, but overall, again, I think the benefit is much greater in these cases. And again, thank you very much for this opportunity to share this forum with you. And I look forward to the discussion.
It was a presentation on Tandem. So now we are ready for a discussion. We have a distinguished panel here. But before we start the discussion, we will share with you a couple of cases that we have for discussion ready here in Buenos Aires. So I want to make sure that Rene is also on. Rene?
Yeah, sure.
Great. Maria?
I don't know. Rene seems to be in a very precarious situation. He's at a very high elevation.
Yeah.
And from the angle, I'm a little nervous he might fall backwards, you know. It's a long distance to go down there.
Okay. We expect have you, Rene, you, Maria, everybody in Buenos Aires for next year. So I just want to make sure Maria is on also?
Yes.
Okay,
Yes,
great.
yeah.
Okay, so Javier, would you like to show the case? Vamos a mostrar un par de casos para la discusión.
We're going to show a couple of cases for discussion. The first will be presented by Javier, and the other one by Dr. Escribano, my moderator. Javier, please go ahead. Hi, everybody. We're going to share a couple of cases related to the talks we've just heard. The first is a male patient, 76 years old, with a history of hypertension prior stroke, who arrived with a stroke that had been going on for 2 hours. At the time of his arrival, he got IV RTPA and an angiogram that showed this stenosis in the bifurcation of the MCA. The MRI showed a frontal lesion, as you can see on the right side, poor opacification of the MCA on that side. And so in this case, we had this lesion. You see invasion of the plaque at the level of the superior branch of the MCA, and then a plaque in M1 prior to the bifurcation. In that case,
En este caso lo estudiamos con resonancia magnética.
we did an MRI. At the time, we had given fibrinolytics, and in the MRI, in the T1 black blood sequence, you can see this enhancement, late enhancement, in the late phase of the MRI, which is showing a fragile plaque, a vulnerable plaque that is complicated. In this case, we asked help from the cardiologist, as in many other cases of these stenotic lesions. Here, Dr. Londero gave us his opinion about the most recommendable thing to do for this case, and he showed these schematic diagrams, as you see there, of kissing balloon and kissing stents. And you can see, and he told us what not to do. For example, not overlapping both balloons in one level, because that would add too much diameter. It would be oversized. Same with stents, trying to place stents first in the upper branch, that is the more complex branch, and then in the inferior branch without any overlap. Here we go with a microcatheter, because the microcatheter would help us pass to the upper branch and change the curve. Once we go into that superior branch, we need a closed curve. So we leave the micro and we change the curve, and we can go more distally. The other thing to be taken into account is the size of the balloons and the brands. Many of the balloons or intracerebral brands have markings, some in the middle, some in the ends. So you need to see them clearly to know exactly what is the space covered by the balloon to avoid overlapping and avoid rupturing the artery. Use the Asasi guides with good torque that allow us a 1-to-1 ratio. rotation. And here's the balloon angioplasty in the top.
La angioplastia con balón arriba.
Balloon angioplasty, top, sorry, and below. First, the placement of the stent in the superior branch, and then in the inferior branch. In these stenosis that are below 3 millimeters, we'd rather use drug-eluting stents. So here you can see the case finished, the T image of both branches, and the control CTA at 3 and 9 months, showing the same image. This is a reverse T. That is exactly what we see in the CT that is on top. Okay, now we go to the next case. The next case related precisely to the talk. Oh, just a second, Dr. Lylyk is saying. If you find it correct, we'd like to ask our guests here and our guests from abroad, if you agree. There's a 3-month and 9-month follow-up. In the 9-month follow-up, there's a mild hyperplasia, but the patient is doing well.
Do you have the translation in your site?
Yes, we can hear the translation, but the pictures explain the case very well.
Self-explaining, great case, fantastic treatment. Then not easy to have the stents just placed, just in contact. It's really a super treatment. Very nice.
Better be lucky than good sometimes.
No, it's not luck.
¿Quiere María?
Pedro, não, parabéns pelo caso, muito bonito, resultado perfeito.
Congratulations, beautiful case, particularly to show the efficiency of the balloon expanded stents. That is the right treatment, in my opinion. To gain time, well, it's very infrequent that in the MCI, yes, we do have a couple of cases. It's rare that you need to do balloon angioplasty before placing a stent in the MCA, because the plaques are not too calcified and you can pass with a stent. So it's rare to have to do a balloon angioplasty before placing a stent. But it was so close that we couldn't cross. Yeah. Well, of course, in most cases, we have no difficulty. Yes, maybe a rare case. In general, you can pass. Of course, it depends on the stent. We use a coronary stent, particularly the science stent. And the navigation is really good. And perfect positioning of the stent. We have 3 distinguished vascular neurologists in the room, Dr. Jose Vila. Can you hear the translation, gentlemen? Yes? We have an initial perfusion image.
Para ver si, ¿cuál es la fisiopatogenia?
I want to know the pathophysiology. What is the mechanism causing the deficit, the clinical deficiency? What is it? Why? There you can see it. Yes. Okay. Did this change after treatment? Oh, the patient did well. Yes. The patient improved. So it was an acute event of a chronic stenosis and apparently non-occlusive that you interpreted as an embolism that came from the plaque. Is that correct? Yes. With a hemodynamic component, of course. Yes, they're challenging because patient will not improve with medical treatment only. The point here is, in the MRA of the wall, there was a hemorrhagic component within the wall. Yes. And the prior event was in the same place? Yes. The patient had received complete treatment. That was in 2015, yes. And from then on, did the patient continue with the stenosis? Well, the patient came from a different institution, sorry. We'll continue with the next case now.
Ok. El siguiente caso.
The next case related to the talk of Dr. René Chapeau is a case that we show it on purpose. It is a complication. In a distal embolism, a patient that was relatively simple because this patient was relatively young with this occlusion in the M2 segment. I'm not showing all the data on purpose because of a technical issue, but we can see this artery, although distal, is quite large. It's a large one, M2. And in quite straight arteries, where the patient was outside the window for chemical thrombolysis. So the decision was mechanical thrombectomy. In this case, we used a solitaire. And you can see during the procedure, the solitaire, you can see the distal markings and contrast extravasation immediately after the stent. We're showing this because when we are distally in occluded arteries, we don't know exactly what there is. And for the new guys, I'm saying this, you have to go very slow with the microcatheter because we don't know what the anatomy is like after the occlusion. We have to test with minimal pressure, a minimum amount of contrast to make sure that we are not hurting, and at the time of deploying the device, doing it, maintaining the stent fixed in a fixed position, and just pulling out the microcatheter because we might cause a rupture of the artery with a stent. This is the post-procedure CT with that hemorrhage. Although the patient did not worsen in the modified ranking, the patient didn't improve compared to the point of admission. What was the size of solitaire? I think it was a 4. It was large M1, and we didn't have smaller devices. That's the other issue we had. Yes. René, what do you think? This is your domain.
There are many causes for bleeding. First one, wire. So, I mean, for each cause, there are some potential things that may help. But of course, this happens, and we have this kind of problem too. But to try to reduce it, for instance, to bring in the microcatheter in a distal place, I mean, up to the Sylvian, which was here the point of rupture, we put the wire with a J shape. So, for instance, a Traxxas wire is a Portal wire. If you push it as a J, you will not perforate, never with a J. Then, once a microcatheter is in place, we make a micro-selective injection to make sure that we're not in a small side branch. Then the other thing is, if you go beyond the distal point, and here the rupture, obviously it's a distal point, then the material must be smaller. So this upper here is the upper limit, and if the solitaire was beyond, and that you pulled the whole MCA down, then it may not be the cortical artery which is damaged, but the small transmedullary arteries that go horizontally at this level, and those may be the arteries that have been pulled. So one of those etiologies probably the reason for this, and may explain what has happened.
Okay. Let's say you have already a rupture. You see the rupture. What you should do? And if you see the rupture, you are there.
Okay. super important. Two things: put the blood pressure down, and second thing is deliver temporarily a coil.
Right.
And usually the bleedings are not as small bleedings, not major bleedings. It's usually a very small thing. So I think you can bring a balloon, but it's the time to prepare the balloon and to have it in place. Usually the bleeding had stopped. So by placing a temporarily coil,
okay, let's see.
Usually it resolves.
Doesn't stop. The bleeding doesn't. After 5 minutes, you still have some leakage there. Are you leaving the coil there? You still waiting with the coil without detaching the coil?
So, very good thing. During placement of one microcatheter and delivery of the coil, then I wait. I bring a second microcatheter very close, because very often the difficulty is to be able to see the bleeding, to be sure that it stops or not. Here it's an important bleeding, but very often it's a small one, and if you make an all-over angiogram, you don't see it. So the second microcatheter, which is shortly beyond the tip of, before the tip of the first one, will show you if it's enough or not. And then I wait 10 minutes, and again 10, and again 10, up to 1 hour. And I really wait a long time before I will occlude an artery.
Okay. Adnan and
Now here,
would you do the same thing? Would you do something different?
So I do exactly what Renee has talked about. It's just great to see that I always cross with a U. When I'm going distal, I'm always using microcatheters. I am very nervous about putting a stent retriever in those insular sort of branches, especially when they start going around the frontal operculum, because invariably you'll cause a hemorrhage. I believe that's where there is greater value for aspiration. The problem is we don't have very good systems for distal aspiration. We have 3MAX from Penumbra. We have the MIVI Q3, which I really like very much for these distal locations. It's quite navigable. And then there is the Zoom 35, which is also good. So the farther out I go, the more likely I am to go to aspiration primarily. Now, I am extremely intrigued with all these mini catch and Tiger 10 and all these fancy technologies. Somehow everything new goes to Rene first. You know, he always gets everything new first, and then everybody else, you know, you or Pedro, maybe those two people get everything first, and we are in the backwoods. We never get anything like that. But I love the concept of a 10 system with a small device to go for these more distal occlusions. I think that would make things safer. But as far as safeguard is concerned, this is exactly what I would do. And we use the same thing. I like a nice 2x8 coil. I always have a 2x8 ready in all thrombectomy cases, helical. Put it up there through the same microcatheter that you have for your stent retriever immediately. There's nothing faster than that. And then you have all the time in the world to try to figure out what you want to do. So exactly the same.
Say, Maria, do you have mini catch in Brazil?
Sim, nós temos acá. Mas assim, como disse eu...
Yes, we have it here. As Pedro said, for distal arteries, M2, I also think it's interesting to use IMAX, but I think is less risky when you have to manipulate distal arteries. The other situation, when you have to use a mini retriever, is use a mini retriever associated to TriMax and perform aspiration with TriMax and remove the stent retriever, because I think it has less complication, bleeding complications, I mean, because we know that the tortuosity of the vessels is so great that you necessarily will have a risk. So if you use TriMax together with stent retriever, I think that will minimize complications.
Gracias. We have 2 minutes left, so we will show our last case. Dr. Escribano has I believe, tandem lesion to show. Please keep in place for 2 minutes.
Pedro,
Sí.
Pedro, solamente uma pergunta para...
One question, Pedro, for the speakers.
Para a trombectomia mecânica, para...
For mechanical thrombectomy, in the case of distal arteries, what are the indications? For all arteries, or only for the area of the pontine, for the pontine area?
Maria is asking the indication of distal thrombectomy. Any distal thrombus or only in eloquent areas?
The more you do, the more you get greedy. The more you see that it works, and the more you enlarge your indications. Of course, you start with the super eloquent territory in a patient that did not receive lysis. As soon as there is lysis on board, you may have more risks. So that would be a reason not to do it. But then, I mean, all studies show, and we don't need a study for this, that TK3 is better than TK2B, which is better than TK2A. So why should we do the job? Not completely, because there is some risk, but this risk is luckily not so high.
I feel the same way, but I think, and I'd love to see what David Leveskin has to say about it, because I think the farther out you go, TPA becomes more effective. But what about, in my mind, is those people who are delayed presenters, who have no TPA is no longer an option, who clearly have eloquence which is affected. So if somebody's got, if you're a pilot and you've got hemianopsia, that's the end of your career. I think you should go for a P2, P3, P4. It depends. If you are 88 years old and you don't need to be out there driving Formula One, then maybe hemianopsia is okay. So it's qualitative. There's no clear data, but we need better tools.
Great. So last minute, Esteban, you have one minute to present the case, please. Stay with us just for one moment, please. I know it's late everywhere, but Esteban, por favor.
No sé si aparece.
Can we have the screen on?
Okay. Bueno, rápidamente.
Okay, very quickly, in 1 minute. This is a patient with a stroke, an acute stroke. The patient had 2 lesions specifically, one intracerebral and one in the neck vessels. In the CTA, we already saw that this patient arrived before 2 hours had passed. But when we saw this was a tandem lesion, you can see a proximal lesion and a supraclinoid lesion that is more distal at the level of A1 and M1. Over here and here, the 2 branches are absent, the anterior and the middle cerebral. So we decided to treat it in the acute situation angiographically. First, we wanted to attack the proximal lesion in the neck with proximal angioplasty with a balloon catheter. We passed the lesion, and then we had to rescue the intracerebral lesion with mechanical thrombectomy with a stent retriever. With 1 passage, second passage, where you can see replacement of circulation, and in the second stage, because the CTA showed no blood, in the second session, we did the stent angioplasty. This is the pre and the post in the perfusion image during the intra-op CTA. Final result. Thank you, Esteban. Thank you.
Very nice procedure. Definitely.
Yeah. Okay.
That's exactly how I would do it. I like the concept of fixing the primary lesion first. So you know what you're looking at. You know your access, you know your tortuosity, you deal with that first, and then you deal with the distal one after the fact. So that's very well done. But I like a balloon guide for this, very important for a balloon guide.
Okay. So I must say thank you guys. Obrigado. Thank you very much. Merci beaucoup, René. Has been a pleasure to have you guys with us. Next year, we'll stay on Balbec in Buenos Aires.
For sure.
Great.
Exactly.
Thank you very much.
Bye-bye.
Bye-bye.
Pasamos entonces muchas gracias a Esteban, muchas gracias Javier.
Thank you very much, Esteban. And now, let's go now to the collaterals. Let's go through the trials and upcoming frontiers, a little bit of artificial intelligence. David in UCLA, David Libeskind is a collateral pioneer, and he is organizing a similar SIMI for 4 years, but hybrid. David, are you there? Of course.
Great. I wish I were there, enjoying steak and Malbec, but it'll have to wait till next year. But thank you very much, Pedro, and everyone for the organizers of the meeting for having me an opportunity to speak to this esteemed group. And I hope there's time for questions as well. So I'm going to speak to you a little bit about what's new and what's not so new from a collateral standpoint in this year. A lot of this you may have heard me speak about before, but I think it's good to discuss and have an interactive discussion about some of these points, because clearly things are not absolutely crystal clear in terms of what to do at every stage. So the focus, obviously collaterals are important in terms of blood flow, hemodynamics in the brain. What we're trying to do in ischemic stroke, of course, is to reestablish blood flow when it's missing or limited. There is in history we have a mismatch, a difference between what we understand about the importance of blood flow and then what we do in practice on a daily basis for stroke. I think everybody would agree that hemodynamic approaches to stroke, whether it's restoring blood flow via revascularization or via collaterals, is the most logical, obvious strategy for ischemia of any kind. There's a lot of animal data now, and increasing in the last couple of years, in particular, on blood flow via collaterals and their effect and what happens not just before and after, but during stroke. A lot of very important information as to, here we're focusing on the peel or leptomeningeal collaterals and how they respond to whether it's induced hypertension or vasodilatory challenges as well. So I do want to speak about blood flow, but at the same time, we have to address some of the debate that we're having clinically. A lot of the debate has been about whether we need imaging or not, whether we need perfusion or not, and in which cases. And as you saw from just a moment ago and a few minutes ago, each case is a little different. The variables are different in terms of the nature of the lesion, the collaterals feeding that lesion, and the specifics of the case. We have had a lot of focus, obviously, in acute ischemic stroke on clot composition, this focus on emboli and where clots go to, but less so from a clinical standpoint on collaterals. That has increased over the last several years. And I think it's increased, however, because we understand the most basic fundamental concepts that we were told and we learned about growing up about stroke may not be that true when you start to add in the variables of collaterals. So that the main one I'm talking about is time. You hear more and more during this conference, as well as progressively, about how time is, not everybody keeps the same time, and not everybody's brain responds over the same time course due to, secondary to ischemia, or when blood flow is interrupted. The degree of injury that follows is different in one person to the next. It's also important to think about collaterals in terms of the response to the tissue and the likelihood of that restoration of blood flow is going to reverse that process as well. And then it has a lot to do with the amount of blood flow that's sustaining the tissue while that proximal artery is blocked. There's a lot that we can do in terms of blood flow. You just saw a moment ago a beautiful result in terms of the changes that you see right on the angio table. And we know this for a long time, that we don't necessarily need the fancy colored maps to show us the radical changes in terms of blood flow, in terms of a lack of blood flow and a restoration. When we want measures about perfusion and blood flow and via collaterals, that's where it gets a little bit more difficult in terms of the quantification, whether we're using a CT or MRI approach. And the bigger question has to do with, do we really care about those specific numbers or those thresholds? Do we care as to what we call, penumbral tissue based on the Tmax delay on a perfusion study? It depends. It depends on the situation, and it depends on the timing of that case as well. A lot of debate about whether you need to get information about blood flow early, or do you within the first few hours, or do you just skip altogether, which is an option. So when we speak about collaterals, obviously it's very specific, not just collaterals in the brain, leptomeningeal collaterals being the main focus. Really, we're not really talking very much about the circle of Willis in terms of the simple shunting of blood from one hemisphere to the next, or from anterior, posterior, in reverse. And we're learning more and more about what happens in terms of the functional consequences of how these collaterals kick in, and how they may fail as well over time, that I'll speak about briefly. So this paper was very important from the Calgary group, showing how, once again, what we get from an imaging study about blood flow has to, oddly enough, be interpreted based on timing. That there are differences in terms of we can't just go blindly based on one, based on the clinical or the imaging. We have to integrate the two to understand what's going on in terms of collateral circulation and how it may sustain or fail. There's a lot that can be done in terms of measuring blood flow in terms of collaterals. The Tmax or other delay parameters tends to be the most obvious one. And this has a lot to do with the fact that, it's the delay in blood flow that is the best marker in a complete occlusion. But of course, blood volume, and as I showed on the lower right, the blood volume gradients may tell you how there's where that change is greatest in terms of the change in terms of blood volume from one area to the next, and may be able to predict where your infarct is going to grow outward and progressively from subcortical to cortical regions as collaterals fail. And it's this mystery about collateral failure that still remains unclear as to what the causes are. Why are collaterals so good initially? This being seen beautifully described in the literature 30 years and more before the present time. But then there's a subsequent compromise, subsequent collapse of collaterals. And it's intrigued us clinically because we know we may be able to treat patients at a later time point where they're sustained by collaterals. But at the same time, it doesn't mean that those collaterals are going to stay forever. Because this collateral failure is something that we have to offset and not wait for. So there's a lot that can be done in terms of flow heterogeneity, in terms of digging deeper and deeper in terms of the derivatives, literally, of the perfusion curves, understanding what's happening in the local microcirculation. But the goal is to figure out perhaps what those causes of failure is that may be the most clinically relevant. So we see collaterals all the time. You know, for every occlusive lesion, there is a corresponding collateral blood flow pattern that we would expect to see, and not just that, but different degrees of how those collaterals are maybe manifest. It's also important because collaterals have been shown to be associated with better recanalization, more effective reperfusion, worse collaterals associated with hemorrhagic transformation, and worse collaterals associated with worse outcomes, as well as opposite being true, that even in a late time window, better collaterals equals better outcome. I mentioned this a moment ago about the circle, the dynamic change of the circle of Willis, and I don't think that this is as important, but I would just point out that it's dynamic as well. So the terminology about whether somebody has a fetal PCOM or not, to a certain degree, is irrelevant, because everyone was once a fetus and can go back and develop a fetal circulation if need be, and it can involute as well. So the circle can be dynamic. It's just that it's a relatively simple system of shunting of flow. So this just showing this example of how PCOM, as you see on a daily basis, opens up beautifully. The vast majority of MCA occlusion cases will have an open PCOM, and that's not necessarily because that PCOM was shunting flow before, but the second that you occlude that MCA, you will divert flow to that PCOM, and the opposite is true as well. Effective reperfusion is very commonly associated of the MCA field, will effectively reduce that shunting and involution of that PCOM flow. Reverse leptomeningeal flow is really the holy grail, the nut that we're trying to crack in terms of understanding this flow pattern. It's a highly unusual nature of flow, where flow only comes in through single circuits, only certain daughter branches. And this is important because it's highly unusual. It defies the basic laws of physics in terms of what we would expect to happen in a vessel. Murray's law does not hold in reverse. And as a result, you get shunting of flow across those bifurcations, filling in reverse towards the parent vessel, and not as much filling in necessarily the other daughter vessels. So it's this very unusual backfilling pattern that we see. And we see this all the time, despite us seeing this very frequently. The fact is that we don't understand it. It's not been modeled well. Non-invasive imaging is important before we go to the angio suite, to figure out who we want to take to the angio suite, perhaps, but also for planning, as well as perhaps to tell us about the degree of collaterals. Now, there's been a lot done with multi-phase CTA as well as CT perfusion, as well as MRI techniques in terms of predicting collateral flow. But you get to a very basic question here, which is how precise a definition do you really need in terms of your decision making? One can argue if you're going to go to angio anyway, you can quickly glance at this, and whether you see better collaterals or not, it may not really make that much of a difference. I'll argue that as much as planning is important in terms of the anatomy, in terms of access from a CTA, that initial look at the collateral status may also be important in terms of what you do sequentially in the angio suite. So going beyond the decision to just go and revascularize that patient, but there are cases where you may not want to, despite what Renee just said a few moments ago, you may not want to get a full TICI-3 reperfusion. In those cases with poor collaterals, prompt reperfusion may not be good. Now, it may change in the future what we do in terms of how far do we go with one case. Most commonly, it's a question of how far do we go after spending a lot of time with very resistant occlusions. But I think that decision-making in the angio suite is the next frontier. Now, we can tell a little bit about this from our non-invasive imaging done beforehand, and we can tell about this a little bit more about this in the suite. In terms of the CTA and CTP methods, these are all variations along the same type of approach, which is simply a non-contrast CT where you add contrast, and either you're tracking it at a late time point or you're tracking it throughout that injection to see how get some dynamic views of perfusion. So when it comes down to collaterals and this question about does this patient have good or bad collaterals, we can dichotomize like this, and we tend to do this. We tend to split things and say, that things are either, partially good or partially bad. But like with a lot of other things in imaging, it's very hard in terms of where do you exactly draw that line. Then partial filling, this grade 2 ASITN level of collaterals, is very hard to actually parcelate out. We can see some temporal information on static CTA. So single-phase CTA, not multi-phase CTA, tells us about the temporal arrival of blood flow as well. We're able to color code this as well to actually tell something about the function of those collaterals, not just their appearance. We can also delve into the topography, the areas that are involved in terms of how collaterals may fill one area better than the next. And this goes without saying that this is the next frontier as well, another frontier in endovascular therapy. How do we know, as Adnan pointed out, what is the most eloquent region and most important region of reperfusing at that next stage? It may vary from one area and one person to the next. So speaking about collaterals in terms of stroke evolution in the last few minutes that I have here and leaving time for questions, we know that time is brain only because they run on the collateral clock, so to speak. Collaterals will determine the time course of the injury. We know that this is associated with lesion growth. It's been shown again and again. The distinction between fast and slow progressors, the distinction between who you need to treat early and very rapidly versus who you may have time at a very seemingly late time point. You'll be hearing more about this. We've presented on this in the past, but in terms of collaterals in the late time window, this is a curious problem because we know that people in general that were entered into DAWN and Diffuse 3 had relatively good collaterals, but not all did. There was still a distinction in terms of who had good and poor collaterals, and even in DAWN, that distinction was related to outcomes at 90 days. Perhaps a slightly different look at collaterals in the late time window. In terms of collateral failure, this is what we're trying to avoid. Waiting too long and not knowing when those collaterals may fail. This is a little bit to do with pressure in the tissue as it increases, which then impacts that reverse collateral filling as well. There are very, very sensitive marginal differences in terms of collateral status that are influenced by pressure. This was shown very nicely by Daniel and his group several years ago now. I mentioned this earlier. Collaterals may be important in terms of reperfusion injury. That the degree of collaterals, poor collaterals, may beget reperfusion injury as well and lesion evolution. So I'm going to end here by just pointing out that collaterals are very important in terms of the precision medicine of stroke, the precision medicine of acute stroke, and what I think is the future in the precision medicine of endovascular therapy for acute ischemic stroke. Sequentially, stepwise, making those decisions in the angio suite, because obviously each case of endovascular therapy and with mechanical thrombectomy or other means is not the same as the next. And the goal is to figure out how we can further improve our outcomes overall. Thank you, and I hope there's time for questions.
Thank you very much, David. Collateral has been around, and I think it will be around as well as precision medicine. So please stay with us. We will have you for questions.
Okay.
I think we'll be also a friend of you from UCLA, Dr. Fernando Viñuela, with us for that roundtable discussion. So please stay with us. I will ask Dr. Mayak Goyal from Canada. Mayak has been around for trials and and vascular neurology for a while. Unfortunately, we cannot have you in Buenos Aires, but I'm sure we will learn a lot about the new trials, what is going on with trials and strokes, and also beyond that. So it's my pleasure to introduce Mayal. He's working at the University of Calgary en radiology, en neuroscience. El doctor Mayank Goyal es el próximo disertante de Canadá. Trabaja extensamente.
Dr. Mayank Goyal works in Calgary University, and thank you very much, Goyal, because most of the stroke evidence is his, and he is working in new trials in stroke. Thank you very much, Mayank. Please go ahead.
Good morning, everyone. I want to thank the organizers, Pedro, and the rest of the SIMI team for inviting me. I'm going to be talking about what are the current trials ongoing and where the world is going. These are my disclosures as expected to have run trials before and consulting for companies. Here's the broad outlay of the trial, EVT in terms of where the world is and where it's going, where is the world of thrombolytics and specific TNT going, and will we be using thrombolytics in the first place for patients with LVO? What about transport paradigms direct to mothership? What about neuroprotection? And what are the questions that we are finding it difficult to answer? And obviously, you're very much familiar with the data that is around this, the paper that we wrote in Lancet from the Hermes analysis at a phenomenal NNT, which is very well familiar to this audience. And then obviously the late window trials, which showed a phenomenal effect in the late window as well. In terms of this, it doesn't work only, so to speak, in a few countries, it works across the planet. This was Sheila Martins in Brazil, showing that it works very well in Brazil as well. And I've written extensively of this idea of denominator fallacy, which we have to keep in mind, that if we become super selective in the patients that we select for EVT, we end up getting good results, but that does not mean that is the way to go forward. We have to think about the patients that we did not treat along the way and how we can best optimize the overall outcome for the population, not just for a few patients. So that brings us to this question that at the current moment, with all the subgroup analysis that we have done, the question now is no longer which patient should be treated, but actually which patient should not be treated using the super powerful therapy that we have. And if you look at the fringes that we are currently looking at, there's the low aspects, there's low NIH, there's the MIVOs. There's also another question that is there, that in the late time window, are we being too selective? And that has been looked upon by Mr. Clean Lake, or many people are just walking with their feet and sort of making it more liberal on their own. So just to talk about low aspects, one of the problems we are thinking about from an aspects is that you can have an aspects territory which is completely dark. For example, here, you can have an aspects territory that is faintly dark, or you can have an aspects territory that is patchy. And we looked at it from the point of view of what we call nuanced score, where this is like a 0, but this could be like a half or a half this way kind of thing. And this is from the Escape Anyone database. And what we found was it actually matters. If you look at areas that are moderately affected, they do much better. Which also brings us to this point of that when we think about low aspects, are we thinking about it the same problem as uniformly? And there could be an area which is clearly a 0 and completely dark, and there could be an area which is subtly dark, and how do we sort of solve that problem as we move forward with the trials? When we looked at the Hermes database and we published the trial on the imaging, which was published in Lancet Neurology, we were able to show that in patients with aspects 3 to 5, there was benefit of treatment over here. So you can see this over here, this benefit of treatment. While in 0 to 2, there was a tendency for harm with very few patients. So now that we have this data, how do we use this data? How do we change guidelines? We did this survey, which was a worldwide survey across 38 countries kind of thing, and we present different kind of questionnaires related to 72-year-old with an aspect of 3, 33-year-old with an aspect of 2, so on and so forth. But the interesting part was that the majority of the people did say that they would treat the patients depending on what the scenario was. Especially if the patient was young, more than 50% of the people wanted to treat it even with an aspects as low as 2. So there is this issue when we look at things in isolation of just aspects as opposed to combining aspects with age, it changes the decision making. And it's across the world, and as expected, the aggressivity of treatment is higher in Western Europe and North America compared to certain other parts of the world. There are multiple trials running in this, in extremis, tension, 2 trials running in Europe. Hopefully we'll find out the results. But even when we do find out the results, we'll run into this complexity of a sort of a tunnel vision kind of approach to aspects. So if the trial is positive, does that mean we treat an 85-year-old with an aspect of 3? If the trial is negative, does that mean that we not treat a 44-year-old with an aspect of 5? And that is a problem we have to sort out. Moving over to low NIH trials, there is this issue which is with low NIH, there's a risk of making things work. But at the same time, there's a high rate of early neurological deterioration with medical management. And once again, we did this worldwide survey across 38 countries, and what we found was that a significant number of the population of people who responded across different countries, more than 50%, wanted to treat these patients, even though we don't have a good data set. And again, once again, as expected, this was maximally in Western Europe, North America kind of thing. But there's also the practical issue that at the low end of NIH becomes problematic. So for example, this patient who presented with NIH of 0, but could not do her job. She was a high-end, high-functioning financial advisor, could not answer a simple tax question. And whichever way you look at it, the NIH was 0. There was this perfusion deficit, as expected, was green because NIH was 0. There was an occlusion of ICA M1. And finally, when we opened the vessel, which we decided to after a lot of discussion, instantaneously, she knew the answer to the tax question and our brain could function. So that also takes us to the issue of, is NIH the right way to think about this problem? And again, there are trials running in this mode. Endo-low is starting soon as well. So we'll find out the answer. And once again, we'll run into this problem of that the trial results, will they be generalizable or not? Talking about medium vessel occlusions, we've been writing on this extensively. We sort of defined it and called it Next Frontier. This was published in JNIS recently. And this is how sort of we're defining it A2, A3, M2, M3 in terms of P2, P3, in terms of where the geographical location is. But in addition, it has to be combined with a substantial clinical deficit that is relevant to the artery of that is occluded. And there's this issue of primary versus secondary nevos, which many people have written about, that the clot moved to the M3. And we've been talking about it. We wrote this extensive detailed analysis of sort of outcome of discrepant infarct patterns, how to recognize secondary nevo. And that will become a big issue when we start to do a trial. For example, here, this is the area which is occluded, but this is the area where the infarct is. So how did this infarct happen? It's probably unrelated to the occluded vessel, which means either there is a second clot or the clot was more proximal at a certain stage. And that is something we'll have to be cognizant of as we move forward. And the degree of discrepant infarct, so to speak, are not. So we looked at all the databases that we had in terms of sort of nevos, and a phenomenal number of them had actually discrepant infarct, which means that there's a component of the mevo which was secondary, or it was multiple mevos sort of put together. And the other part that is there is the outcomes of secondary mevos are much worse than the outcomes of primary mevos, which is in a way expected finding because of the fact that there are other parts of the brain that are affected. So we think 20 to 40% of all mevo strokes may be secondary mevos, and that is something we have to be cognizant of. What about the clinical course of mevo? So one of the things that people talk about is, oh yeah, it's a small vessel, TPA will work, let's get it open kind of thing. But we found that 50% of the patients do not end up with MRS01, which is sort of super important to remember here. And obviously TPA does improve the recanalization, but in spite of the recanalization, 55% of the people had MRS01 versus not. So that's something to keep in mind. The TPA, while it's a great drug, does not work like magic. There's still 50% of the patients that do not open with alteplase, and that is something we'll have to sort of keep in mind. Now, obviously, there is no level 1 data from it. There is limited data from M2, which we published in JNIS, that in M2 occlusions within Hermes, there was benefit of treatment. Now, it's important to remember that within Hermes, a lot of those M2s were such that they were M1-looking M2s. There is this issue that people talk about that mevos may be challenging to detect on imaging, especially the readers of limited experience. And from that perspective, it's likely that future technologies, for example, color coding of multi-phase CTA maps like this one, will help in it. So here, for example, you know by this different color that there has to be an occlusion over there, and makes it very easy. There's also these kind of maps which will soon be available from multi-phase CTA or from CT perfusion, which will help in detection of mevos. So, different people are thinking about a trial in this regard. This is not an easy trial to run. We are thinking about it as well. Is tenecteplase knocking on the door? We've seen the results of the Extend-IA trial, Extend-IA TNK from the Australian group, which showed benefit of TNK over TPA. There are higher recanalization rates and better functional outcome. The dose did not seem to matter. There is this issue of in patients who are going for EVT, does TPA really add anything or not? And I worked with the Dutch group and the Chinese group, led by the Chinese people in Feng Day and Jianmin. It was a sort of a pleasure to work with them. That showed the non-inferiority of EVT alone. Mr. Clean, no IVS finished enrolling, and the results should be out soon. The other part that is there is IV thrombolytics in the extended time window, and Gottstamala and team in Hamburg with this trial in terms of MR based is also a trial time that's running, which is enrolling quite well, and we should know the results soon. We ourselves are running a trial in Calgary, which is the ACT trial, plain and simple, alteplase compared to tenecteplase in all comers that are eligible for alteplase. The stroke transport paradigm, there's obviously the issues of direct to mothership, drip and ship, flying neurointerventionist mobile stroke unit. And this is a question that we've looked at in detail and did all kinds of modeling around it. The RACE-CAT results came out recently, but at the same time, there was no difference in outcome, whether you went direct to mothership or with a drip and ship situation. There is the issue of mobile stroke unit. This data was presented at the last ISC in the Berlin area, where mobile stroke unit had high chance of receiving IV thrombolytics and shorter time to needle with MSU. But at the same time, there was lots of complexity of setting it up, the cost associated with it, and I'm not sure too many people will be able to replicate this in terms of a resource allocation point of view. There is a lot of work going on in terms of pre-hospital LVO detection. There are many different technologies that are being tried and things like that. We are working with this device called Forest Devices. We looked at all possible devices and we found this one had the best balance of practical utilization in our context versus their ability to detect LVO. The trial is called SIGWA trial. We should be starting it soon. Michael Hill and I are leading it. Now, in terms of neuroprotection, this is, in our opinion, probably the biggest story. That is where we are focusing our energy. You know the results of the ESCAPE NA1 trial. It was a phase 3 trial looking at this drug NA1 in all patients who were going EVT. It was a worldwide trial. The main results did not show any benefit of NA1, but in the subgroup of people who did not receive alteplase, there was approximately 10% benefit that was seen. There was a benefit of mortality as well. And obviously, as expected, this was a subgroup analysis of 446 patients. We need to go and repeat this trial and see whether this was a chance finding or not. So that is what is called ESCAPE Next. And that is what we are focusing all our energy on. We hope to have the first patient randomized within the next 1 month or so. And it will be on all those patients who do not receive alteplase. And as you know, the alteplase story is moving along because of the direct empty trial. And hopefully, Mr. Clean No IV trial will confirm those results. So there will be a shift away from alteplase. There are questions that we should be thinking about but are difficult to answer. For example, what is the denominator? What is the total number of patients with an EVT eligible occlusion in the total population? And how many of them we are able to treat and how many of them we are not? And the ones that we are not, what are the reasons for non-treatment? Is it related to patient education? Is it related to transport? Is it related to imaging criteria? And so on and so forth. The other part that is there, which we've written extensively about it, is that, you know, what is our technology capable of from the point of view of calling dead brain? Is that brain truly dead? And we have strongly said that we should not be calling it dead brain or should not be using the word core, but we should sort of be further studying this idea of dead brain. And right now we have proposed this term SITUV, severely ischemic tissue with unknown viability, and that unknown viability is going to be dependent on how fast and how well we open the vessel. So here in the last 20 minutes or so, I've rushed you through all the stuff that is going on in our world. We are at a very, very exciting phase. We are moving towards more and more evidence-based medicine in the world of acute stroke. Hopefully we'll move in that direction in the hemorrhagic stroke side as well. But the next few years are going to continue to be exciting, where this field is going to expand and we will have a much better idea of how to help our patients from this otherwise devastating condition. I'm going to stop here. Thank you. And open it up for questions.
Well, thank you, Mayank. Very nice presentation. I'm sure I already see some questions, so please stay with us for the questions. Nuestro próximo invitado es alguien muy conocido por todos.
Next speaker is well known to all of us. He is a Latin American who is well known for his interest in stroke, because he's worked so hard, particularly in trials. He was highly involved in the trial that showed that in Brazil, endovascular treatment has a benefit, just like in the rest of the world. And these findings can be extrapolated to all of Latin America. So our friend Raul Nogueira, professor of neurology, neurosurgery, and radiology at Emory in neurocritical care, he is the director of the service at Emory, and in the Memorial Hospital. I would like to ask him to be with us in this section. can you predict that recanalization will be futile, as they say in English, or there's no point in doing it? It would be very nice to know that, because we could save a lot of work and much damage to a patient. It's a pleasure to introduce Raúl Nogueira.
Bienvenido.
For the opportunity to discuss this fascinating topic. Here are my disclosures. So how to predict futile recanalization in stroke using imaging? I believe that at this point, we actually can't predict futile recanalization with imaging. More importantly, at least in the early window, you should not even try to. It's important to acknowledge the possibility of futility. It's a concept that has been there since the foundation of medicine. There are limits to what we can do for any given patient. However, futility represents an unacceptable likelihood of achieving an effect that the patient considers a benefit. There are two components to it. One is a quantitative component, where that likelihood of a benefit is exceedingly poor, less than 1% chance. So it's not low, it's very, very low chances. Moreover, there is the qualitative component of futility, where the quality of the benefit is also exceedingly poor. These concepts are not adequate because it's hard to get a consensus on what these two components are. However, exceedingly low probability rather than uncertainty and unpredictability define futility. The other important concept is that medical futility should not be confused with healthcare rationing. This is not about how much does a treatment cost, but rather do the advantages of this treatment outweigh the disadvantages in this particular patient. In terms of common wisdom, it's simply to give the patients the benefit of the doubt. How do we define benefit in acute ischemic stroke? And I think there was a lot of confusion in our history where you would dichotomize things in the good and the bad, right? And you got more sophisticated with the ordinal shift analysis, where you acknowledge that there is a benefit in going from the different steps of the disability scale. But we then got even more sophisticated, and we start acknowledging that the movements along of the scale had different weights, right? So I think it's important that you understand that this is not about having a good outcome, but rather about having better outcomes than without treatment. There are many other benefits that you can't measure with our typical metrics, like there are cognition and performance benefits that are not properly captured by the modifier 1 scale. One can prevent a hemicraniectomy with aggressive reperfusion, a procedure that actually rescues ischemic brain and prevents cerebral edema versus the hemicraniectomy that only rescues the herniating brain. It also can shorten length of ICU and hospitalization stay and potentially cut costs as such. Another important notion is, at least with the way thrombectomy is currently performed, we improve quality of life rather than quantity. Very modest improvement in terms of mortality, but you do not increase the amount of people who are living with a high degree of disability. The bulk of the improvement is with good quality of life. How do you quantify benefit in acute ischemic stroke? And here I think you use two weights with two measures and a double standard when you compare endovascular treatment with intravenous treatment of stroke. Here are good examples. We have the recent EXTEND trial. We see here a treatment effect size of 6.7%, and that was a highly positive and celebrate study as it should. It is another study that was highly positive and celebrate as it should, the CAS3 trial, treatment effect size of 7%, 5%. The investigators for the PRISM trial consider a benefit that would be significant if it was more than 6%. The most investigators have lowered it to 4.5%, when you ask stroke experts, the median minimal clinical important difference for us to notice across treatment, no treatment with a novel and safe therapy is as low as 1.3% in the opinion of stroke experts. So maybe you have a bar that is too higher for endovascular therapy. The expectation is too higher because our early trials have been so powerful, but they were so powerful because you really over-select the treatment population. You are not treating a lot of people who could still benefit. Like the BASICS trial was considered a recent failure, again, with numbers very similar to the numbers that I just demonstrated to you, 6.55%, very similar. True that it didn't reach statistical significance, it was underpowered, but the treatment effect size is as good as celebrated trials in intravenous thrombolysis. Other thing is why the concept of reperfusion futility based on imaging is a bad idea. One must be very careful to avoid the misuse of imaging, which you are doing more and more. We tend to think that as you do more imaging, more complex imaging, we gain accuracy despite losing time. You have to be careful. As you look the data on CT perfusion, diffusion, post-aggressive and fast reperfusion, things are very confusing. You can have a patient with a core of 91, as you see here, that with rapid endovascular perfusion has absolutely no core on the DWI post-mechanical thrombectomy. This is what you call the ghost core and has been reported by our colleagues from Barcelona. Predictor early reperfusion treatment, right, for patients treated in the first 3 to 6 hours. So the message here is that you should never exclude a patient from treatment based on CT perfusion findings alone. This is our experience at Grady. We have looked at, within the first 24 hours, almost 10% of the patients will have a ghost score with a reversal greater than 10 cc's. If you consider the first 6 hours is actually almost 15%. These lesions can be quite big, 20 cc's. In a quarter of the patients was over 33 cc's. The predictors of ghost score include early onset to reperfusion time, less than 6 hours with an odds ratio of almost 3.5, but also poor collateral scores, okay? But what is really important is the presence of a ghost score was an independent predictor of lower disability. It's actually a good marker if you actually correct for the patients that have the real core, obviously. How about the DWI? Is it a lot better? Well, it's a very good way. It's easier to see, but you still can have cases like this where you have with aggressive early reperfusion, remarkable DWI reversible. How common is that? Turns out that approximately 15% of the patients you have a permanent DWI reversal greater than 10 cc's or so. It's not that uncommon. Okay, so ghost scores with both CT perfusion and DWI. So in my opinion, the only real marker of necrotic tissue, reversible damage, is loss of gray white matter differentiation, non-contrast CT. It's the most reliable biomarker. So why waste time with more imaging in patients if you can't trust that? The other thing that's very important to understand is to refine the idea of not only the quantity of infarct, but also the quality of infarcts. Not all infarcts are made equal. It's a heterogeneous process. This paper in Nature, it's absolutely fascinating. They essentially disembodied a pig brain. They kept it in normothermic conditions for 4 hours, and after that, they hooked it up to a perfusate that had the oxygen and nutrients. And by doing so, they document preservation of cytoarchitecture, attenuation of cell death, restoration of the vascular dilatory response, and glial inflammatory responses. 4 hours of a disembodied brain. You see, again, reperfusion bringing a lot of the brain tissue back. It's absolutely amazing. So reperfusion is very, very powerful. And futility in reperfusion is something that we need to question more and more. Why? Because you need to start understanding the concept of selective versus diffuse tissue death. The neurovascular unit, it's not composed only of neurons. You have vascular cells, you have glia, and these cell lines have a differential vulnerability to ischemia, right? So while you have normal brain, there is actually a spectrum with several shades of gray going from selective gray neuronal necrosis to progressive neuronal loss with glia preservation before you can get into the pan-necrosis. And probably people in this spectrum here will do a lot better than this spectrum, okay? So it's the idea of an incomplete infarct, which is what you have here. This is a patient that you reperfuse after a ACA, MCA clots, and you can see this pattern that almost look like cortical lamina necrosis with sparing of the white matter and a lot of the brain scaffold all the way to the 6 months follow-up, right? So yes, a lot of neuronal loss, but you still have a lot of the elements, right, holding this scaffold together. It's very different than a patient that has pan-necrosis with cystic encephalomalacia like this. I think these patients will have different outcomes. Another reason why excessive imaging in the early window is a bad idea is that most people, about 85% of the patients, have favorable imaging within the first 6 to 8 hours. So why waste time looking for bad imaging if 85% have good imaging? And here is a paper with about 85% in the first 6 hours. Is another paper with about 85% of the patients with favorable imaging in the first 6 hours. So what about if one does not have a favorable imaging profile, 15%? What happens then if I do reperfusion? Can I harm them with endovascular reperfusion? Well, let's look at that. And when you look here, less than 70 versus greater than 7 mmol on CTP and MRI in the Hermes meta-analysis, you don't see more symptomatic intracranial hemorrhage in these patients. Not only that, but this 15% of the patients with the not so favorable imaging profile actually seem to benefit. It is the Hermes 3-5 analysis, 186 patients, and you see that they do have a higher likelihood of having less disability and a higher likelihood of being function independent at 90 days, both statistically significant. Looking at core size now, greater than 7, it's not statistically significant, but you can see here that there is an idea of a benefit. Even if you look not only at CTP, but also at TWI, you can see, again, the numbers are small, but there is an idea of a potential benefit. So not surprisingly, when you look at the first 6 hours, most patients will benefit from treatment, right? So the conclusion here is, right, in the early window, you are wasting the precious time when we know the vast majority of the early patients have favorable imaging. In order to identify 15% of the patients with unfavorable imaging, when you do not even really know if they don't benefit, right? We don't even know if it is futility. It should be less than 1% chances of benefit. So it just doesn't make any sense, right? The other problem that you need to understand is this confusion in our field between predictors of outcome and treatment effect modifiers. This comes from the fact that we start with single-arm, uncontrolled trials, so you are comparing thrombectomy with thrombectomy, treatment, no treatment. Yes, younger patients do better, lower NIH strokes patients do better, higher specs do better, right? However, if you actually compare not different patients in terms of this, but similar patients in terms of these characteristics, treatment and non-treatment, which we now can do through randomized clinical trials, you see that neither age, stroke severity, and it seems not even aspects, stroke size, are treatment effect modifiers, okay? Here is the answer for who does well with treatment. But this is the more important question. Who does better with treatment? Who has any chances of benefit? And imaging markers are predictors of outcome, but not necessarily treatment effect modifiers. Look at this beautiful analysis from the Hermes data. Greater than a third of the MCA doesn't modify treatment effect. Aspects doesn't modify treatment effect. So where is the futility here? Excessive imaging leads to over-selection. more selection in these trials, better outcomes in endovascular group, but also better outcomes in the controls. You're just filtering patients out to the point that if you compare the endovascular treated patients in Mr. Clean with the controls from Extend-IA, the controls in Extend-IA are better. So again, CT perfusion, excessive images, filtering people out that could still benefit from treatment. This is over-selection. And here is how you can even illustrate this better. CT perfusion, 100 patients, they are selected. Very high treatment effect size. Number need to treat is 3, 70% are function dependent at 90 days. This is very much like Extend-IA. This other group is selected more inclusively with non-contrast CT. We end up treating a lot more people. The benefit is not as good. In fact, half of this treated population has these outcomes, right? And you go like, well, I would rather be here than here, but look at the denominator fallacy issue here. When you look at the overall population, 10 out of 100 here benefit as opposed to 16 out of 100 patients here benefit. So this is the issue of over-selection. Some final basic concepts here, treatment power and time sensitivity. How big is our treatment effect size? It's one of the largest in medicine, probably because you are over-selecting so much. It's almost like antibiotics in sepsis, right? So how do other fields in medicine deal with time-sensitive conditions that are very severe? Like STEMI, go straight to the room, you don't do a myocardial scan, sepsis, bacterial meningitis, you do antibiotics, you don't wait for lab results or scans. So why, in the face of a large vessel occlusion stroke, high stroke severity, early on, we are not taking these patients straight to the angio suite? I think that's a mistake. You need to rethink this concept. Endovascular treatment is one of the most powerful treatments in medicine, at least by the number need to treat you currently have. So you have to have a very strong reason not to treat these patients. You can harm patients actively or passively. Not offering a very powerful treatment, it's a way of harming patients. Let's think about how other fields in medicine think about the futility and costs. Have you ever seen anybody excluding a patient with a large ST elevation of mine, maybe in cardiogenic shock, because they have poor prognosis or the costs are high? Doesn't happen. Cardiologists will treat these patients aggressively despite almost 40% mortality in a cardiogenic shock. How about a sepsis, severe sepsis? Poor prognosis, treatment costs. You see emergency room physicians or critical care specialists with not offering aggressive treatment in the presence of sepsis. That doesn't happen. 40% mortality in septic shock, right? So why we think so differently in the face of a stroke? Trauma is another model, right? Where you treat first and you ask questions later because it's just a bad disease. So I think part of the problem has to do with this, like how the patients look. A stroke patient doesn't treat as much empathy, right? The other problem is cardiogenic shock, septic shock, large stroke. Maybe you should change the name to cerebral ischemic shock to see if you can change our behavior in relation to these conditions and treat them more aggressively, rapidly than what you were doing with all this over-selection and wasting time. Look at cancer, right, and futility and costs. Moreover, when you don't treat STEMI, sepsis, trauma, and cancer, people will die. When you don't treat a stroke, most of the time they don't die. They stay alive, but with a higher degree of disability. And because of these people stay alive, unlikely these people, they are actually consuming healthcare resources and being a burden to society. So if anything, from a financial standpoint, you should be more aggressive with stroke. Finally, we need to understand that not all the benefit of stroke treatment, reperfusion, can be explained by shrinking the size of the infarct. In fact, this analysis suggests that it only explains 12% of the functional outcome benefit. It seems that reperfusion of large strokes also seems to reduce cerebral edema. You see one paper here, another paper here, third paper suggesting that. How is that possible? Again, it's by rescuing how the other cell lines in the neurovascular unit, the astrocytes, the endothelial cells, the pericytes, they may be able to abort that cerebral edema, which confers yet another opportunity for a benefit. So I believe the future is you need to understand that time is brain and imaging takes time. Therefore, time is brain, image is time, imaging is brain. We need to start thinking like cardiologists. You shouldn't reinvent the wheel. An acute MI is not equal to a fast perfusion scan. Go straight to the angio suite and fast reperfusion. And the brain cells are even more vulnerable to ischemia than the heart cells. So you need to act as fast as the cardiologist, or potentially even faster. And you do have the EKG for the brain. That's called the NIH stroke scale equal greater than 10. In fact, the rates of false positive cath lab activation using this versus this is pretty similar as if you look here at these ranges. So I believe this will be the future. Within the first 6 hours, you're going to be bypassing the CT or MRI suite patients. You'll come straight to the angio suite. You're going to be acquiring simple imaging. What you need to do is that you have published on some of our initial findings with that. We just need to see there is an occlusion. Maybe you can look for degrees of collaterals. I think we're doing some pilot work here, but it's unnecessary, okay? We just need an occlusion in early time and treat everybody. And with that, you're going to save time. And I think you're going to have better outcomes. This has been reported by many other colleagues, direct to angio. And in particular, this work from Mark Riba in Barcelona shows very promising results with improvement in function outcomes at 90 days, as you can see here. There is now finally a trial for that. It's called We Trust, where you're going to, again, randomize patients for conventional imaging versus direct to the angio suite. And if they fulfill criteria for treatment, they're going to go into an intention to treat analysis for us to look at their function outcomes. So to conclude, current selection paradigms are too restrictive and time consuming. Be aware of ghost scores, false scores on both CT perfusion and the WR. Be aware of patient over-selection, okay, and the high time sensitivity, mostly in the early window. Imaging takes time, and in the early window, it only increases the chance of fertility. More time you waste, you are only increasing the chances of fertility. And you are trying to do image to look at 15% of patients when you are probably hurting 85% of them. Doesn't make sense. The current technology allows us for the proper selection in the angiography suite, and you can behave like cardiologists and achieve STEMI goals. Very important. There are likely much more patients being harmed by no treatment than treatment in both the early and late treatment windows of reperfusion therapies. The final message is select faster, select less, and treat more. Thank you very much for your attention.
Bueno, impresionante, Raúl. Realmente, como siempre, aprendemos y aprendemos.
Raúl, amazing.
Impressive. We always learn from your talks. It's almost a philosophical talk. In principle, well, in the beginning, we didn't select so many people. We didn't treat as many either, but of course, the least we select and the faster we act, far the better. We see this during the discussion, and we are leaving a lot of material for the discussion. Actually, we have neurologists, interventional neurologists, and cardiologists. We are doing fine with time. I'd like to introduce somebody that has worked a lot in artificial intelligence, AI. Professor Gregory Alvarez, a vascular neurologist. He's a director of the Stanford Stroke Center. He's professor of neurology at Stanford University Medical School, California. He is an outstanding person. It's a pleasure to have him with us. More than a pleasure, it's a real honor. Somebody who has worked so much in this field that is now booming.
Thank you, Gregory, and welcome to SIMI 2020. Thank you for take some time to spend with us. I know you're always busy, so please share with us the artificial intelligence with in stroke. We are delighted to have you with us, and ready to listen to you. Thank you again. Welcome.
Thank you so much. It's really my pleasure to be here. Certainly wish I could be there in person. It's been since 1992 since I was able to visit Argentina. I'd love to come back when the world is in a slightly better place. But it is a pretty exciting time for artificial intelligence and stroke, and thank you for asking me to cover this topic, which, as you mentioned, is really exploding. This is a list of the AI stroke software that has been approved by the FDA, and this list is growing every few weeks. What you can see is that there's a huge number of approvals for hemorrhage detection software. There are 4 for detecting large vessel occlusion. There's 1 for automated aspects, and there's 1 for an automated thrombectomy indication. So AI software is clearly arrived. And what I'll point out is that the vast majority of these clearances are what are known as notification clearances. And that's very important to understand that this software at this point is not making a definitive diagnosis. It's basically saying, hey, take a look at this scan. I think there's a brain hemorrhage. Or, hey, take a look. I think there is an occluded large vessel. So it requires the combination of the software and the human for the most definitive diagnosis. What we've seen in a number of studies is that this software can improve the performance of the human, but it cannot replace the human. And that's why these notification clearances are very clear. They are not making a diagnosis. They are bringing your attention to these scans, but they can prevent you from making errors. So if we talk about the one that has the most clearances, such as the brain hemorrhage detector, you can imagine if you're about ready to give a thrombolytic to a patient, you've looked at the scan and you don't see a hemorrhage, but all of a sudden you get a notification that says, hey, the software sees a hemorrhage. You may take a look and say, hey, I missed something that is really going to help me decide that I shouldn't treat this patient. Also, many places, the scans in the ER are not being looked at immediately. There's a long list for the radiologist. So this is a flag that, again, says, hey, I'm going to move to the top of the list because there may be a brain hemorrhage here. And here's just some typical examples where you can see that intraparenchymal, subdural, subarachnoids, and intraventricular hemorrhages can be identified by the software. The sensitivity and specificity is in the range of 95%, which is quite good for these softwares. But what that means is that there is going to be 5% of the time where a brain hemorrhage is missed. So you can't take an absence of brain hemorrhage as definitive. And there's going to be about 5% of the time where the software alerts you, hey, I think there's a hemorrhage, but you take a look and then you say, nope, that's a false positive. The software got fooled because the software, still can make mistakes. I think it's going to be that way for many years to come. So it's a combination of the human and the software that gives you the best performance. These brain hemorrhage softwares can also measure the volume of these intraparenchymal and intraventricular hemorrhages, which can allow you to get automatic stability information and help you decide if somebody is eligible for a clinical trial, or if you're using a prognosis algorithm that depends on hemorrhage. This is a much quicker and easier way to get the hemorrhage volume than measuring it out yourself. Okay, let's move on to LVO software. This is large vessel occlusion software. There are 4 that are FDA approved. This is the example of the rapid one, which has the highest sensitivity and specificity, 97% and 96%. Again, meaning it's very good, but not perfect. It's going to miss a few, and it's going to false positive notify you sometimes. So it's, again, going to be up to the physician to take a close look. So what the software does is it provides these MIP images, and then there's a vessel tracker that looks for an occlusion. And you can see if you're suspecting an LVO, you get an output that looks like this, which makes it very easy to identify where the large vessel occlusion is. In addition to this, what you can get is blood vessel density assessment, which can allow you to find more distal occlusions. So on the left, where you have a proximal MCA occlusion or mid-MCA occlusion, you have a severe reduction in vessel density, giving you the red mask. And then as you move progressively to the right, you have less severe reductions. So you can pick up high-grade stenosis from intracranial athero or more distal occlusions. Even if you're not in the LVO category, you can still pick this up from the software, which can be quite helpful. And these are softwares that will give you the answer in less than 2 minutes. Next, we have Automated Aspects. This is the only software in the US that has what's called a CAD approval, which rather than just notifying you, it is a computer-assisted diagnosis. But it still doesn't mean that it is the computer making the diagnosis alone. What we found as we did the studies that led to the FDA approval was that the performance is best when you combine the software and a physician. And basically with this software, you can take a typical neurologist or a general radiologist and get them to read aspect scores in the same accuracy that we see from a neuroradiologist. The software places the 10 aspects regions on the brain, and then it identifies the regions that are abnormal. Can be particularly helpful when you're at the border zone of the indication for thrombectomy. Obviously, in the 6-hour window, most guidelines still recommend an aspects 6 or more. There are some reasons why you might want to treat patients with aspects less than 6, and Raul mentioned some of those earlier. But here's an example of one where the software is helping you to identify those regions and identifying this patient as eligible for early window thrombectomy. There's a study from Munich showing that this could perform better than even interventional neuroradiologists, and then one from the GAME study published in Stroke, where we were able to show that the software was particularly good for picking up these very low aspect scores and outperformed typical clinical readers. Also, out of a plain CT, you can often get a hyperdense MCA identified by an automated software, and this can tell you if there's a high suspicion of an LVO. And what we've seen recently from this software is that about 60% of LVOs can actually be detected on a non-contrast CT. So if you're screening a large number of patients just with a plain CT, this can immediately identify, hey, this is somebody who really needs a CTA. Even if you weren't clinically highly suspicious of an LVO, we've identified that hyperdense vessel, and this patient again needs to move to the top of the list of attention because they may have a treatable large vessel occlusion. I'm going to focus most of my talk on the role of CT perfusion, because I think this has been a huge advance that's allowed us to now have a transparent time window and particularly attack these late window patients who have, during most of our careers, been patients who were told they cannot be treated. You came in too late, and now we know that's not true. We can identify if there's salvageable tissue in patients at virtually any time they come in. So the real major advance here, of course, was the Diffuse 3 and Dawn trial, where the vast majority of patients were selected by CT perfusion. And this allowed us to get away from this very depressing slope that we've seen over and over and over again in our stroke trials. And that is the treatment effect modification by time. Right? So if you look on the y-axis, this can be either the good outcome rate or the treatment effect. And what you see is over time, this is dwindling to 0. This is data from the Mr. Clean trial. Now, if you go over to the Aurora cohort, which here was the Dawn and Diffuse data that was pooled together, what you can see is that when you use the imaging-based selection, you can get away from this depressing slope. Here you see in black the good outcomes in the thrombectomy candidates. You can see how they're stable over time. And then the good outcomes in the control group, interestingly, are actually declining over time. Somebody who comes in late in the window with an MCA occlusion and really no opportunity for spontaneous recanalization with clinical benefit does very poorly. So the treatment effect is the difference between the black and the red lines. And when you look at the treatment effect in these studies that have used CT perfusion to select patients, what you can see is the treatment effect is not modified by time. And there is no reason to think that 24 hours is the outer limit. In fact, recent data from South Korea, as well as from the Diffuse group, has suggested that we can go well beyond 24 hours and still find patients with salvageable tissue. So that's pretty exciting. So infarct growth rate is highly variable. That was one of the key findings that led us to be able to prove late window benefit. And what was really surprising, and this came out of the Diffuse 2 data, was that 50% of patients have such good collaterals that they are maintaining a small core for 12 to 15 or more hours after symptom onset. So it's not a minority of patients, it's a high percentage of patients. And also surprising was only 20% of patients have this very malignant growth, such that not only do minutes matter for these patients, but actually seconds matter. So that these are the patients where they are completing their infarct at a very quick pace. And I think that most of us could probably agree that if you've got a completed infarct, there is no penumbral tissue, there does not make a lot of sense to reperfuse that patient. Reperfusing a large swath of dead brain is not going to do you any favors. So the key is to be able to get this imaging done very, very quickly. And nowadays, by incorporating CT perfusion into a stroke CT, it can add 2 to 5 minutes, which is really amazing. And if you do it before the CTA, you can have this information at the time the patient is getting off the scanner. So absolutely, as Raul said, you can't waste time on imaging, but the good news is now we can get this quality of imaging without wasting time. And really, this is the explanation for the difference in those good outcome rates that we're seeing in the slide that Raul just showed you. Not only for IV TPA are these patients in the green zone doing so well, but the IV TPA plus the thrombectomy, they do terrific. So if you look at the overlay of the criteria for these various thrombectomy trials, you can see trials that did not do any imaging. Basically, we're including that 20% of patients with a completed infarct. These patients do not benefit from reperfusion, and they dilute the treatment effect. That's why when you look at Extend IA or Swift Prime, you get a much more robust treatment effect. And Diffuse 3 and DAWN, by capturing the 50% of patients with favorable collaterals, also had a very robust treatment effect, in fact, larger than the treatment effect seen in many of the early window trials. This concept does not only hold for thrombectomy, the recent data shows that this concept holds very true for IV thrombolysis. This is an example of where we have been hitting our head for 2 decades against this curve. This is the curve of treatment benefit for IV thrombolysis over time. It's fading away as you get beyond 4.5 to 5 hours. But if you use imaging-based selection with CT perfusion, you can break that curve and show benefit all the way out to 9 hours. So this is a trial from the Extend, which Raul also mentioned, showing that we can successfully treat patients out to 9 hours. But the more important data is from this Lancet paper that Bruce Campbell published right after Extend, where he combined the data from ECAS-4 and the EPITHET trial, which were all trials that had perfusion imaging and treated patients with IV thrombolysis between 4.5 and 9 hours. When you pool the patients, you see an even more robust benefit to patients who have a mismatch on CT perfusion. But the key finding is this part of the graph. These are the patients who did not have a mismatch. And most of these patients weren't ones with a big core. They were ones who had a completed infarct. And once you complete the infarct, then reperfusing the patient can lead to harm. Let's take a look. Here's the death rate, 17% on TPA, versus 4% on placebo. The rank and 5, 8% versus 4%. So when you mix a subgroup that's harmed with a subgroup that benefits, you dilute the treatment effect and you can wind up with a negative trial. And that's why it's taken so long to break the time barrier for IV TPA. Okay, CT perfusion has become very popular since Diffuse 3 and DAWN because it's part of the late window guidelines. So one of the things that we need to do is make sure that people understand how to interpret these images. So this is showing that the images can be automatically processed to see if thrombectomy may be indicated. This is an FDA clearance for thrombectomy indication based on the multiple trials, both early and late, that we're using CT perfusion for identifying patients. And in addition to the basic mismatch map, you have to dig deeper. And what you can see is that you can pick up the collateral information from the Tmax maps. Areas of severe delay in the arrival of the contrast have very poor collaterals. And those poor collaterals can be used to predict how quickly that infarct core is going to grow. This is a patient with great collaterals and very slow growth of the infarct core. Here's a patient with terrible collaterals and very rapid growth of the infarct core. And here's some of the data that demonstrates this. This is the diffuse 3 data, the better collaterals versus the poor collaterals, a substantial difference in infarct growth. And this is very practical data about transferring patients to your thrombectomy center. This is 3-hour transfer time. And what you can see is that if you have good collaterals, there is no growth over the next 3 hours, where if your collaterals are poor, there is substantial growth, and many of the patients may complete their infarct over those 3 hours. So it tells you whether or not you need to re-image some of those patients. One of the very important things about CT perfusion that's underappreciated is the image columns. These image columns give a tremendous amount of information. Particularly the mean transit time maps can, for example, tell you if you have an acute versus a chronic occlusion. This is data that we presented and have now submitted for publication, showing that in an acute occlusion, your mean transit time is virtually always increased, where in a chronic occlusion, it is not. So here you can see, here's the normal and mean transit time in the chronic occlusion and the abnormal in the acute. So a lot of information there. And look at these. Here's an early window patient where they were treated with IV thrombolysis because they thought this was a patient having a stroke. But if you look at the CT perfusion, what you can see is this is not the pattern of a stroke. We have increased blood flow and increased blood volume in the symptomatic hemisphere. This is the pattern of a seizure. So you can avoid treating stroke mimics by having this additional information. The ghost core is a complicated topic, but it really comes down to what type of imaging did you do and what type of thresholds did you use. For what we did in SWIFT Prime, there was essentially no ghost core. 2 patients out of SWIFT Prime had ghost core, 1 patient out of diffuse 3. So the key is to get the thresholds right, and we know if it's ultra early window, you need a stricter threshold. This threshold is identifying core as tissue that has more than an 80% reduction in cerebral blood flow. And this is a good way to avoid the ghost core. Finally, I'm going to finish up by commenting about this issue of why is it that sometimes you can't see the core on a CT perfusion. And the reason for that is that CT perfusion is not showing you dead brain. Plain CT or MRI is better for that. CT perfusion shows you the blood flow and volume at the moment you do the scan. And if that blood flow was low several hours ago, killed the tissue, and now is improved, then you're not going to see it. And there are many different reasons. And this is why education about how to read CT perfusion is particularly important, as we show that CT perfusion is very useful for treating stroke patients. So this is the concept. Once you reperfuse, both the green and the pink images are going to disappear because the CBF and the Tmax have normalized. This is a dramatic example of somebody who had a big stroke yesterday, but there's spontaneous recanalization. So although one branch is still occluded, if we look at the map, we can see the CBF is bright in the involved hemisphere. That's the opposite of what we would see. Normally we see dark, low CBF in the involved hemisphere, but here shows you that this is subacute infarct, vasodilated vessels, and this is futile reperfusion, right? This is reperfusion of tissue that is already dead, right? So we see the high CBV, the high CBF, and we can understand why we didn't see pink on the mismatch map. It's because the CBF is no longer low. We've got vasodilated vessels that have lost autoregulation. So how can we help people with that? This is a new feature to the Rapid software, which identifies the hypodensity on the mismatch map. So a subacute infarct will show up in blue. The pink shows you the typical tissue with very low cerebral blood flow, and it's the combination of the blue and the pink that is going to represent the irreversibly injured tissue. So this will help you, but the basic idea is that you always need to look at that non-contrast CT, and here more subtle abnormalities can be highlighted to you with the blue overlay. So I'm going to finish up at this point and just mention that AI stroke software clearly has arrived. So you need to understand the limitations and the benefits of this software. We're going to be living with this software for the rest of our career. It's going to get better and better, but it was not designed to replace the human. It is designed to help the physician make the best possible diagnosis as quickly as possible and get patients treated as fast as we can, because obviously we want to treat patients as soon as we can, but we don't want to use time as a reason not to treat. Now that we have a transparent time window, we want to time every brain, see who's got salvageable tissue, make the correct diagnosis, and help as many patients as possible. Thank you very much.
Well, thank you very much, you, Greg. That was a great presentation. You know, one beautiful thing about the stroke, always there is something new. So we learn, every step we are learning. Thank you very much. Please stay with us, as well as David, Raul, and Mayank. Probably we will have a fantastic discussion. We have a bright neurologist with vascular neurologists with us, people from the stroke domain, interventional neurologists. So stay with us. Bueno, fantástico, ¿no? ¿Qué les pareció?
Amazing, great. What did you all think? Wow. The good thing about AI and the software for stroke is that there's new things all the time, all the time. However, as Greg reinforced the concept, we're not going to be replaced as physicians. We'll always be needed. We can stay calm about that, I think. And also the interventionist neurologists. We have such a huge amount of information. Perhaps we can revert philosophically that nihilistic point of view, that stroke that had this tissue that was dead was in a condemned position. This is changing. Society is demanding that this should change. So let's head for our discussion. We're going to present some cases for the discussion, as we did before. Because we have David with us, and the first topic was collaterals, I would like the co-chair, Dr. Escribano, to present a case that, well, it wasn't yesterday, this case. Maybe this would be a case that would be treated today. This is a young patient. A lot of hours had gone by. Left hemisphere, aphasia, hemiparesis. So, Dr. Escribano, if you would please go ahead with the case. Thank you.
Ok, gracias. Sí, lo interesante de este caso es
The interesting thing about this stroke was that it was 10 years ago. Of course, we did not have all the materials or the experience that we have today in endovascular treatments. So this was a patient who was young. He's 16 years of age. 24 hours had gone by since the beginning of the symptoms, and all the left hemisphere showed alteration of perfusion on the CT. And the angio-MRI showed lack of flow already in the left carotid at this level, specifically at the supraclinoid level, where there was a stop, the left carotid, spontaneous passage, and all of this area here of lack of perfusion. Spontaneous passage was through the anterior communicating artery. Very few symptoms, therefore, in this patient. This was because of the collaterals, obviously. As I said before, at this time, we did not have a lot of tools available to offer this patient. Therefore, what we did have, a system that was called NeuroFlow. We had that at that time, which was for vasospasm originally, but was later also approved for stroke as well. This would therefore be pre at this level, which is where there was the biggest lack of image in the different arterial phases and late parenchymal phases. There was an absence of collaterals in this area. Here, specifically, and it can be seen even better here, the deficit was greater, and there was then an opening of collaterals.
Esto sería la tomografía con perfusión.
This is the perfusion CT after treatment, and the MRI 48 hours later. The patient had had aphasia and hemiparesis on the right side. On the flare sequence, we can see the residual lesions, but the NIH had gone down. End. Oh, do you have 6 years follow-up? We have. Do you have any other images? There were practically no lesions on the MRI at 6 years follow-up. At this level, here there were lesions here and here, 48 hours after the intervention. Patient obviously continued with the distal occlusion. However, there were no problems at this level with the collaterals. That progressed as a result of the neuronal plasticity that he had. Well, he was a very young patient.
Well, I'm not sure if you have the translation, Professor Albers, David. Have you heard the case?
Yes, we did. I tried to listen at first in Spanish, and that was a real test of my language abilities, but much better in English. Yeah, no, that's a fascinating case of neuroflow. Pedro, your group and others were large champions of the neuroflow device, and we've talked about this on many occasions. But an interesting tool because it intrigued many of us because partial aortic occlusion, a remote endovascular approach, was able to change blood flow in the brain. Now, as much as it intrigued us, it also disturbed some of us that wanted to go up and treat the distal, the actual arterial lesion. The improvement in flow is something that mechanistically we debated, as you know, Pedro, for a long time. And rather than describing it as popping open collaterals, arterial collaterals, the soundest and the most logical argument is the elevation in blood volume. And that elevation in blood volume can facilitate flow in that region. So mechanistically, there's a lot more on the venous side that's important than on the arterial side. That being said, this is a dramatic case. My only question back would be, are you still using neuroflow? Do you still have it? Because it was limited, obviously, here. Most things ended after the Centis trial was done.
Well, as you know, we had some, but we are out now. I tried to convince many companies to start again with that product. We are having some, but unfortunately, we don't have more devices. Going to the Centis trial, I would like to know your opinion, both of you. What do you think that failed? What happened? I know you wrote some papers about David, but I think maybe we did some mistake.
No, I don't think there's any mistake. I mean, I think that Centis was the largest stroke trial, interventional stroke trial done at the time, randomized control trial. It was very successfully done, but this gets into the contentious point of this debate or topic, which is how was imaging used and how was the imaging ascertained. And I'll be the first to say that we've looked at the imaging post hoc in many different ways, and it still exists, but it wasn't done standardly. In a rigorous fashion. It was much more, it was somewhat done on an anecdotal basis, showing a series of cases one after the next. And I would actually argue that a systematic imaging evaluation, if it were possible to do Centis again with Greg's imaging or Greg's favorite imaging, you would be able to make a lot more conclusions done today.
I mean, I think that's true for so many of our failed trials. As the Extend IV trial showed you, you can try and try and try without the right imaging and you fail until you identify patients with salvageable tissue. The case that you showed clearly had a full hemisphere of salvageable tissue and did great. But it also brings up the point that even with how excited we are about our current tools, we're still only seeing good outcomes in 50% of the patients or 60% of the patients, which means there's a lot more for us to do, that we need to be able to preserve penumbra on the way in. We need to use the neuroprotective agents in that capacity or neuroprotective strategies so that when you get to the cath lab and get that clot out, you have salvageable tissue to reperfuse. In your case, you had somebody with good collaterals and you were able to help them. But that's how you get a trial done with a couple hundred patients rather than 1,000 patients. You get the right patients, and then afterwards, you can expand and try to push the frontiers, which is exactly what's happening now with thrombectomy. We fully believe that patients beyond who we enrolled in Diffuse 3 can benefit, and now the challenge is to figure out who they are and how best to identify them.
All right, okay. Thank you, both of you. Any comment, Professor Vila?
Sí. Hace muchos años,
Many years ago, the head of neurology at Mass General, the professor showed a patient. He always showed the patient that had all 4 vessels. He had 4 vessels occluded. He was an Amtrak driver, and yet he had perfusion in the whole brain. So what this did was it taught us that any patients that we see with perfusion defects is because there is a brain failure. Collaterals fail, but we don't see the ones who have good collaterals and who have perfect vascularization. We've seen specimens, vascular preparations in Switzerland. When they color one vessel, the whole brain is filled if the collaterals are healthy or good. So we're treating patients where there is already a failure in the collateral system or network, and that's why it's so hard to predict the course or the outcome. Dr. Nogueira's concept is opposed to others, that you have to treat everything under 6 hours, regardless of whether there's mismatch or not, if it's a large infarct, a small infarct. Those patients will do better. So I believe that the biomarker of brain blood flow is a huge contribution to knowledge and for the treatment of these patients. But we need another biomarker, not just flow. We know without flow, the tissue doesn't recover, but sometimes even with flow, it doesn't recover either. So you were thinking of another biomarker. Yes, we need a special biomarker that we might have available to evaluate the energy at the tissue level, either through oxygen or mitochondrial activity. I know that at Karolinska we had wanted to study this, but they weren't able to resolve the issue. But energy is what we need to measure, but core has not been well defined, in my opinion. There's other structures, such as the protein denaturalization, which is very early and is much more efficient as a marker than ischemia. We infer that a certain level of ischemia will cause protein denaturalization, but sometimes there's no concordance or agreement. So we have a big challenge ahead. We need to find another biomarker that might help us to understand what we can't see now. Did you hear the translation?
Yep.
Yes. Yeah, I think very good point that it would be wonderful to have a perfect marker of ischemic core, which we don't have. I think the best one that we have that's widely available is diffusion imaging, where you see cytotoxic edema because you have energy failure. And what we've seen is that there's really quite limited permanent reversal of a diffusion lesion. We see a lot of transient reversal. When you raise the blood flow, you can get a transient increase in apparent diffusion coefficient. But when you really look closely at patients who have follow-up imaging beyond that time of transient reversal, that basic DWI with a low ADC is a very nice marker of core. So we can always refine it, but we prefer MRI at Stanford. But for the real world who's out there, you know, in community hospitals across the globe, we have to translate it to CT perfusion. So I think the closest that we can get at the moment is to be using very carefully done perfusion imagings with the appropriate thresholds.
I agree. I mean, the only other comment I'd make is that we have to be practical. We have to choose whether we're going to be practical or not. Whether we want to understand the exquisite science of what's happening at the cellular level, or we want to be able to make prompt, very fast decisions. And this is different in different types of strokes. So obviously, when you have a large vessel occlusion, the best treatment in the majority of cases is going to be revascularization. So we want certain information out of the biomarkers, but as Raul argued, in certain scenarios, we don't want any biomarkers. We just want to be able to move forward and not waste any time. And I do agree with that. But I think there is a happy medium in between where, you know, as Greg was pointing out, that there's two dimensions. One is you can do the imaging quickly, and you're not relying on the imaging alone. On those markers alone, you're still there's still the element of bringing back the individual who's making those decisions.
One of the problems is we don't truly have the EKG for stroke yet. So if we had great biomarkers, and I know some are being developed from finger sticks that may be fantastic, that'd be really helpful. But we see plenty of stroke mimics. We see strokes that don't appear like a typical stroke, that you wouldn't be rushing that person off. But if you get the imaging and you see it's a stroke, then maybe you can treat them where they would have gone to the back of the line without the imaging. So I think that it is complicated, that our jobs are secure, that you need somebody with a detailed knowledge of vascular neurology to be assessing these patients so we can feed the right patients to somebody like Raul to do his procedure, but not send everybody to the cath lab. There's going to be so many false positives if you send everybody that you think has a stroke to the cath lab, and you're going to miss a bunch that have a stroke mimic or have a what we call a stroke chameleon, right? They don't really look like a stroke, but they are.
Okay, fascinating, guys, but we have to move on.
Okay, be practical.
Can we show you one case short, Selena?
Yes.
Just one. Okay. Give us a couple of seconds. We are very happy with Rapid. We just got it, and we are really, really happy with the communication, with the improvement of the software. So Selena is going to show you a case. Please, Selena.
Sí, pasamos de hace 10 años a...
Yes, from 10 years ago, now we are with all of the technology available to us. This is a 45-year-old female patient, hypertensive, smoker, who was taking valsartan as single treatment. She came to clinic at 9:25 a.m. and 20 hours and 25 minutes of clinical course. So she was beyond the therapeutic window for fibrinolytic therapy. NIH was 24 points. And during the COVID time, we changed the protocol. We used to do MRI, but now we started to doing CT, first chest and then brain. So this is a patient. Here we see we did the brain CT, which showed these images. This is the perfusion. And 137 milliliters was the ischemic core volume. Remember that the patient was 45 years of age. So, and less than 6 hours clinical course. So for any protocol, she would be excluded from treatment. This is the angio-CT. there seemed to be in the internal carotid an occlusion. So she had a focal neurological deficit, less than 6 hours, with a high NIH score and a high core ischemic volume. We decided to treat the patient, or at least to do an angio CT, which showed here slowing at this level, at the level of the carotid. So there appeared to be a plaque. Higher up, there was a thrombus, M1 proximal at this level. Therefore, we decided to do the thrombectomy. Mechanical thrombectomy was carried out. And the patient had a favorable outcome. During the study, in order to follow the protocol regarding the stroke mechanism, we do a simple chest CT first. And in the simple chest CT, 5 minutes post-angiogram, an MI of the anterior wall was visible, and we were able to confirm it with the cardiac angio-CT. This is on entry, the CT scan, and this is the control MRI. Patient had an NIH of 24 on entry, and after treatment, this decreased to 9. And patient left the hospital with a score of 3. The patient today has anomia, light aphasia only, but the rank is 1. The modified ranking score is 1 currently.
It's really remarkable how well a patient can do without one hemisphere of the brain. It certainly attests to the fact that young patients sometimes can recover much better than we think. And this is the point of ongoing trials. As I mentioned, we certainly believe, and we treat patients with cores bigger than 70 at Stanford as well, particularly younger patients. We like to look where the salvageable tissue is. Maybe you salvage some of the motor strip. I think that may be one of the key areas where there was mismatch. But the important thing that is happening is randomized trials. The SELECT trial is requiring CT perfusion. Somebody like this would be randomized, so we can see how much better they do with thrombectomy than control. And there's several low aspects trials that this patient would have been eligible for. So no question, patients like this can benefit. This patient did remarkably well with such a huge infarct. Very fortunate. Oftentimes we don't see that type of incredible clinical recovery. I don't think you salvaged any of the initial core, but again, some of the penumbra that was present looks like it had some critical tissue, and then probably the other hemisphere played a role in such an excellent recovery as well in this young patient.
Well, yeah, I would chime in and underscore the role of age. Being young is far better in terms of the recovery and outcome. The other comment is this is posing a great challenge now as we deal with COVID on a daily basis. The question about relatively younger patients that are coming in with these large, extensive thromboses. And we know that they have multi-organ complications. They're very sick. And the questions about do we treat or not have come up for thrombectomy. And a lot of debate about that because outcomes can be very poor. On the other hand, even the smallest potential of a good outcome in a young patient means a lot.
Well, thank you very much. That was just the introduction for the next topic, which will be COVID and stroke. So thank you for your help. I know how valuable is your time, so thank you again. Hope you see you next year in Buenos Aires.
Okay.
With the Malbec. Thank you very much. Gracias.
Congratulations. Bueno, great conference.
Excelente, Celina, muy bueno. Les pido que se quede y continuamos.
I ask you please to stay. We will continue because we're a little bit late. We have to start the next block. The next block is stroke and COVID. We have distinguished participants, Dr. Paul Bogard of the UK, who will illustrate us about stroke and COVID.
Paul Bogal is neuroradiólogo intervencionista del Royal London.
Is interventional neurologist in London.
Go ahead.
Hello, my name is Paul Bogal. I'm a consultant interventional neuroradiologist and a research lead over at the Royal London Hospital. I've been asked to give a short presentation on some of my thoughts around stroke and COVID-19 infection by Professor Lylyk and the team over in Buenos Aires. So I'd like to start by just talking about a few of the studies that have been published on the disease process, what we were seeing on both the arterial and venous sides. Then I'd like to talk about what I think is the underlying pathophysiology of what's occurring, and finally offer up a few suggestions on where we might focus our efforts on the disease. So, as everyone knows, this is a pandemic the likes of which no living person has seen before. Realistically, over 60 million cases so far worldwide, and over 1.5 million deaths. With no obvious let-up in sight. So just briefly, it's similar. The SARS coronavirus 2 is essentially similar to SARS and MERS. There is a spike protein on the coronavirus that facilitates entry via the ACE2 receptor into human cells with association from other transmembrane proteases. So I think when we're talking about stroke, it's important to recognize that the majority of the strokes that we are seeing are essentially thrombotic rather than hemorrhagic. But there's disease affecting both the arterial and the venous sides to the circulation. So there have been reports of significantly higher rates of stroke associated with COVID-19 relative to seasonal flu. In addition to this, you've got several case series of mechanical thrombectomy, et cetera, that demonstrate perhaps that the clots are a little bit more friable and easier to fragment. The pattern of the arterial strokes is different to what we would expect, often multiple emboli, multiple territories. And the severity of the stroke is worse than we would expect for the level of clot burden seen. So the Parisian group compared their results to the same time period in 2019, and they showed that the patients coming in with large vessel occlusions that were COVID positive were generally younger. They had larger infarct core volumes. They had more severe strokes with a lower clot burden, and as may be expected from what I've just said, higher levels of mortality. And other groups have essentially shown something very similar with bizarre clot locations and associated clots, such as subocclusive disease affecting the subclavian arteries in association with MCA occlusions, etc. Other things that have been seen is essentially, normal-looking arteries, but with large floating thrombi in the ICA, in the CCA, in the ECA. People were seeing thrombus within the heart. So just thrombus pretty much everywhere in bizarre places for what otherwise appeared to be healthy vessels. On the venous side, people have been reporting cerebral venous sinus thrombosis and cortical vein thrombosis in young patients with no obvious underlying cause or reason. And often these patients are coming in with associated hemorrhages because there's large degrees of sinus thrombosis seen. So what does this tell us so far? Well, we're seeing thrombosis on both the arterial and venous sides of the circulation, which means that both high and low shear stress states are involved. And it seems to be, although I haven't mentioned this, but several of the studies, as has generally been reported, demonstrate that there's a link between hypertension, diabetes, etc., etc. So how can we begin to try and explain this? So what I want to do now is go back to the basics of clot formation and start right at essentially the very beginning. So von Willebrand factor is a molecule that is essential to hemostasis, and it's produced and stored in the endothelial cells and megakaryocytes only. During its biosynthesis, it undergoes significant multimerization as well as post-translational processing, and it's packaged within what are called the Weibel Palade bodies. There are differences in the synthesis of the von Willebrand factor within the different vascular beds, with the lung and brain expressing higher levels compared to, for example, the similar sized vessels in the liver or kidney. The stored von Willebrand factor multimers are enriched into what's called ultra-large von Willebrand factor, which is very prothrombotic, and that's released upon stimulation of the endothelial cells and stimulation of the platelets. It's basically ultra-large von Willebrand factor. It consists of hundreds of single or small von Willebrand factor monomers joined together. And the biological function of von Willebrand factor depends largely on the size of its multimer. So the ultra-large von Willebrand factor multimers, the longest molecules are the most biologically active in inducing platelet aggregation. So that's the prothrombotic nature of it. Obviously, the body has control mechanisms to limit this, otherwise we would thrombose off all of our vessels very quickly. And the mechanism that controls that is a cleaving protease called ADAMTS13, and that basically cleaves von Willebrand factor at the A2 domain and chops up the large multimers into smaller, less biologically active multimers that are then excreted by the body. So when ultra-large von Willebrand factor is released, it's sort of curled up in a ball. Part of it will stay adhered to the endothelial cell, and then it will unfurl with the flow, basically, on both the arterial and the venous sides. And as it uncurls, as it unfolds due to the blood flow, the different binding sites, so the binding site for platelets and the cleavage site for ADAMTS13 are exposed, hence allowing, for example, the enzyme to come and chop up the molecule and make into smaller multimers, and also allowing platelets to bind. So these ultra-large von Willebrand factor molecules can also self-associate, so you can have one end-on-end or intertwined to form long strings or rope-like structures and even nets that allow platelets to bind and leukocytes to translocate. And this picture just demonstrates what I've just described. So you're seeing end-to-end attachment of the strings. You're seeing intertwined strings up in the top left. And then the scissors represent ADAMTS13 enzyme. And you can see the small circles on the von Willebrand factor string are representing the different A1, A2, and A3 domains for platelet binding and enzyme cleavage. And here's just a fluorescent labeled study showing in the top a very long string with fluorescent labeled platelets bound to it that's actually over 3 millimeters long under flow conditions. In B, you're seeing a similar platelet string, which then dissolves after infusion of ADAMTS13 over the surface of it. And here, again, just as I sort of aforementioned, the von Willebrand factor molecules can form rope-like structures or sort of a hammock or a spider's web type structure that is even more biologically active and can capture platelets better. Okay, the platelet binding site is called it's in the A1 domain, and it's called the GP1B receptor. As I mentioned earlier, this is normally hidden when the molecule is curled up in its globular form, but with shear stress, the molecule unfolds, the binding site is exposed, so platelets can bind via the GP1B receptor to von Willebrand factor. after binding, this switches the conformation of the GP2B3A receptor into its active conformation, which then means platelet binding can occur, further platelet activation can occur, and then you have essentially the whole cascade of platelet-rich plug forming. Okay, why have I mentioned this? Well, von Willebrand factor is a key component in both venous thrombosis as well as arterial thrombosis, and perhaps most importantly is it's very, very, very important for high shear stress states. Okay, so now turning our attention to what's called an endotheliopathy. So an endotheliopathy is inflammation of the endothelium. And this results from any cause, from trauma to sepsis to ARDS, and as I will show, secondary to COVID-19 infection. This results in the release of von Willebrand factor. And there's an excellent review recently published by Sean Gu et al. This picture on the left simply demonstrates that the epithelium of the airspace, the alveolar airspace, shares a common basement membrane with the endothelium of the lung capillaries. Therefore, any damage to the to one results in damage to the other. You can't have damage to one without damage to the other. Okay, so have we seen evidence of an endotheliopathy in COVID-19? Yes, we have. There is autopsy data to suggest a widespread endotheliopathy that affects virtually every vascular bed of the body. And in one of the studies, the authors reported most of the small vessels appeared congested. Okay, well, we've talked about von Willebrand factor release, how this is very prothrombotic, how platelets could form. So, how platelet plugs could form. So have we seen evidence of microthrombosis as well as the endotheliopathy in COVID? And the answer is, again, yes. So numerous studies have shown platelet-rich microthrombi in the lungs of patients with COVID-19, as well as elsewhere, actually. And in the recent study of Karsana et al., microthrombi were seen in vessels smaller than 1 millimeter in close to 90% of cases. Okay. Have we seen then evidence of deranged von Willebrand factor in patients with COVID-19? Again, the answer is emphatically yes. The first case that I'm aware of was by Escher et al., who was published a case report that showed the von Willebrand factor antigen levels were 500% of normal. So a huge, massive release of von Willebrand factor. The excellent case series published from the group in New York by Goshua again showed massive spikes in von Willebrand factor levels, and the von Willebrand factor level was associated with disease severity. So the higher your von Willebrand factor antigen level, the more severe your disease. In Europe, the French group published by Rauch et al. Looked at the prognosis and progression of patients with COVID-19 in relationship to their admission von Willebrand factor. And they showed that on admission to the emergency department and to hospital, you could predict which patients essentially were going to require more intensive oxygenation and more intense levels of medical management based on your von Willebrand factor levels, as well as associated things like factor VIII. In the small population that attended hospital that had normal levels of von Willebrand factor, those patients essentially did not require supplemental oxygen or any real medical management. In Manchester, Kieran South and his group published are in the process of publishing data that suggests there's a 6-fold increase in the levels of ultra-large von Willebrand factor for patients with COVID-19 compared to healthy controls. Okay, so we've shown a spike in the von Willebrand factor, we've shown microthrombosis, we've shown endotheliopathy. What about the regulatory components? What about ADAMTS13, the enzyme that breaks down the ultra-large von Willebrand factor? Okay, again, studies are now showing some mixed results, but certainly some patients have significantly dropped off levels of the cleaving protease. With Lylyk et al. From Brighton demonstrating a 50% reduction. And they said that they think that this is at least in part related to consumption of the enzyme because of the surge in the release of the von Willebrand factor. Very recently, a group out of Italy have published effectively saying that the von Willebrand factor to Adams 13 ratio is very strongly correlated to disease severity, which obviously makes sense given everything that I've said. And I think one of the perhaps most important things to recall or to remember is that this pathway, von Willebrand factor and Adams 13, this is important in disease pre-COVID-19. So if you have an abnormal ratio, a high von Willebrand factor to Adams 13 level, and you have large vessel ischemic stroke, you are more likely to have a poor outcome, irrespective of whether you have COVID-19 or not. So realistically, we need to be targeting our thinking, our efforts towards this axis. So how can we do this? On the right here, we have a flow diagram that's slightly adapted from one that I published several months ago. But essentially, it documents the steps that I have discussed. So where can we potentially intervene? We can stop platelets binding to the GP1B receptor on von Willebrand factor. There's a couple of drugs. Caplazizumab is produced by Sanofi and is in human use. And that inhibits binding of the platelets to von Willebrand factor. And Fibotide does the same thing. We could alternatively assist the body in breaking down von Willebrand factor. So we could give recombinant Adams 13 to patients, and we could base that on their von Willebrand factor Adams 13 ratios when they come into hospital. As I said earlier, the GP1B receptor binding results in activation of the GP2B3A receptor. Therefore, it makes more sense to give GP2B3A antagonists than, for example, aspirin to inhibit platelet-platelet interactions. Because of the nature of this talk and the amount of limited time, there are many things that I've not been able to discuss. Thromboinflammation, the associated effect that this pathway has on leukocytes. I haven't been able to discuss how von Willebrand factor response essentially is linked to your blood group, and this is why people with non-O blood groups, so type A, type B, blood groups are at increased risk, and this comes back down to the fact that your interaction with von Willebrand factor varies, and also that in longitudinal studies, your von Willebrand factor and Adams 13 ratio are associated with increased risk or decreased risk, dependent on which way your ratio swings of cardiovascular disease in general. These are just some of the papers which discuss some of those topics that I've mentioned. So I think there's lots to do. I think it's really imperative that we start looking at this problem in our patients. I think we need to start looking at the von Willebrand factor and Adams 13 ratio in patients coming in with strokes. I think we need to remove clots and send them for histopathological analysis, but we need to be looking for the amount of von Willebrand factor within those clots. Don't forget that these clots could, for example, form within the heart or elsewhere and still appear embolic. But this is the likely pathway by which these these clots are actually forming. I think partly we could maybe explain the worse outcome and the larger strokes we are seeing with relatively low clot burdens down to potentially a microthrombosis of the peel vessels. So are we getting a macro plus microthrombosis and loss of, or at least decrease in your potential peel collateral supply? I think we should strongly consider use of GP1B antagonists in these patients, as well as considering advanced antiplatelet medication. So should we be putting people on GP2B3A antagonists perhaps earlier than we would normally consider if someone has come in with a stroke? I'd just like to invite everyone watching to Brain Conference, which will be running next week. I'm the lead organizer. It's free to attend, and there are 28 CPD points available. Lots of great speakers from around the world, and I really hope that you can attend. And I'd like to thank Professor Lylyk and the fabulous Buenos Aires team for inviting me to speak. It's been a real whistle-stop presentation through some of my thinking around COVID-19 and strokes, and I hope you've enjoyed it. If you have any questions, please feel free to email me at the email address below. Thank you.
Well, thank you very much, Paul. I think you get around a very specific points on the relationship between stroke and COVID. I know you are very passionate about it, so we are looking forward to meet you in the BART meeting in December. I think you made really a good point. Also, it's a good point to consider the 2GB3A, I think, will play a role, specific role in the treatment of COVID and stroke. So thank you for pointing that. We are going to go back to this. But certainly to keep on the schedule, I think the next issue on COVID and stroke will be, well, guys, what happened in the early reports from the New York people, Mount Sinai people special, that emphasized that what important was the venous thrombosis. So I'd be delighted to focus that on venous thrombosis. Yo decía, muchachos,
I'm saying Bogal put a lot of focus on the microthrombosis and von Willebrand, as we heard, in relation to stroke. And I think he very early on was concentrating on this when the first Mount Sinai reports were coming out about the high incidence of thrombosis in young people, thrombectomies in young people, and venous thrombosis in young people. So at the same time, I heard an incredible talk by Alberto Garcia de la Fuente. He's from Monterrey in Mexico, and he gave a talk about venous thrombosis, deep venous thrombosis. So, Alberto, we would like to hear you now to give us your opinion, what you think of this, and to show us a little bit your talk. It's a very specific talk. Alberto works in the Centro Médico Muguerza. I'm talking about Alberto, but it's Dr. Garcia de la Fuente from Monterrey in Mexico. He is professor at the University in Monterrey at Mexico there, Mor de Leon. Thank you for being with us, Alberto. We are ready to listen to you. We have interventionists, neurologists, panel very interested in hearing you speak. Please go ahead. Good afternoon. It is an honor for me to be in this prestigious congress organized by Dr. Pedro Lylyk. I thank him very much for the kind invitation to this congress. I modified my talk a little bit with the circumstances and things that are occurring currently. We work mainly with vascular problems that we treat. The venous pathology is considered relatively uncommon. It causes, however, serious neurological alterations that can be potentially reversible, and with timely diagnosis, they can be completely resolved, and one can avoid the consequences that can sometimes be fatal. Imaging studies are essential for diagnosis and treatment. The most important symptoms, headache is very important. Many women use this. We have to pay a lot of attention to this in the current times of COVID, where COVID is causing so many cases of thrombosis that we are seeing. There's other neurological alterations that can occur, disturbances of consciousness, blurred vision, or seizures. The most common signs are papilledema. There can be a focal neurological deficit, also present, a cranial nerve palsy, ocular signs, and on imaging, the signs that we find more often are the delta sign or the empty triangle, but there are others, the cord sign, presence of medullary veins, or hyperintensity, hyperdensity, both in the transverse sinus as well as the internal jugular vein and in other veins of the body. Can be present in some cases. There can be cortical infarctions, unilateral or bilateral, and in 40% of cases there can be brain bleeding. Annual incidence in the U.S. is 2 to 7 cases per million inhabitants. This was underestimated. However, with more updated technology, more and more thrombosis in smaller and smaller vessels are being diagnosed currently. The accuracy and the timely diagnosis is crucial in order to rapidly give treatment and reverse the complications and sequelae. The causes of cerebral venous thrombosis can be local factors that alter the venous flow, caused by many things. Decrease because of the increase of the Pacchioni structures, trauma, mastoiditis, infections of some other sinuses, sphenoidal sinus, others, neoplastic invasion, compression, and systemic factors, changes of the coagulation proteins. But what increases 6 times in women the risk of thrombosis is the peripartum period, use of contraceptives, or the use of hormone replacement. There are many, many causes, and we have recently added COVID as well as an important cause for venous thrombosis in the whole body. Imaging methods that we use are CT, a simple or with contrast, and the venous angiography, which can be done with MRI or CT, and then several sequences for MRI and digital subtractant angiography if we decide to do some intervention. The most common site of the thrombosis in all the patients is the superior longitudinal sinus, followed by the transverse sinus, although this deep vessel system can also be affected. And this is very important for treatment. We see changes in imagings that can be different to cytotoxic edema, vasogenic edema, or bleeding, intracranial bleeding. What do we find? For example, on the CT, hyperdensity of the transverse sinus, and in the coronal image here, the superior sinus has denus, the Galen vein too, the basal vein here, hyperdensity of the Galen vein. There can be edema and edema surrounding, and here it's bilateral. This is somewhat later. Sometimes here we don't resolve all the sequelae, although use of thrombolytics is not contraindicated at the local level in these cases. MRI, different intensities depending on the metabolism of hemoglobin. What we find most often is a subacute phase from 6 to 15 days, and here we see hyperintense images on T1 and on T2. Let's show some cases. Venous thrombosis, such as this one. Here, this is a contrast MRI. Here, the image, we see that there's no filling here, but there is filling of the transverse sinus. On T2, it's hypointense. signal. This is an acute thrombus, and areas that can show bleeding, such as these, as it was in this case. Diffusion images show alterations too, and flare on T2 here. Bilateral images that show us hyperintensity. Spectroscopy with discrete increase of lactate here, as shown on the image, when we have here thrombosis of the superior longitudinal sinus. Hyperintensity here in several images, other images here with negative filling of the sinus, and other examples. Sometimes we can also see changes throughout the superior longitudinal sinus axis and the deep system too, and on the angioresonance, important increase in collateral circulation, a common pattern in these patients. All of this ultimately alters the metabolic patterns of the brain. We decrease the outflow of the venous pathways, and we affect the CSF too, as well as the lymphatics of the brain. Metabolic changes at this level which have effects triggered on occasion by hypertrophy of the pachyone villi, which further decrease the flow in the sinus, make it slower, leading to thrombosis. In adults, talking about the brain cerebral system, the venous system, all of the veins draining, both from the periventricular area as well as the cisternal area, go on one hand to the internal cerebral vein, and the cisternal one to the Rosenthal basal vein. I'm going to show now some cases. For example, this is a case of a woman, a patient who had started with changes of memory, forgetfulness during certain periods. But what was surprising was that the patient continually had headache. And there are areas of hyperintensity here, particularly in the drain of the deep venous system. And what we saw here was that the deep venous system was draining basically to the left transverse sinus, and we saw this filling defect which was on the left transverse sinus. The coronal image shows it too, and on this axial image also we see this, an image here which we believed was affecting the draining of the deep venous system and therefore the cause of all the symptoms. And MRI shows that transverse sinus drain on the left side here was thinner. And in this patient, all we did was give anticoagulation treatment, PO, linked to some antiplatelet treatment. And this was enough to remove the headache and to improve also the patient's memory. We do not have a neuropsychological evaluation, just a pure clinical workup. However, but in future cases, we will have to evaluate these patients better to see how they respond to anticoagulation. Another case, another patient with confusion, loss of attention, later vertigo, later somnolence, stupor, and when we did the images, we find here on diffusion some areas of restriction of diffusion in different parts, particularly areas corresponding to the venous drain of the deep venous segment, particularly periventricular here on flare, and higher up as well, acute restriction to diffusion. Angio MRI was normal, the arterial phase was normal. However, here, the deep venous system that was draining to the left transverse sinus showed an area of stenosis in the outflow, particularly in the rectal sinus, Patient only received anticoagulation, only medical treatment, and this was enough to see an improvement. I would like to present another case. This is a patient who begins with headache, vertigo, 2 days before, develops hemiparesis, loss of consciousness, and is finally intubated. On diffusion, there's some restriction at this level, particularly on the left thalamus. Discrete diffusion restriction here in the basal ganglia as well, around the ventricles. But on flare, here we see changes in intensity, particularly in the terrain corresponding to the deep venous system. Here at the level of the vein of Galen, and further up, more hyperintensity at the periventricular level as a result of the ischemia because of the involvement of the deep venous system. Once again, the coronal image, same thing, changes in the intensity, and here iso-intensity in the straight sinus. And when we do the angiogram, it's gone. Most of the profound system, the vein of Galen, the straight sinus. So we introduce a catheter, first of the transverse sinus. We find some thrombi at this level. We go to the straight sinus and the vein of Galen, and we introduce thrombolytics, a bolus at this level. And we did some mechanical maneuvers, and we proceeded to try to repermealize or open up this. We obtained some flow, continuous pressure, and when we do the venous contrast study on the next day, we see how the whole of the straight sinus is patterned, as well as the transverse sinus are open. At this stage, we see some bleeding at the head of the caudate nucleus, ventricular bleeding as well. 7 days later, the MRI shows partial resolution of the bleeding. The patient slowly improved and became completely independent later, thanks to this early, or more or less early intervention, which was able to solve his problem. A condition that, if not, would have probably led to the patient's demise. Another case here, 3 hours earlier, patient had started after strong sneezing with headache, nausea, vomiting, ataxia, and dysphagia. On diffusion, we see restriction of diffusion in the posterolateral area of the medulla. We thought it was arterial. It could have been the posterior inferior cerebellar artery. The pica was affected, but it was normal when we did the angiogram. And so here in the transverse sinus, there was something that surprised us. So I'm going to show you the angiogram. There's a stasis at this level. Here, stasis. Images that we thought perhaps were thrombi at this level. So in the venous segment, we began to carry out a maneuver with thrombolytics. We installed a bolus of medication and, of course, as well, mechanical maneuvers. The symptomatology immediately improved, and we left the infusion in place 24 hours. We came back later. There was still no flow of the jugular vein, but we did an angioplasty of the jugular vein, and we were able finally to restore flow entirely, and patient was asymptomatic. And this is another case, very interesting. A young girl, 15 years of age, who had for 2 days had paraparesis, and we found nothing of importance. We didn't really know why. The paraparesis, which was almost a paralysis in the anterior spinal artery, we did an angiogram. It was completely normal, but there was stasis in the artery and delay in the flow of the anterior spinal vein. So when we did the angiogram here, we found some slowing of the flow in the anterior spinal artery and stasis also during the venous phase. lasting more than 17 seconds. Another sequence here where you can see the venous phase. After thrombolytics, at this level, 15 milligrams. Lylyk was sufficient in order for the patient to have complete recovery and reestablish circulation with filling of the anterior spinal vein in 7 seconds. Another female, 40 years of age, papilledema and seizure crisis. What did we find? We found this edema, some hemorrhage too in the right parietal lobe. The angio-MRI, lack of filling in the superior longitudinal sinus, some increase in the collateral venous networks, part of the transverse sinus. The delta sign in the superior longitudinal sinus was present, and this filling defect in the jugular vein on the right. When we went up to the sinus, we found all these thrombi, also here in the longitudinal sinus, and we came to the distal segment, thrombolysis, aspiration, mechanical maneuvers, and we left in a continuous infusion, which was able to open up most of the venous system. This is an image 1 year later. Look, we see hemosiderin, and a pretty good image corresponding to the brain cortex. The patient has very healthy, and this is the contrast study, and everything is open, even the contralateral jugular vein. Another male, 48 of age, same symptoms, very similar. Here with diffuse thrombosis of all of the brain venous system. Once again, we did a bolus infusion, continuous infusion from the rostral aspect of the superior longitudinal sinus, and finally in the control image it was patterned and it resolved the problem entirely. And finally another case, a male 75 years of age who presented severe vertigo, tinnitus and confusion. On the right side there was some collateral circulation to the left jugular vein, and here the left brachiocephalic trunk was completely blocked. There was no filling of the jugular vein. So what we did was we carried out maneuvers with aspiration. We used a device of angioaspiration, and we were able to open up the vessel. Aspirex was used in this case, and flow was restored in the jugular vein. And these are the control images with better flow throughout the posterior fossa venous system as well as in the jugular vein. So ultimately, central venous thrombosis is a multifactorial entity which may, of course, be life-threatening, and it presents many clinical signs and symptoms, and the main causes vary. They vary from the developing countries and the developed countries. The best diagnosis is obtained with good diagnosis and rapid intervention. Thank you. Thank you, Alberto. Thank you very much. Really, we know the problem. We don't have the fantastic examples that you showed us. We were talking here with a neurologist. What happens if this is underdiagnosed, the venous thrombosis in our country? Juan, what do you think?
When it is underdiagnosed, it's difficult. Sometimes patients come back with headaches until they develop all the symptoms. But it's difficult to believe that so much time has passed without being diagnosed. But the incidence, as he showed, is very low, less than 10 cases per million inhabitants. I mean, recently we presented from the Neurological Society a registry of several centers of the country, and we were more or less with the same incidence rate. It is difficult, and many of these patients do not reach us. or they reach us because they are referred. But yes, once in a while you see them. Alberto, in times of COVID, have you seen an increase in the number of cerebral venous thrombosis? Is that your experience as well? Yes, absolutely. Seen that quite frequently. But we've seen an entity that maybe we have not taken into account enough. That is vertigo. Vertigo. We have worked a lot with ENTs and neurologists. Particularly, we started with ENTs because they see patients. It's a game between neurologists and them, patients with headaches and vertigo that bounce from one doctor to the next. And very frequently, we have found stenosis, particularly in the transverse sinuses. Most of these patients, when they receive anticoagulation treatment, have a significant improvement. And this we have confirmed, although we haven't done statistical study of this, but with the fact of giving anticoagulant, and if we remove anti-vertigo and anti-pain medication, we see it. And in patients who do not respond to medical treatment, we've decided to do endovascular treatment, and they also improve immediately. So I think that on that side, yes, we are underdiagnosing venous thrombosis that may be accelerated by other pathologies, but particularly, well, now, as Doctor said, yes, we have seen a higher incidence of thrombotic effects associated to COVID, no doubt. Thanks, Alberto. Speaking of underdiagnosis, maybe one of the things that is related to venous diseases that have been underdiagnosed, particularly venous hypertension that is idiopathic, small ventricles. Don't you think that that also happens? Fortunately, there are people of the Mayo Clinic with us. We have Dr. Lylyk, who is Associate Professor of Radiology and consultant. And I'm sure it's cold in Rochester now, isn't it? But he's already with us, I believe. So he's going to discuss venous hypertension in venous cases.
Hello, my name is and today I'll be talking about stent therapy for idiopathic intracranial hypertension, highlighting our multidisciplinary approach for treatment of this disease at the Mayo Clinic. Here are my financial disclosures. So first, just a little brief overview of the epidemiology and natural history of IIH. So the predominant risk factors for idiopathic intracranial hypertension include female gender, obesity, and being of childbearing age. So the typical patient of idiopathic intracranial hypertension is a woman that's obese between the ages of 20 and 45 years old. And basically, you know, there's about a 4 to 5-fold increase in the prevalence of IIH among obese patients when compared to patients with a normal BMI. Regarding the natural history of this disease, it's important to point out that we're not just treating headache here. Patients with IIH have about a 20% incidence of significant permanent vision loss. The patients do have headache though, and essentially, you know, with the severe nature of their headaches, they are known to have a poorer quality of life as reported by a number of studies. Regarding diagnostic criteria, there's a few different criteria out there. The classic criteria for diagnosis of this disease are the modified Dandy criteria, which include symptoms and signs attributable only to elevated intracranial hypertension or papilledema, elevated ICP greater than 25 cm of water, normal CSF composition, and no evidence of hydrocephalus, mass, structure, or vascular lesion on cross-sectional imaging. More recently, we've been using the criteria put forth by Friedman et al. In Neurology in 2013. I think it's an excellent article and very good criteria that account for, you know, our more modern approach with MRI. But essentially, if you have papilledema and normal neurological exam, normal brain parenchyma on MRI, normal CSF, and an opening pressure above 250 millimeters of H2O, then you have definite IIH. Now, you can have IIH without papilledema. if you don't have papilledema, then you just need to have greater than or equal to 3 of these 4 imaging findings: empty cella, flattening of the posterior aspect of the globe, optic nerve sheath dilatation, or transverse venous sinus stenosis, which is found in basically all IIH patients. So here are just some of the imaging findings. Here we see our classic empty cella, where you just basically see the flattening of the pituitary gland. Here we see the bilateral transverse sinus stenoses. Here is a normal person for reference. Here we see, temporal occipital lobe herniation into the groove of the transverse sinus, and you can actually make out the temporal occipital lobes that are compressing the sinus here on this venogram. And actually, this is an important point to something very important to point out, is that actually what's causing the venous sinus stenosis in these IIH patients is not any type of thrombosis or disease within the wall of the sinus itself. Oftentimes, and you can see this on MRI, it's essentially the brain becoming too boggy because of retention of CSF and interstitial fluid, and the brain is basically compressing and herniating into the groove of the transverse sinus and compressing the sinus, causing the stenosis. And you can actually see that here because you can see the undulations of the gyri and the sulci, compressing the sinus here. Here we see the dilated optic nerve sheaths as well as flattening of the posterior aspects of the globe. Now, a vast majority of IIH patients are managed without stenting, with medical therapy and weight loss. This is something I want to make sure that everyone's clear on. About 90% of patients respond to medical therapy alone. So this treatment that we can offer, it's for those patients that cannot tolerate medical therapy or do not respond to medical therapy. So typically when you see a patient with IIH, you review their medications, make sure that there's not any particular medication that's known to cause symptoms of IIH. Then you screen for comorbid conditions, obstructive sleep apnea, PCOS. These are associated with IIH. Then, what we always do is encourage weight loss. Typically, just a 5 to 10% reduction in the patient's weight can actually get rid of the disease of IIH. If this is unsuccessful, and this is the most effective but hardest treatment is weight loss, then we use medications to lower CSF pressure, whether that's acetazolamide, Diamox, Topamax, in some extreme cases, furosemide. And then historically, patients with IIH would then go on to receive surgery, either VP shunt or optic nerve sheath fenestration. The efficacy of acetazolamide was established in this trial called the IIH treatment trial. They basically gave patients 500 milligram BID and titrated it to about 4,000 milligrams a day. And patients were all treated with diets as well as personal weight loss coaches. And essentially, the use of acetazolamide significantly improved papilledema grade and also, improved, headaches and quality of life. Now, when do we offer surgery, including stenting for these patients? So this is offered in 3 main scenarios: either fulminant IIH with vision-threatening disease, an extended period of maximum medical therapy and weight loss with persistent disc edema, or severe papilledema and no headaches. There was one trial that looked at VP shunt versus optic nerve sheath fenestration versus medication, but this actually was stopped early due to poor enrollment. So now I'll talk about stenting. So unilateral or bilateral stenosis of the transverse and sigmoid sinuses is the radiological hallmark of IIH. It's seen in over 90% of these patients. And essentially, what we think is going on in these patients is, there's something that's causing them to retain more interstitial fluid, whether that's dysfunction in the lymphatic system, whether that's fluid retention related to, hyperaldosteronism or some sort of, androgen hormone that causes fluid retention. We don't know. But you have this increased ICP, and then the brain compresses the dural venous sinuses. The problem then is when the dural venous sinuses are compressed, they are under high pressure. There's going to be a pressure gradient. And then the arachnoid granulations in the transverse sinuses, which are resorbing CSF, which depend on that gradient, which depend on having a lower venous pressure, they're unable to resorb the CSF. So then the ICP goes up more, the venous stenosis increases, and you have worse CSF resorption. It becomes this vicious cycle. So when we decide that a patient is a candidate for stenting, we basically load them on aspirin and Plavix, 325 of aspirin, 75 milligrams of clopidogrel, and then we continue it for 3 months if a stent is placed. And the need for any type of surgery in the 3 months following stenting is a relative contraindication. The procedure is done under local anesthesia with IV sedation. The anesthesia team is present and they offer heavier sedation during stent placement, because sometimes when we actually place the stent, it can be very painful for the patient. Regarding our technical setup, we use ultrasound access transfemoral, 6 French ballast, no short sheath. We often use a 5 French Sophia for pressure measurements. And then we use an exchange length transcend or V18 wire. V18 wire is a very stiff 18 wire that is sometimes helpful for delivering the Zilver stent. And then we obtain pressure measurements from the left IJ through the torcula to the right IJ. Regarding the decision to stent, it's based off the presence of an angiographic stenosis. They need to have a gradient of 8 to 10 millimeters of mercury or more across the stenosis. And, you know, we used to use the wall stent, and I'll show you an example of a wall stent case. But since, you know, maybe this past summer, we switched to using the Zilver stent. And this Zilver stent that we use is the Zilver 518, which can actually be delivered through a Navian catheter, through a 6 French catheter, and goes over an 18 wire. And then we measure a post-stent gradient. So here's kind of just a classic case of IIH stenting, and this is back when we would use the carotid wall stent, and this is like at 4x. So, you know, we don't actually shove our wires that fast, but, you know, so basically we get our exchange wire as far as we can to the contralateral, you know, jugular vein, and if it's not possible, we don't do it. The worst thing that can happen is that you rupture a vein while doing this. So if it's not possible, we just focus on the dominant sinus. Then we get our catheter, and then we do a venogram on the contralateral side, and then essentially just measure pressures from the sigmoid sinus, the transverse sigmoid junction, from the transverse sinus, and then essentially work our way, you know, to the torcula to the contralateral sinus. And then if there is a significant gradient, then we go ahead and do the stent. For the wall stent, you do need a lot more support because it is harder to deliver. But you can see here we're advancing our ballast catheter past the point of stenosis. And then we just deliver the stent over the exchange length transcend wire and deploy it to treat the stenosis. So here you'll just see the standard stent delivery technique. And one thing to point out here is that these wall stents are about, you know, 36 millimeters long. So they, you know, there is some precision that's needed when deploying them. And we try to make the stent to be, you know, in the middle of the stent at the site of maximum stenosis. So there's that. Now, some cases are more difficult. You know, when you have an intrinsic stenosis, like in this case, you know, this patient actually had a history of prior dural venous sinus thrombosis, so they don't really meet IIH criteria, but they did have papilledema and, you know, all the other symptoms that are associated with IIH. And you can see here that we're trying to cross this lesion of the left transverse sinus, and it's actually just very, very difficult to even get through there with the wire, which is not typical of the stenoses that we see in patients with IIH. Here you see we're crossing it with the microcatheter. Now we're getting the Navian through to basically help us deliver the stent. And now we're getting our ballast through. And I'm sorry, this wasn't a Navian, this was a 5 French Sophia. And now we're trying to get this catheter all the way through past the stenosis, but it's actually very difficult because the stenosis was just so tight. And because of that, you know, we said, well, let's just try to deliver the stent. And, you know, we're advancing the stent, and this is the wall stent. And you can see here that it's just hitting the wall of the sinus, and we're basically having an extremely difficult time trying to get the stent to cross the point of stenosis. So then we just got a 6 French Navian across the lesion, which comes in very handy. And this is before we were using the Zilver stent. And then through the 6 French Navian, we were able to deliver a smaller wall stent, like a 6 by 22 wall stent, to treat this focal stenosis. Now what we would do is basically just deliver a silver stent through the navian if we can get the navian across the lesion. So I think the silver stent is actually huge. Using the silver stent has resulted in a huge improvement in our practice. And here, you can see the stent just being deployed and the stenosis being treated. And then here's a case where we use the silver stent, and this kind of just goes to show how nice this stent is for using for the treatment of venous sinus stenosis. But we have our Sophia. We're just advancing our V18 wire into the superior sagittal sinus. It's a very sturdy wire. And basically, we just have our ballast parked in the sigmoid sinus, and we're able to deliver this very large silver stent. I think this one was a 8 by 60 silver stent that's going to cover the whole transverse sinus in one swoop. And it's actually a very handy tool for treating these stenoses. So here you can see the deployment of the stent. And nice smooth deployment, and then the postoperative venogram showing the stenosis resolving. So having done a lot of these cases with the wall stent and recently switching to silver, I can't speak highly enough about that switch. So we discharge the patients home the day of the procedure. It's common to have localized pain at the site of the stent or ipsilateral headache for the first 2 to 3 weeks after placement. And this we typically treat with oxycodone. If patients have grade 2 papilledema or better, we stop the Diamox. But if they have grade 3 to 4 papilledema, we continue Diamox until there's documented improvement in the papilledema. And then we get a venogram at 3 months. And if there's no issues, we discontinue the clopidogrel and do aspirin for life thereafter. Overall, the results for IIH stenting are excellent. Papilledema improvement in over 90%, headache improvement in 80%, pulsatile tinnitus improves in 90%. Hemorrhage rate in recent meta-analyses is about 2%. We've had one out of our 78 cases so far. Recurrence retreatment rate is about 10% though. And I think that's going to be better when you start using longer stents, like those longer silver stents. These are just typical findings. Not typical findings, but things to look out for in the CTV. So here, this patient just has a little bit of thrombus on the wall of the stent, so we treated them with anticoagulation. This was incidental. Sometimes you can see extrinsic stent compression, and sometimes that needs to be treated with angioplasty or more stenting. A new contralateral stenosis can pop up, and in those cases, you should consider possible stenting of the contralateral sinus. And I guess that's it. This is kind of our treatment algorithm, and I'll leave this for you to look over on the video if this is of interest to you. Thank you very much. And if you have any questions, feel free to shoot me an email or send me a tweet or a message. I have a longer talk that goes into more depth about technical challenges and complications, and be happy to share that with anyone at any time. Thank you very much.
Well, thank you very much. That was excellent resolution for a important problem that we have. We were discussing that is underdiagnosed, at least I think in our country. I don't know the neurologist's opinion about that. We already spoke about that in the blog before, no? Yes. Any thoughts about that, Pepe or Juan o Celina? ¿Piensan ustedes que vieron digamos, la presentación?
Did you see the presentation, how excellent it was? Now, I have a feeling that there are many more cases. Recently, the ones we see are very late. They have papilledema, almost blind, many patients. Unfortunately, the inclusion criteria are clear, but the study, the algorithm, is also clear how to work up the patient. And you've seen the gradient, 8-10 centimeters of water. Does anyone want to comment? Or yes, I believe that the pathophysiology, the context of these patients for neurology in general is not very well known. There's a screening of the venous sinuses when there is intracranial hypertension. We can look for venous thrombosis or look for somebody else. But this type of stenosis, where there's extrinsic compression, often, and we see it in venous angiosity, and people think it's something normal. In the clinical context of this type of patients, of course, this is important. And we see it daily practice, not in a daily way, but we measure the pressures in the patients that we feel might have this. And there we see very high gradients, which improve with treatment. And we see how slowly each symptom improves progressively. The headache less quickly, at first the papilledema. The general neurologist, however, doesn't consider the screening as much of the stenosis of the sinuses. And you have to appreciate and evaluate them on the MRI. So we need to go and look for the ophthalmologist, do you think? When do you do so to open up the optic nerve sheath and then the small lateral ventricle if there's no thrombus, venous thrombosis? Did you hear the translation, sir, about the question, sir?
I don't have the translation yet. Wait one second.
John. Hello, can you hear me? Hello. Hello, can you hear the English translation now, sir? Hello,
Yes,
hello.
now I can.
Okay,
Yeah.
great. Okay, so we'll ask him to repeat the question.
Did you get it or you didn't?
I have not heard the English translation yet.
So the question was, when are you indicated the surgery? I think you already covered that point, but the question is when you indicated the surgery of the optic nerves, what was your indication for go for that?
Yes, so I will say that prior to stenting, we were doing a lot of optic nerve sheath fenestration, but since we've started doing stenting, we've basically reserved optic nerve sheath fenestration only for cases where patients have fulminant papilledema with threat of permanent vision loss within 2 weeks. But otherwise, we just go to stenting because usually the patients have improvement within 1 to 2 months. But if somebody has very, very, very severe papilledema, we will do optic nerve sheath fenestration.
I see. And the second part of the question was related to the ventricular size?
Los ventículos pequeños.
Sí, pero ¿qué le quieres preguntar acerca de eso?
Que se asocia frecuentemente de esta patología
In this pathology, there are small ventricles often, even without venous thrombosis. Did you hear it, sir?
Yeah, so you're saying that these patients often have small ventricles even without venous sinus thrombosis. And that is true, that the idiopathic intracranial hypertension patients do have very small ventricles. And that's another reason why we don't like to do shunting in these patients, because the shunts are difficult to place in these patients. And there is a high rate of shunt failure in patients with idiopathic intracranial hypertension. It's on the order of 20 to 30%.
Maybe we will have some solution from the endovascular point of view soon for that. But I want to ask you a question. What is, you mentioned that you have some rate of restenosis with the stent. Have you seen more on stainless steel, or you see more stenosis on nitinol stents? Or that doesn't matter?
No, so the stenoses, I've only seen one case of an in-stent stenosis. It was the one that I had showed you in the slides. Most of the restenosis is actually juxta-stent. So it's in a segment of sinus that has not been stented. And what is happening, I think, is that, because the brain is retaining the interstitial fluid, the brain is actually compressing on the sinus where the stent is not present and causing the restenosis. So in those cases, we will go and place an overlapping stent to take care of that compression. And one of the reasons that I like using the Zilver stent is that you can stent the whole transverse and sigmoid sinus with one 60 to 80 millimeter long stent, and that gets rid of the restenosis.
I see. Well, thank you very much, Wallet. We are running, as usually, with a shorter time. So thank you very much. It was a fantastic presentation. We enjoyed a lot. And I hope next year you will be with us in Buenos Aires instead of virtually in Rochester. Thank you very much for your contribution.
Yeah, that would be lovely. Thank you very much for the invitation. I'm very appreciative.
Thank you. So we're going to move forward for the last presentation in this block. Professor Jens Filler. It's another presentation for Germany, guys. Professor Jens Filler is director of the Department of Neuroradiology in the University Center in Hamburg. He's visiting professor of neuroradiology also in the University of Oxford. So, la próxima presentación va a ser el profesor Jens Filler.
The next presentation will be by Professor Jens Filler, a friend of Latin America. We're really sorry he couldn't come to Buenos Aires to be with us this year. He is professor at the University of Hamburg, visiting professor also at Oxford University. We hope briefly to hear him. I believe he is online. So onward with Professor Filler, please.
Buenos tardes.
Good afternoon.
In South America, wherever you are, my name is Jens Filler. I'm recording this in Hamburg, Germany. Unfortunately, I cannot be with you. So I would love to. I love Buenos Aires. I've been there a few years ago. That was a wonderful experience. So my subject today is next frontiers in stroke treatment. It's a very interesting task, and I'm trying to give you as good as an overview as I can. So these are my potential conflicts of interest. And where did we come from? We had all the inconclusive studies within the first 6 hours, and the major reasons were we included just all patients, even the ones without occlusion, which was a stupid idea, and not we, but some. And we used the wrong tools within the studies. And then with the advent of stent retrievers and the proper patient selection, meaning patients with actual arterial occlusions, we had good outcomes within the first 6 hours, and it's a huge amount of evidence for this one. And then also beyond 6 hours, and then specifically with the rapid software. This year we had another very important randomized trial with the Brazilian study, which is also a huge success. This is what I mentioned. We have about it works in Brazil and other countries. So we have this confirmation from Resilient. We have this year the BASICS trial on posterior circulation, which I will not cover here. The BEST study from China, also on the same subject. Then we had a direct MT on skipping IV TPA in mothership patients, and the actual SKIP study from Japan, and the ESCAPE NA1 trial. I will cover this briefly in my talk. And just very recently, a few days ago, the Mr. Clean no IV type trial stopped enrolling patients, so we will see the results in a few weeks and very few months, I hope. My talk is about the next frontier. So this is what we achieved and what's going to happen next. And it's really hard to predict what's going to happen. But I think we have three very important trends that I'm personally seeing. And that's one is gaining higher efficacy for the treatment, so standardization versus individualization. So both are more or less mutually exclusive. Then we have higher efficacy adjunct therapies, neuroprotection. And then a very important trend is also access for more patients. Not all patients who could have a benefit from thrombectomy get it because of problems with transportation and availability of trained interventionists. I will cover this also in my subject, in my talk. So let's start with this part. So obviously we all take great pains to standardize the treatment. So we have guidelines, but they are at times inconclusive. And something that emerged within the last 2 years is the importance of the first retrieval and the success of the first retrieval. And this is a study that is going to be published very soon in Stroke. You haven't seen it from the German Stroke Registry. And what you see here is the rate of reperfusion success per retrieval. It goes down. So first retrieval 40%, then second retrieval 20%. And this is from 1,800 M1 occlusions. So it's not only the superstars. Maybe you all have much better results, but this is across all of Germany. Let's say everybody is included here. And what you see here, the reperfusion rate increases. The more you retrieve, the better the reperfusion, obviously. So after 6 retrievals, you have included 83% reperfusion, but the clinical outcome doesn't improve. So we have the best outcome with the first retrieval, the second best with the second retrieval, and so on. So we need to invest in a technology that gets it right with the first retrieval. And this is something to think about. So I think many folks are thinking about, let's try aspiration first. And if this fails, we can still try a more complicated method. But the data that I just showed to you suggests that this might not be the right answer. So we should try to actually really get first pass recanalization. And the idea was first retrieval, distal aspiration, second retrieval maybe, or second therapy, combination therapy. And my feeling is that we will have a combination therapy as a standardized first approach. Of course, we have budgetary limitations and so on. So the individual choice could also be made between stent retrieval and distal aspiration based on some reasoning. And this, so that's what I was trying to say. So you have all these different combination techniques, Solumbra, ART, SAFE, Captive, Protect Plus, which are more or less similar with some subtle differences that might change something. So Protect Plus and SAFE here with first pass TK3 of more than 70%. But this is in the hands of the masters who more or less established these techniques, and it's not clear that it works everywhere. So this randomized trial, I think it still hasn't been published yet, the ASTRA-2 study. It analyzes frontline contact aspiration plus stent retriever versus frontline stent retriever only. And the combination therapy has a seemingly higher first pass effect, TK3 after first pass, but it's not significant, and it's a randomized trial, so that's not very conclusive. So it's all that are the p-values of nightmares. So it's just not significant. But yeah, it looks quite convincing that the combination therapy is also better than stent retrieval alone. But there could be another way to approach this problem, and this is if we have an individualized approach on a reperfusion technique. This is a regular occlusion, and this is an irregular occlusion. So some call it, they give it other names like the claw sign, irregular phenotype, clot meniscus sign. There are quite a few studies in the last 2 years on this subject in anterior and posterior circulation. And the interesting part is that this was one of the first, and they observed in a relatively small sample, but with very convincing results, that ADAPT seems to work best in the regular and stent retriever best in the irregular / claw sign, whatever. So it might be a way to still justify using non-combined therapy in the first attempt. And I think this is something that needs to be worked out in the coming time. So I think this is an interesting thing. So this standardization, so put everything in one basket versus individualization, I think this is undecided for the moment, but this is something we will closely monitor in the next few months. So then we have another approach, which is higher efficacy by neuroprotection and adjunct therapies. This is an example of experimental studies, and what you see here is, just as an example, normobaric hyperoxia on infarct volume in mice. So neuroprotection, does it work or not in stroke? And the red dots represent a huge effect on decrease in infarct size, and the blue dots not. And what you see, there is no effect, almost no effect beyond the 3rd hour. And that's animal studies, obviously. But there are plenty of other indications that the requirement for neuroprotection to work is an open artery. So first, it's strongly time dependent, and second, we need recanalization. So thrombectomy will create a renaissance for neuroprotection. We could call it thrombectomy-enabled neuroprotection. That's a very interesting development, and one of the first very important studies is the ESCAPE-NA1 trial. They randomized more than 1,000 patients to NA1, narinitide versus placebo, and they didn't find a real effect. So if you look at this, placebo versus neuroprotective agents, nothing, no difference. So neuroprotection doesn't work even with recanalization. But if you look more closely, in the patients who didn't receive TPA, alteplase, you have a therapy effect of 10%. So there seems to be some strange and unexpected interaction between alteplase and this neuroprotective agent. So the next study is already starting, ESCAPE Next, and just exclusively on patients without alteplase. So it seems, so I would bet that this is the first study with positive effect of neuroprotection in stroke. This is a huge breakthrough. There are other developments that are not pharmacological. So this is an injectable implant to stimulate the sphenopalatine ganglion here, and it's seemingly easy to inject. And it has been published last year in the Lancet, and same thing, almost an effect within 24 hours. Why is this important for us? It could use to be freezing the penumbra. If patients are transported from remote places, this could be a very good strategy to keep them thrombectomy able. So to freeze the penumbra, to freeze the growth of the infarcted brain. And that's interesting way. So they will invest more in this technique, and we will see other technologies like this that increase the number of patients for thrombectomy. And this brings us to the next subject, which is access for more patients. So there are some metropolitan regions where almost all thrombectomy patients are treated according to the protocol. But there are regions where this doesn't. And we have this famous comparison. Is it better to send the patient directly to the hospital or give the patient in a more remote hospital IV TPA first? I will not go into this deeply. There has been lots of meta-analysis. This is one of them, and it shows there is probably not a big difference, and this is due to the selection of patients. And just also a few days ago, the RACECAT trial, a randomized study on this subject, has been presented, and it also didn't show a difference. But the problem is, it applies for Catalonia, which is a very, let's say, well-organized region in Spain, and doesn't necessarily apply to more remote regions. So I think I'm really looking forward to the publication to see. So we have all these paradigms. So essentially what we need to do is we need to bring together the patient, the interventionalist, and the angio equipment. And there are different ways to do that. Bringing the patient to the angio with IV first through another hospital, mothership, drip and ship. But another option is drip and drive. That's meaning we bring the interventionalist to another hospital where the patient receives IV TPA. And this is one study from Hamburg, and we started this with Group A, where we had a drip and ship, and Group B, drip and drive. It's not exactly correct. And then you see what's going on. This is the drive the doctor to the patient, and this is the other way around. And what you see here is the time from CT to DSA, and the difference is 2 hours. So we are 2 hours quicker if we drive to a remote hospital and do thrombectomy there than do it the other way around. It has something to do with logistics. It doesn't necessarily apply to other regions, but to Heidelberg, they do the same. They started even a little earlier than we did. And we combined our forces to have a prospective study, which is called the NeuroSquad trial. And we found essentially the same thing. So we had a time improvement of 54 or 75 minutes, depending on onset to groin puncture and imaging to groin puncture. So that's really very convincing data. But as I said, this applies to Hamburg and Heidelberg, necessarily to other regions. And you can do some simulation stuff based on very elaborated models. And this is what you see here. Let's say you have this non-endovascular center and you have an endovascular center. And as a patient, you are here. Then it makes total sense to go first to the non-endovascular center and then to the endovascular center. But if you are closer to the endovascular center, no questions asked. But this changes dependent on different assumptions. And this is what we did. And we used this software from Destin Health, and it has been published this year in Stroke, to model drip and ship versus mothership versus drip and drive. And dependent on the transportation time, how long it takes, the door to needle time and the door to groin time, image to groin, and so on. And you see if a patient has a stroke in this region, we need to go to the hospital by car. And if the patient has a stroke here, patient can come to us by mothership approach. And drip and ship only makes sense in very remote regions here. And if you change your settings, let's say you have a delayed drip and drive doesn't make much sense anymore, so no violet regions anymore. And if you have an overload of the comprehensive stroke center, we have a low processing time in our center. It makes much more sense to drive to other hospitals. And we just did an analysis where you see this with the time of the day. So it changes if you are early in the morning or late at night. So obviously it makes a difference as well. But the final approach, and I think that's also very interesting, could become very important, is telementoring. So we would mentor a less experienced interventionist to do the procedure. So this is a part of the survey that we did this spring in the beginning of COVID. And what was interesting is that in Latin America, video streaming from angio to angio had a very high rate of interest. 50% of the participants were interested in this kind of technology. How does it work? We have a camera system. It's specifically dedicated with a specific streaming architecture. It's not so simple to stream live from an angio suite to an experienced proctor, and this proctor, in case of complication or something goes south, can help. And during COVID, it has achieved a huge adaptation. So you'll see some tweets here where it's used. So Dr. Galdames, for instance, here, you probably know him. He is really very excited about the system. These are actual images done with the system, and we published the first experiences here with a web device. You can zoom in even more closely to see what's going on. Then you can switch to the angio. It's even better than being in a room as a proctor, and you can help your colleagues who are less experienced with thrombectomy procedures. And we just started the Texas study. We call it Texas teleproctoring enabled clot extraction in acute stroke to help colleagues in Romania. So we proctor the colleagues in Bucharest. So that's supported by Medtronic. Very, I think I'm really looking forward to the results of this study. So it looks very good. So if I may summarize the next frontiers, from my perspective, high efficacy, my prediction is we will have standards for patient groups. So something like this claw sign and maybe other methodology to determine what's the best therapy for the individual patient. Neuroprotection, adjunct therapies. There will be many studies, and I think the key challenge for us is we need to stay involved. We shouldn't leave the field for others. We definitely need to keep our fingers in all this kind of stuff to maintain our role. And finally, my prediction for access for more patients, we need more patients to help more patients with stroke. I think this remote proctoring thing is turbocharged by COVID. This is what we observe. So participate, and if you're interested, reach out to me. Thank you very much. And yes, muchas gracias to Buenos Aires and vielen Dank aus Hamburg. Next year, I hope I will be able to come. Bye-bye, and thanks for the invitation.
Thanks, Jan. Actually, I think we would like to go to Hamburg, but we are expecting you in Buenos Aires. No problem with that. Saying that, thank you very much. That was we clearly see that we have frontiers, but I think I'm very optimistic about the future. So in regards of that, we are not having any more time. We are going to skip that, and we're going straight to the Guillermo Dabus, who is waiting for us and at the Baptist Memorial in Miami. Hola, Guillermo, ¿cómo estás?
Hola, Pedro, ¿cómo estás? ¿Escucha bien?
Hi, Guillermo, how are you? Can you hear me well? Yes, we are looking forward to listening to you. I know you're going to discuss carotid angioplasty, CAS versus hysterectomy, and the results of CREST-2. And what is your approach? What does your group think about carotid angioplasty? So we're anxious to listen to you. You can speak Portuguese, Portugal, English, or Spanish, whatever you wish. Just like, because the rest of the speakers speak English, I think it's easier for everybody to understand. So I am going to give my talk in English if you agree.
Perfect. So Pedro, thank you very much for the invitation. It's always a pleasure to be here and participate in your activities. One of the, one of the true masters on our field. So it's really an honor to be here. And, I'm going to be talking about the status of CREST-2. We're going to go through some data. And what will CREST-2 tell us? I mean, we don't have the results yet because the study is not completed yet, and it's going to be taking a while, but we're going to go through some of the specifics and the reasons why this study is going to be extremely important. So these are my disclosures. Specifically to this talk, I don't have any very specific disclosure. So, as a background, I think it's very important to understand where we are when we're talking about carotid angioplasty and stenting. And you can see here in this table, it's a very busy table, but what it shows is that over the last 30 years, pretty much, we did a lot of studies in regards to carotid angioplasty and stenting, okay? Even from the early days, first, of course, in terms of carotid disease, started with the NASCET, which compared medical management at that time in the 90s to carotid endarterectomy. But then following all the stent studies, you can see like the stents or carotid angioplasty stent has been extremely scrutinized in the literature. We studied it through all sorts of angles: symptomatic, asymptomatic, high risk, low risk, standard risk, anatomic risk, medical risk. So, I think, it's probably one of the most scrutinized procedures like that we have in medicine. And, I can tell you, like, as everything that we do, when you look into the progression over the last, it is like a little bit older, but, that's when a lot of studies in regards to carotid stents actually were published. But so from the 2008, a lot of the studies that were published actually showed a significant improvement in outcomes specifically for carotid angioplasty and stenting when using the composite outcome of death, stroke, and MI, which is used for a lot of the trials. Or if you do only composite of death and major stroke, you can see there's even lower. And, the reasons for this, as with everything that we do, that, we gain experience throughout the years, that explains that. So more experienced operators, better patient selection. That's the other thing that's extremely important. We're going to talk a lot about it because that's a very, very key component of CREST-2. We need to make sure we're selecting the right patients for either for endarterectomy or for the carotid stent. And we're going to talk a little bit more about that. And also, of course, improve technology. The technology evolves. The filters are better. The stent designs are better. The support that we have to do them are better. So all this come together to really facilitate improvement and result in improvement of the outcomes of carotid angioplasty and stenting. Before we go to CREST-2 specifically, I'm just going to touch upon some of the basic aspects of the CREST-1. So CREST-1, as we know, it was a study that basically compared endarterectomy to carotid angioplasty and stenting, specifically in symptomatic patients with greater than 70% stenosis. And the result, the overall outcome, the primary endpoint was very similar. So the overall composite of death, any stroke, and MI was very similar in both groups. Now, when you break up the stroke and MI, it's when it gets a little bit more interesting, right? So on the angioplasty and stenting group, there was a little bit higher risk of stroke. Now, most of this stroke happened because of minor stroke. So it was not major stroke. Actually, if you compare the endarterectomy arm to the stroke arm, to the stent arm, on the major stroke, the results are very similar and not statistically different. Now, when you look into the minor stroke, indeed, the risk of a minor stroke was greater in the angioplasty, or actually the risk that it happened more compared to the endarterectomy arm, 3.2 to 1.5%. This was statistically significant. However, in the other hand, the risk or the occurrence of MI was also statistically significantly higher in the endarterectomy arm, 3.4%, compared to the stent arm. So this has been a matter of debate throughout these last years. Here in the United States, where there's still a lot of regulation in regards to carotid stenting, mostly in regards to payment by the Centers of Medicare and Medicaid. So that's something that is taken into consideration. So that's important to understand that the risk of CAS, which is said by the vascular surgeon to be greater for stroke, it's true, but it's for minor stroke. And on the other hand, endarterectomy had higher risks of MI. So when you look into this graph here, which basically shows the freedom from all-cause mortality. So what does that mean? That means that if you had a minor stroke, you were way more likely to be alive, later on, than if you had an MI. So in other words, MI is associated with long-term mortality, while minor stroke is not. So the CREST-1, basically, again, what demonstrates is that endarterectomy and stenting are very similar procedures. There's a slightly higher chance of a minor stroke when you look into the stenting arm compared to the endarterectomy. However, the risk of an MI, like a myocardial infarct, or ischemia, was greater in the endarterectomy arm, and that is associated with long-term mortality, while a minor stroke was not. So the other thing that the CREST-1 showed is that there's specific age limit, basically from 48 years old to 79 years old, where both procedures are very similar. Now, most of the problems on the carotid angioplasty and stent arm actually happen in patients older than 79 years old. So that shows that potentially these older patients, maybe stent is not their best option. So now talking specifically about asymptomatic disease. And when that comes in mind is when we go to CREST-2. So, I would like to acknowledge we have a very cohesive group. It's like almost like a quality assurance group. We review all the interventionalists that want to be part of CREST-2. We review at least like 30 to 40 to 45 cases they each submit, and each one of us review, and then we have a thorough discussion in regards to this person should be or not part of CREST-2 in the stent arm. So special thanks to Dr. Rubin, who's the chair of our committee. Now, what CREST-2 wants to answer is like a question somewhat like that. This was actually a real questionnaire. So if you have a patient who is a 67-year-old and has 70% asymptomatic carotid artery stenosis, how is this patient treated according to what the answers were, depending on where you are in the world? And you can see here, the answers vary. A lot of people go through like asymptomatic just for medical management, but in terms of treatment, which is in a lesser degree, it changes in their atherectomy and stenting. It varies according to where you are in the globe. So that's the main question that actually CREST-2 is set to answer, is this. If you have a patient that is asymptomatic and have a greater than 70% stenosis, which is better? Intervention with either stenting or endarterectomy versus medical management. So CREST-2 was actually, it's an NIH-funded trial. First patient was enrolled in December 2014. Several centers are now part of it. So again, it's like two parallel arms on CREST-2, okay? And the primary endpoint is any stroke or death within 44 days of randomization, or an ipsilateral ischemic stroke thereafter up to 4 years. So we exclude the MI from this. So basically death and stroke. So those are the two arms. Why? Because again, the CREST-2 is a study comparing intervention, either with stenting or endarterectomy, versus medical management. And the decision about if the patient intervention would be endarterectomy or stenting, it's according to center expertise. So the center decides if you think it is a good case for endarterectomy or for stenting, that's what's going to be done, versus or randomized to medical management. In regards to our interventional management committee, as I mentioned, we reviewed like almost 400 interventionalists. So here in the United States, cardiologists, interventional cardiologists, interventional radiologists, interventional neuroradiologists, neurosurgeons, interventional neurologists, and vascular surgeons are the people involved in carotid stenting. So all of them, as long as they have a good track record and good volume, can be part of CREST-2. You can actually see here of this 400 interventionists reviewed, 50% were reviewed immediately, or actually even with like the follow-up reviews. 33 have been right now conditionally approved, which means that they need to submit a little bit more cases and then they will be approved. But there's a good amount of cases that have been like, denied or deferred. So that's important to know. We've been very strict on the people that can't participate in the study. In regards to the stent arm, those are the stents that were FDA approved. So those are the stents that are part of the protocol. They can use any of these stents, and any of these protection devices can be used. In regards to the endarterectomy, the endarterectomy can be done in a straightforward endarterectomy technique or an aversion technique, as you can actually see here. So it really totally depends on operator expertise, as long as it follows the rules of the protocol. The medical management is very straightforward and standard. The patients need to be on statin. The endarterectomy arm, they need to be only on aspirin, and on the angioplasty stenting arm, they need to be on dual antiplatelet therapy for at least 1 month after the treatment, and then aspirin, same way as the endarterectomy part of the trial, indefinitely. Primary risk factor targets: systolic blood pressure less than 130 and LDL cholesterol less than 70. And secondary risk factor target: non-HDL cholesterol less than 100, hemoglobin A1C less than 7, smoking cessation, target weight management, and greater than 30 minutes of moderate exercise 3 times a week. So similar to what happened in Sampras, we're really optimizing medical management in a way that has never been done before. So even if you compare the NACET, which was done, in the 90s, medical management at the time was not like this. So it's possible that even NACET at the time would be different. So who knows? But, so there's a very strict risk factors and control. So right now, at this point, about a month ago, we have that going about 70% of the cases for the systolic blood pressure less than 130, and for the LDL less than 70 in about 70% of the cases. So a pretty good compliance on that part. Of course, still needs rooms to improvement, but it's actually doing pretty well on that. Now, the enrollment in CREST-2, had a big hit when COVID started, like everybody else, right? We were like really in good track. The black line means what was expected. And then the red line is the surgical part with endarterectomy versus medical management, and the blue one is the stent versus medical management line. And you can actually see here that when COVID started, this really get a drop because, a lot of places stopped enrolling. It was very difficult to put patients on trials. The systems were shut down. The hospitals were shut down. So it makes it very difficult. So the prediction now initially of enrollment when the trial started was it would end in December 2020. However, we know now that this is more likely to happen actually in December 2022. And then, of course, there's 4 years of follow-up. But, at least at the time, we're going to have preliminary results. This is an interesting thing, just out of curiosity. We sent questionnaires to all the trials, to all the sites participating in the trial to see how affected they were in regards to when COVID started. And you can see here they all reported really significant their systems being very affected in regards to their research enterprise, making it very, very difficult to enroll patients or to participate in monitoring visits. So that of course, it's a big, big problem. And, because of that, you can actually see the reason why the study kind of dropped in the most recent months. In regards to the total numbers, so on the carotid stent versus medical management arm, the study is 66% complete. There's like 821 patients already enrolled. And on the endarterectomy versus medical management treatment arm is 73% complete. So, those numbers are very, very good considering everything. I mean, it's a lot of patients. I mean, in terms of neuro studies, those are like some of the largest studies to date. Now, CREST-2 trial is what we discussed right now, but there's also something that we call the CREST-2 registry, which is a little bit different. And the reason to have a CREST-2 registry is to facilitate rapid initiation and completion of enrollment in CREST-2. Why? Because this gives access to a lot of people to do carotid stent, to get expertise, get better experience, and with that, increase the enrollment on the CREST-2 trial, because a lot of these patients may fall into the same criteria. So if you have a patient that is asymptomatic 70%, it can be treated in the CREST-2 registry. However, preferably you need to put this patient on the trial. Now, if the patient refuses to be on trial, he can be in the registry. But the registry also involves symptomatic patients. So pretty much in the registry, you can treat everyone. You treat everyone in a controlled way, in a way that people know what's going on. Those cases are adjudicated, and the CREST-2 registry executive committee look into everything. And we actually have been able to review some of the data. I'm going to show some of the data on that and see that the reason why we think it's actually doing very well. So in CREST-2 registry right now, which includes stenting and some TCAR case, which is a new procedure, we have enrolled almost 8,000 patients. Just think about it. I mean, which other study has 8,000 patients enrolled? None, as far as I'm concerned. This is just for carotid angioplasty and stenting and for a TCAR. You can actually see here too on our CREST-2 registry, the interventions that we approved in the beginning started very slow, but then as experience was improving and the expertise improving, more people are approved. And right now we have 329 interventionists that are either totally approved or conditionally approved in over 200 centers. And centers now include mostly North America, but there are some centers in Europe, in Barcelona. There's some centers in Australia, and there's few centers now being started in Israel. So it's very interesting. Now, again, as I mentioned, the interventional committee and the CREST-2 looks very carefully at the results, making sure the cases are being done for the right reasons by the right operators and are being well selected. We published a couple papers on that. More interesting, this is a very interesting, I think this shows exactly what I was saying. When you select the right operators that are trained, because all the people that enter either CREST-2 trial and the CREST-2 registry, they need to participate on a webinar where basically they're told what we believe in terms of interventional management committee should be the best technique for the carotid stent procedure. And they're obligated to sign a paper saying they acknowledge that they will follow those guidelines. And actually, if you look into this, and this is a study that was published about 1.5 years ago, and taking data from 2 to 3 years before. So as I mentioned, we have over 7,000 patients now. This study was done when we had 2,741 patients. But you can actually see here, the numbers of the registry are second to none in terms of outcome. The outcome has been extremely good into like all patients, but if you split into asymptomatic and asymptomatic, those rates are better than the first CREST, the CREST-1. And those numbers in terms of like complications are actually spectacular when you compare to any other study that was done. So we're very excited about that. And I think this really proves the point that when you have patients that are, or patients that are well selected by physicians, interventionists that have the expertise to do it, I think that's really like the key for success. The other study that is very interesting as part of CREST-2 is what we call like CREST-Age. So CREST-Age is looking to cognitive assessment of patients. So let's say that a patient, you know, maybe the stroke difference is not going to be high between medical management and treatment, either by endarterectomy or carotid angioplasty and stenting. However, what about if cognitively they are better? So this is what like CREST hemodynamics or CREST-Age is trying to assess. So the patients, 500 patients, they're supposed to have perfusion and a neurocognitive assessment on baseline and then be followed for 1 year and see how they perform. So that's going to be very interesting to see if there is really an improvement in cognition or their better outcome in terms of neurocognitive compared to their neurocognitive baseline. I think it's very, very interesting what it's going to potentially show. So I'm going to share with you like some of the reasons why we think like this case should be very well selected and people should be trained and making sure they're entering the correct case in CREST-2, because you want to potentialize the chance of the study going well and doing well and demonstrating the results that they're supposed to show. So if you start putting like crazy cases, I mean, that's going to be a disadvantage for whatever technique you're using to treat those carotid disease. So I'm going to show some cases. There's some specific carotid angioplasty and stenting exclusions, and there's also some specific endarterectomy. I'm not going to mention the endarterectomy ones. We're going to look into specifically the exclusive like carotid angioplasty and stenting exclusions. So those are some of the exclusions, you know, severe tortuosity, for example, proximal common carotid disease or innominate stenosis on the right side if you have the problem, or if you have a severe intracranial stenosis. So everything that can potentially make the procedure more difficult or potentially masquerade like a bad result, I think that's important to exclude. Lesions that are extremely calcified should also be excluded. Why is that? Well, because those may be more difficult or more prone for thromboembolism. We don't know that, but we know that they respond poorly to carotid stenting. That doesn't mean that it cannot be done in an endarterectomy arm. So if you have that, instead of doing medical management versus carotid angioplasty and stenting, you put this patient on medical management versus endarterectomy for randomization, because these patients could be treated successfully with endarterectomy. The same way, lesions that are long, you know, may not be enrolled in any part because they're usually not very favorable for either. And sequential non-contiguous lesions. So I'm going to show some examples now. So for example, this case here, a patient with like a very heavily calcified and mild, you know, some tortuosity on the carotid, but mostly because of this heavy calcification, of course, should not be considered for CREST-2. A very tortuous arch, very tortuous innominated proximal carotids should not be done. Patients that have tortuous internal carotid, remember, you need to pass a filter with you unless you do the MOMA device, but you need to pass a filter, and you know, there's this angulation is not very helpful. Even if you straighten up the vessel, you may cause spasm. You know, that's a case that you want to do this, you can do in the registry, but you should not do this on the trial, because if there's a bad complication in this case, you know, that's going to go against the procedure and putting medical management to advantage. There's another, you know, case that, of course, not a good case to put in a trial, you know, a very bad arch, type 3, or again, an angle, like a tortuous carotid that is like heavily calcified. Again, lesion in the arch, you know, osteo lesions, very calcified. Remember, like in CREST-1, a lot of the strokes actually happen on the contralateral side of the stented vessel, which means that a lot of those potentially happen during manipulation of the arch. So that's something to keep in mind. So, you know, if you have a bad arch, very calcified, a lot of plaque, maybe that's not a good patient to put in CREST-2. And I'm almost done. Again, I just mentioned this, but severe tortuosity of the carotid arch, common carotid, not a good case. Usually translate, you push this sheath forward, this curve goes up, it all becomes a mess. I mean, why do that in a trial? It's not a good idea. Another case here, again, very tortuous internal carotid artery. Remember, you need to pass a filter. I mean, it's not a good case for it. I mean, I don't need to say that, but it's very clear that this patient should not be in a trial. Long lesions, another problem. Contiguous lesions as well. Remember, like you need to have one focal lesion. The shorter, the better. That's the perfect case for the trial. String lesions, string sign lesions, no case for crest. So the case that we want for crest are basically these cases here, okay? Short lesion, straight vessel. We want to potentialize, decrease the risk of stroke on the carotid angioplasty and stenting the most we can by good patient selection and by good training of the interventionists, of competent interventionists. That's how we believe we're going to achieve the best results possible in the angioplasty and stenting arm. So with that, I conclude my presentation. I really appreciate you all for the opportunity, and I'm happy to entertain any questions. Thank you.
Well done, Guilherme. Muy bien, parabéns. As you pointed out, I think the credentialing of the interventionalist is essential, as well as the selection of the patient. I think those are critical points. If you remember the case one, I was really disappointed, not by the result, but probably by the credentials that people need to get involved. So
yeah, I think
yeah, go ahead.
No, I think you're absolutely right, Pedro. I mean, remember, like there was, two big studies, like EVA 3S and SPACE, European studies actually, that most European, that really like showed, very poor results, to be quite honest, a very high risk of complications on the stent procedure. And a lot of that, when you look into the protocol, a lot of these patients were not on dual antiplatelets. A lot of the cases didn't have filter used. So, it's important that people understand that every procedure has a limitation, and you need to do and maximize the chance of having a good outcome of the procedure. How you do that is with good trained people that have experience, that have expertise, that understand what they're doing, and they're selecting the patients right. Listen, there are situations where sometimes you cannot get out of doing a patient that, it's more torturous. I mean, we do that, but should not be done in the trial, right? Because you want to potentialize the chance of the trial being successful. And in real life, if you have another option, maybe that's a good thing. I mean, we have nowadays, I don't know if you've done there in Argentina, if you're doing that, but there's TCAR nowadays. So, some cases are good for TCAR, some cases are better for carotid angioplasty and stenting. Some patients are still better for endarterectomy. I mean, we have all of that, and I think it's important that we all understand what is the best case for a specific patient. And, believe me, there's going to be patients that also will be good for medical management. We don't know what the result will show. I mean, a lot of that will be dependent on the results of the procedural arms. But, medical management nowadays, with all the medications that we have, understanding better that, the LDL needs to be less than 70, blood pressure less than 130. That's, again, statins. That shows promising for some of these asymptomatic patients.
Okay, thank you very much. Obrigado.
Muchas gracias, Pedro.
We have Sakai knocking the door, so we have to go to Japan. So we release you. Thank you again for contribution. Thank you for being so kind with Latin America. I know you are the center of training there. You manage training a lot of people there. So we really appreciate that from Latin America. Obrigado.
Muchas gracias, Pedro.
Adiós.
Es un placer. Adiós.
Adiós. So, Professor Sakai, the director of the Department of Neurosurgery of the stroke unit at Kobe City Medical Center, is ready to go with us. They have been performed angioplasty in Japan for many years. Those guys are very well trained, very well equipped. So we are looking forward to hear what's happened today with angioplasty and stenting in Japan. Nobuyuki is there. Please go ahead. Good morning. It's too early in Japan.
Thank you, Chairman. I'm Nobuyuki Sakai. Today, I'd like to present our experience of carotid artery stenting. This is my disclosure. Let me introduce myself. My name is Nobuyuki Sakai, Japanese neurosurgeon and neurointerventionist. Now, President of Japanese Society of Neuroendovascular Therapy. Worked at Kobe City Medical Center General Hospital. and I have a chance to host WFITNet Congress in 2022 at Kyoto. At first, we announced to you 16th Congress of WFITN will be held in 2021. Unfortunately, COVID-19 pandemic came to us, so we postponed to 2022. Date is August 21 to 25. Please come to Japan and join our Congress. This is total career of my neuroendovascular therapy, including about 1,500 carotid artery stenting. This is distribution. Recently, acute ischemic stroke therapy is growing. I started carotid artery stenting in 1997, and Precise and AngioGuard approved in 2007, and most recent approved device is Casper stent. This is Paramat stent. This is my first case. At that time, I deployed balloon expandable stent without any embolic protection devices. You need to understand, at that time, most of carotid artery stenting have been done with balloon expandable stent without embolic protection. Death stroke rate is about 5%. But as you know, carotid disease is embolic source to brain. As you know, progression of carotid diseases have dangerous plaque. Professor Teron developed his own blocking balloon system to protect emboli. 2002, we introduced pack-surge guard wire for use carotid artery stenting. This is recent device named carotid guard wire. We aggressively use this pack-surge guard wire. This is surveillance of JSNet in 2007. At that time, about 3.4% death stroke rate in Japan. 2007, Precise AngioGuard approved. Indication is high surgical risk, 50% or more symptomatic, 80% or more asymptomatic. But we have many bad cases with filter protection. This 61-year male have tortuous anatomy. I navigate AngioGuard distally and put stent. But just after post angioplasty, he have major stroke. Filter cannot catch any debris. At that time, this filter is only approved device. Very famous Argentina vascular surgeon Professor Parodi developed his own embolic protection system named Parodi system. His protection mechanism is making reverse flow during carotid descent. At that time, if I have unstable plaque, we introduce balloon guiding system with distal filter. You can see many debris catched by angio guard and aspirate blood have also debris. This is our surveillance. Professor Miyachi published this data. First period is carotid guard wire mainly used. Second period, we introduce filter protection. And the third period is combined technique. We use proximal balloon protection with this device. Result is much better than filter period. Probably you know, proximal balloon protection is better than filter protection. Everybody know carotid artery stenting have more stroke, but we have been conducted many national surveillance, including registry and trial. JRNet is nationwide surveillance of neuroendovascular therapy. Over 30 English publications. JRNet 1 to 3 catch 10 years experience. Permanent death stroke rate within 30 days is only 2.7% in Japan. We have now two modalities for carotid revascularization: surgical procedure and endovascular procedure. If efficacy of carotid stenting for stroke prevention is same with surgery, who want to give their neck to the doctor? Interventionists should show safety and efficacy. Current our protection system is combined use of MOMA and carotid guard wire. This is my total experience. Permanent mortality is only 2.3%. This is number of cases in carotid revascularization reported by Japan Neurosurgical Society. Carotid stenting reached over 10,000. However, carotid surgery is only 4,000. Japanese neurosurgeon control both surgery and stenting. Vascular surgeons CEA is only 100. Cardiologist carotid stenting is only 500. Neurosurgeon, neurointerventionist is main player. So stenting penetration rate is reached to about 70%. This is United its data. Stenting penetration rate is about 10% in United States. Japan have more endovascular. Neurosurgeon, neurologist, neurointerventionist is main player. This is very famous trial with stenting versus surgery. As you know, stenting have more stroke at 30 days, mostly minor stroke. This stroke occurred within 30 days. 2 of third occurred in the procedure. However, 1/3 is occurred after procedure. I show you our case. This 78-year male have 3 times TIA, so we treat with stenting. Intravascular ultrasound showed instant protrusion, and he have embolic stroke. Another case, the 78-year male have also symptomatic carotid artery stenosis, treat with stent, instant protrusion with the intravascular ultrasound, and he have ischemic symptoms on day 7. You can see intraluminal plaque protrusions. So we treat long ingression with balloon 2 times, and finally protrusions disappears. This is our analysis. Once instant protrusions occurs, more stroke. And this is another analysis. Stroke after carotid stenting occurred 70% after 48 hours. We have been used 3 traditional stents in the world. We have 3 different next generation stents. This is pre-cell area. Of course, wall stents have smaller than open cell stent, but next generation stent have very small free area. This is 3 micromesh stent, and this is characteristics of micromesh stent. OCT analysis showed less instant protrusion with micromesh stent. Italian cardiologist showed fantastic result with OCT analysis. Thermomicrovention made Casper stent in Europe. This system named Road Saver. In 2014, I have experience of this stent. This 85-year male of my stroke at the left carotid, and the MOMA and guardrail system introduced and angioplasty, stenting, and post procedures. This is carotid Casper stenting procedure. You can see no instant protrusion. This is third case. Unstable plaque. And I put Casper stent, even if external carotid occluded with plaque shift, but no instant protrusion. Long-term time. Thermo decided to do approving trial. I am PI of this trial. Indication of this trial covered both average and high surgical risk. We enrolled 140 cases in 13 Japanese centers. And only 2 endpoints occurred. Just before we published this data in JNIS, we enroll 40% of high surgical risks and 60% normal surgical risk. Guardrail protections in 57%. And multiple protection system is about 90%. And this Casper stent approved.
Well, thank you very much, Nobu. That was a fantastic presentation. Really, it seems like we have to learn a lot of things to learn from you guys from Japan. So thank you very much for being with us. Regards to everybody in Japan, in Kobe. We will be there next year in Kyoto. Javier, ¿qué te parece? Yo creo que estamos acercándonos casi al final de este bloque, pero me gustaría que que introduzcas al próximo
We're
speaker.
coming to the end of this block, but please introduce the next speaker. The next lecturer will be in charge of Dr. Batley-Vaughan, neurointerventionist of Barcelona, who will speak about the We Trust protocol, direct patients going straight to the mothership, so to speak, straight to the angio suite. Good day. Thank you very much for the invitation to see me one more year. I was there in the previous year in person, and it was a real pleasure. Unfortunately, this year, this is the way we have to work. Anyway, let's keep moving forward. I was asked to speak about direct transfer to the angio suite and the new clinical trial that is called We Trust that we are starting now. What we actually need to do to determine if a patient actually needs endovascular treatment in stroke is to rule out hemorrhage, rule out an extensive infarct, and finally confirm that there's a large vessel occlusion. The methods to do it are many, but anyway, they don't have to be always the same, depending on the time the patient has been since the onset of symptoms. As an illustration, look at this publication of 2013, where they assessed measures of quality in hospitals in the UK, and they observed as a measure of quality performing a CT on the same day. And you can see that this objective was reached in only 47% of cases. And this was not so long ago. And we are talking that over here, we are doing the exploration in minutes since the onset of symptoms or since they arrived at our center. That is to say, we have made great progress in this regard, time-wise, at different speeds, of course. Same as happened with fibrinolytic treatment 20 or 20 years ago when we started thrombolysis. Very few patients with thrombolysis, and we took 90 or 100 minutes. That was time to needle. And we really improved our experience trying to reduce this time to 15 or 20 minutes since the arrival to the hospital. We could start fibrinolytic treatment, and we are posing the same streamlining door to recanalization process. First, you have to motivate the whole team so they are aware of the importance of time, reducing time, and by doing this, you can significantly reduce door to treatment or to puncture. But anyway, there is a long time, 45 minutes in the interval between the angiography and the arrival to the suite. So some circuits need to be streamlined. And maybe some things should be skipped. What we always try to do is to get a pre-hospital alert in the ambulance, from the ambulance, so we are waiting for the patients at the door. So we bypass the emergency room. We do not go through the emergency room, if possible. We do a quick neurological exploration at this point, and then we ask the emergency department, the ambulance, to bring the patient directly to the CT scanner, where after the images are acquired, that is, without contrast, we can start with fibrinolytic treatment if necessary, and complete all the neuroimages tests with contrast to verify if the patient is a candidate or not to treatment. This time interval, door to puncture, can be very variable, but in this study in 2014, you can see the large differences in different centers. The best for doing it at 75 minutes, something that now seems crazy, but it is directly related, this interval, with worse prognosis. The longer this period, the worse the outcome. Lesser is the chance of not having disability. And you can see that in the large clinical trials, no matter how much they tried to reduce this time, Swift Prime and Escape took about an hour. It's not bad, but I think we can improve it. Let's consider an extreme case, a patient who is asymptomatic, who comes to the angiogram for diagnostic angiography, and while he's being transferred to the bed, he presents a sudden hemiplegia and aphasia. Most of us would not try to remove the patient from the angio suite and take them for another conventional CT. What we would do is confirm that the patient does not have a hemorrhage, that there is an occlusion with a cone beam CT. We can confirm this at the angio suite, and if so, we can immediately proceed in minutes to femur puncture. But how much are we willing to stretch this time interval without having to go through the CTs, through the conventional CT scanner, 1 hour, 2 hours, 3, 6, 12 hours? How long are we willing to extend this interval? If we think tomography obtained with the angiography machine is enough, this study that we conducted in Barcelona, we studied 2,778 stroke codes admitted in hospitals, and we tried to see the characteristics of patients who ended up receiving endovascular treatment and those who did not. And you can see that basically they were time measures. And according to the NIH scale, the aspects or the condition of the patient pre-stroke. We can also see that most of these patients, 80%, arrive within the first 3 hours. Instead, the percentage of the chance of these patients coming with ischemic stroke does not vary within the first 6 hours or 6.5 hours, and the chance of having a perfect aspects of 10 diminished quickly with time, about 60%. But the chances of them having an aspect compatible with thrombectomy that is beyond 6 or more, is even greater than 90%, up to 6 hours. Very few patients present in this temporal window with an aspect that may be a contraindication for thrombectomy. So probably you don't need to get sophisticated images to identify these patients, because they're very rare, and probably it would not be harmful to perform a thrombectomy anyway. And the chances of having an LVO also remains quite stable, around 40%, and the chances of receiving endovascular treatment also is within these percentages, and this is because aspect doesn't drop too much within this period. So finally, if we can make sure that the patient does not hemorrhage with a CT scan with a good functional situation previously, we can find 60% of patients who will benefit from thrombectomy. So what are the circuits that a patient can follow when they arrive to a center? Just like you said before, they can go to the ER, but we try to skip the ER in every single case, because this means going back and forth to the CT scanner, and a lot of time is wasted. So whenever possible, we try to send the patient straight to the angio suite. And in some cases, if we are at the hospital and ready and prepared, and we know that the patient is arriving, plus we've done a neurologic exploration at the doors showing a high chance of occlusion of a large vessel, then we can transfer the patient straight to the angio suite. The emergency system sends the patient straight to the angio suite, and in very few minutes since arrival, you can see how we transfer the patient. We prep the patient quickly. Everybody knows what to do. Everybody is trained and synchronized. Here we are going to acquire the images. We will confirm there is no hemorrhage, no intracranial hemorrhage, and from there on, in less than 5 minutes from the arrival to the suite, we are ready to proceed with puncture and perform the procedure. It's impossible to go faster if you follow this circuit. This, we have to show, is safe as well. you know that now hemorrhage can be detected with current cone beam CT, but particularly those that will cause high score. There are algorithms that actually improve or optimize the quality of images. Can you see there's a very good resolution? These are images obtained in the angio suite. And a criticism that is done to the posterior fossa. In the posterior fossa, you can also see that the quality of the images is also very good, and you can detect hemorrhages very easily. Our first pilot study with direct transfer to the angio suite was done a few years ago. Since we started with this protocol, we've seen that about 1/3 of the patients, we could logistically transfer them straight to the angio suite. Another third went straight to the scanner, and in some cases, in the last third, it was not possible either because we had not been told or we were not there present, and the patient had to go through the ER. Now I'm going to compare the times and results. You can see that the price we pay to take the patient straight to the angio suite is that we transferred without occlusion that would not need thrombectomy, and this percentage, well, actually would depend on a percentage of patients who are directly admitted from the street or those that come from other health centers, and they've already experienced the ones with hemorrhage. And the price we pay is to obtain this a significant reduction of times. You can see how the mean time door to puncture is 15 and in some cases 8 minutes compared to 60 minutes or 90 minutes if the patient had to go through the emergency service. We can reduce 50 or 70 minutes, and this necessarily has a price to pay. Now we saw the patients that went straight to the angio suite. There were many more that had a dramatic clinical improvement, very good improvement in the scales. But there are other groups that propose the same thing. Some propose making the diagnosis with a CTA in the angiography suite. In every case, there is significant decrease in timing, around 20 minutes less from door to puncture. And here you can see other publications that are becoming more and more popular over the last few years. And to assess the impact on outcome, this first study, actually, it was not too good to do that because the groups were not well balanced from the onset of symptoms to the arrival at the center. So we have a study with case and controls where we matched patients according to age, time to arrival, and location of the occlusion. And you can see that this dramatic increase in time, about an hour, going straight to the angio suite, had a repercussion in the modified ranking. You can see that the patients had more favorable results without disability. So this encouraged us and confirmed that we were on the right avenue. But what should we have to do to generalize this? We have to do a randomized trial, well randomized and well controlled, and this is precisely what we're doing. What we are doing in the WITRAS trial is that upon arrival to the center, and then we'll speak about the protocol. This is what we're doing in this WITRAS international trial. Here you see a different example, a patient arriving, quick neurological exploration, confirming the situation. We can start treatment, but a question that comes up is, are we denying the benefit of giving TPA IV in these patients because they come straight to the angio suite? No, I think the answer is no. Based on our experience here in this slide, we have more than 35 patients treated with fibrinolysis at the angio suite, after acquiring the image with the angiographer, and none of them has had a problem. Hemorrhagic rates are similar to a group where TPA was given after the conventional tomography. There are not many complications. We believe that the quality of the images of the cone beam CTA is enough to give TPA, probably even better than of the first trials with TPA in the 90s, of course, when TPA was given based on the angiography units of the time. But how far from symptom onset is this kind of admission beneficial? Straight to the angio suite. This is another study of case and controls where, in general, the prognosis is always favors the group that was going straight to the angio suite. And if you look at this, what about patients who arrived much earlier? You can see all the patients. They've been classified in less than 3 hours and more than 3 hours. Reduction of time is similar at 45 or 55 minutes, but at 55 minutes, they will have more impact in the first 3 hours, which means much more, much better than within the first 6 hours. So, reducing by 50 minutes in this fast transfer, the patient that quickly develops an effect in the first 3 hours will have a great impact on outcome. But when we're closer to 6 hours, the impact of time reduction will have less effect. So the sooner the patient arrives, the more they will benefit. Here showing that the benefit is within the first 3 hours, and then you lose part of the benefit. Why are we doing this We Trust trial? Why should we perform it? We have said this in 16 centers. At Dr. Lylyk's center, we had the pleasure of having him and his team. They are involved, and we are very encouraged with this project. We want to include in 16 centers all over the world more than 500 patients in 2 years' time, and will be followed after 3 months post-treatment. This is the idea. We want to assist if we can get rid of this image that when the patient arrives, or whatever is normally done in centers, whether it is a CAT scan or an MRI, and the patients will be randomized to go straight to the angio suite or to conventional images. And from there on, they will continue the usual clinical practice, treatment with thrombectomies, if it's necessary or not. The primary endpoint will be seen in patients with confirmed occlusions, and then we'll see what happened with both groups. So we want to demonstrate that the quick triage to the angio suite is positive, has a positive impact in patient outcome, and that current technology, is mature enough to select the patients in this manner very quickly, and thus reduce the 60 minutes down to 40 or 50. We believe that together we can have an impact in the future of stroke treatment, and we are ready to start with this trial. In the next few weeks, we hope it will be in January or February, I think we can start recruiting patients. Thank you very much. Delighted to discuss this topic with you. Thank you, Dr. Rivo. Excellent project and excellent presentation. I hope that next year you will be able to be here with us in person. Unfortunately, our time is almost up for questions, so we have to continue with the very last presentation of this section. So, Pedro, we can continue? Yes.
We're almost at the end. We just had the industry symposium. However, before that, there is a North American Society of Interventional Neurologists that is carrying out a very noble gesture for all of us. Many people around the world have embarked on MT 2020. We have the pleasure of having with us here the president of this society, Lylyk. He is Director of Interventional Neurology, Co-Director of Endovascular Neurosurgery, and he is Director of the Stem Cell Platform at the University of Miami and at Jackson Hospital, we all know in Miami. So we have Lylyk here with us who will tell us what this initiative is all about.
We have a pleasure to have you with us. Ending this symposium of ischemia in Buenos Aires. We thought with Javier and Esteban and also with our co-chairman of MT 2020, with Angel Ferrario, that will be a fantastic thing to finish our symposium with your advice about the MT 2020. So please, the platform is for you. We are waiting for your talk. Thank you for being with us, and welcome to Buenos Aires, virtually.
Thank you so much. Thank you so much. It's such a pleasure to join all of you. I visited Buenos Aires last year in November, and I thought I would come back much earlier to your beautiful city, but at least I'm there virtually. Thank you, Dr. Lylyk. Thank you, Pedro, for inviting me. And I won't waste any time because the topic that you've allowed me to kindly present is very exciting and close to my heart. Mechanical Thrombectomy 2020 Plus initiative, global initiative working together globally for stroke thrombectomy access. So these are my disclosures. I don't own any patents or royalties. I do consult for companies, and I have grants for stem cell research in stroke. So the outline for just the next 15 minutes is going to be fairly straightforward to discuss with all of you the rationale for Mission Thrombectomy 2020 Plus. Why did we do it? What is the mission and vision of this global public health campaign? How are we currently organized? And then the public health interventions that we are pursuing to accelerate access to thrombectomy globally. So what is become very clear is that there is a major burden of stroke globally, and that burden is very geographically disparate. And what do I mean by that? So 80% of this global burden of 17 million strokes that is also quoted to be around 13.6 million. So there are, I think there is a overall decrease in the incidence, annual incidence of stroke since these numbers in 2010. 2016 numbers are 13.6 million, which is good, but it's still a staggering burden. And 80% of that burden is in low and middle income countries that have less than 20% of the resources to really attack this global burden. The number of survivors actually is now estimated to be about over 100 million stroke survivors globally. And so this long-term disability burden due to stroke is now substantially modifiable. And why do I say that? Because all of us know that the major burden of stroke comes from large vessel occlusion stroke, and we finally have a highly effective therapy for that subtype of stroke. And so that's why, without going into the details of all the evidence we all know of the multiple randomized controlled trials that showed that mechanical thrombectomy is not only highly effective, but very safe and very cost effective, we now have a blockbuster trial published in New England Journal by our dear friends Sheila Martin and Raul Noguera, showing that this therapy is immensely beneficial even in low and middle income countries. And so this can be implemented virtually anywhere globally. And this is a trial from Brazil, as you know. And this therapy is highly cost effective. So it's while highly costly, it is very cost effective, because if you look at the study from Saudi Arabia, a modeling study showed that this implementation of thrombectomy led to a saving of $600 million over 15 years, because the number of disability years that are saved by doing a mechanical thrombectomy and making a patient independent is that outweighs the upfront cost of the treatment. So when we have such a effective therapy, the question that we asked in SVIN in 2016 is, what is the gap in treatment? And we started just even with the US, which is a leader in mechanical thrombectomy, and we found that even the US had a major gap. What we saw was that the number of eligible patients for thrombectomy was a widely ranging estimate. One estimate thought it was between 30,000 and 100,000 patients. But there are other estimates that go up to almost 200,000 patients of LVO in the US. And that is now felt to be the more accurate estimate. And in 2016, we were only performing under 20,000 thrombectomies. So less than 10% penetration. And the worldwide estimate of LVO, if you take the 17 million figure or if you take the 13 million figure, is 1.7 million to 1.3 million LVOs annually, with the total number of thrombectomies in 2016 was less than 100,000. So the gap in implementation of this highly effective therapy is staggering. And this is compounded by the fact that access to stroke treatment is very time sensitive for outcomes. Even in the US, in 2011, only 60% of the population had an access within 60 minutes to a endovascular stroke treatment capable hospital. And even the recent modeling data, almost 10 years later, shows that only 63% of US population would have a 60-minute ground access. And with air, that goes up. But this is still a very humbling figure that we are far away from achieving a high degree of access to this highly effective therapy. And as we know, one of the most effective therapies in medicine with a number needed to treat of 2.5. What we also know is that even in a given continent, such as Europe, there is a major geographical disparity. Western Europe has very good number of units, whereas the Eastern Europe has a lot less penetration of the number of stroke units per million inhabitants. So this geographical disparity is what made us think about a global campaign that could address this disparity that exists globally and try to really decrease that disparity using a public health intervention. When we looked at the numbers beyond 2016, here is what we found. In the US, the numbers went from 10 to 20,000 in 2016, went to 32,000 in 2017 thrombectomies, and to 45,000 in 2018. And the 2019 numbers that just came out that I didn't get a chance to put here are still around, just around 50,000 in the US. And so the question is, by 2020, can we get this closer and to a 50% penetration? Worldwide, the numbers are even more staggering. Staggeringly low is what I mean. And there were 79,000 in 2016, total thrombectomies. 2017, they rose up to 106. 2018, they went up to 156, so a decent increase. And 2019, this is projected, but it's actually a true figure of 192K thrombectomies in 2019. So the goal that we proposed is that we would double these numbers to a goal from 2018 to 2020 of 202,000 thrombectomies using public health interventions. That's where Mission Thrombectomy 2020 was born with that thought in mind, and we announced this in 2016. And the vision and goals were as follows. MT 2020 is a global, metric-driven umbrella campaign. So we believe that we are going to be holding hands and joining all parties and societies that are interested in increasing access to thrombectomy to reduce death and disability associated with LVO ischemic stroke by accelerating access to mechanical thrombectomy. And how are we going to do it? We are going to integrate disparate knowledge barriers that we know from different regions. We are going to unify multiple efforts that different societies have. And we are going to use public health interventions and double the access to thrombectomy every 2 years for the next decade so that we can reach to a 50 to 60% penetration. And again, like I said, the goal for 2020 is 202,000 thrombectomies to make it catchy for the year 2020. We have to see, we are in the last month, and we have to see in a few months if we did achieve that. And so how are we going to do it is something that I'll describe in the next few slides. But it's useful to step back and learn about some principles of how do new treatments diffuse. This should actually say, how do new treatments in medicine diffuse? And it turns out that it takes about 30 years for a new treatment to reach about 40%, or about 50% access, I'm sorry. And this is constrained by information, by facilities, by trained physicians, by financial access. And so this is actually not something that is only specific to thrombectomy, but this is what happened to STEMI for heart attacks. And turns out that way back in 1962, Everett Rogers figured out this by modeling that new treatments, unless you do active public health interventions, they're going to take a long time to reach the patients that they can benefit. And so what we decided was that thrombectomy was indeed in need of public health interventions, and this is again based on principles of what conditions can be benefited by public health interventions. They have to be a large health burden, which stroke is. The burden is distributed unfairly, and I told you that's the case globally. The treatment is highly effective and safe, and so we have thrombectomy that's very safe. The treatment is cost effective, and there must be evidence that upstream preventive strategies. What do we mean by that? I'll tell you in a second. These are political and social strategies that could substantially increase access to this effective treatment are not yet in place. So this is a clear indication that thrombectomy needs public health intervention to increase access. And the upstream strategies are economic, they're political, and they're community factors that are addressed by these strategies that can substantially increase the treatment. And so what we want to do is take this 30 years time horizon in both high-income and low-income countries and move that to the left and make it in 10 to 15 years rather than this long time in each of these regions. And we are going to do that by arming ourselves with the knowledge of the access pillars. And so these public health interventions will address what we know are the pillars of treatment access. The first pillar is information and diagnostic access. There should be enough information, widespread information about LVO, diagnosis and triage. So both specialists and generalists need to know about LVO diagnosis and triage, and therefore allow for a correct triage of LVOs to the right facility. There needs to be the facility itself. So physical access is a second pillar, and the distance to facilities, the availability of angio suites, and the actual availability of stroke teams to manage this flow of patients is all it all falls under physical access. And then, of course, probably the most important is financial access, where this treatment is reimbursed because there is clear agreement that this is highly effective and cost-effective treatment, and it does not fall on the patient at an odd hour to have to come up with this payment out of pocket. So what we have come up with is a scoring for access that is in development, that is based on all these three pillars. And what we want to do is accelerate LVO diagnosis and treatment with public health interventions. We want to accelerate physical access, physical infrastructure, and we want to accelerate the financial ecosystem so that this treatment is highly reimbursed. So we put this structure together over the last 4 years that has a core leadership team in the US and a global executive committee that is comprised of all the regional co-chairs that are based globally. This central committee works with several leaders in stroke throughout the globe that are in different parts of the globe. Dr. Demchuk, Carlos Molina, Sheila Martins, Thomas Leong, Osama Mansour, Dr. Miao in China, Dr. Sailaja in India, Dr. Mehari Gabians from representing Africa, work with all of us in the core leadership committee that include my colleagues, Dr. Inoa Jadhav or Santiago Ortega, who many of you know, and Dr. Al Mufti, and we have added 4 more excellent rising stars in stroke and neurointervention, Drs. Kaushal, Nabil, and Asif to this roster. And we all work with regional committees that are based in different in all over the globe. And this regional committee is comprised of a stroke chair, a neurointerventional chair, and 6 to 8 board members that are distributed between stroke and neurointervention. And we have a country liaison that connects us to the regional committees that is based in the US, is from originally from the country they are liaison for, so that we can use that connection to stay closely connected with the regional subcommittees. The SVN Leadership Committee guides us, and then there is a excellent project management company called Orbis Medical that helps us administrate this very large structure on a day-to-day basis. We have an advisory committee of all the societies that are partnered with us, including AHA, ASA, ESO, Mina Sino, and certainly SIMI would be another society that we could be partners with, and we get advice. And I'm very happy to announce today that we have a total of 82 committees now, or actually 86 now as of this week, that are spread in 6 continents throughout the world. So this has been a amazing growth over the last year, where we have all these regional committees that are carrying out several public health interventions in their regions. We launched 86 committees, as I mentioned. We are starting to communicate to the regional ministries of health and health policymakers the white paper that was published in that was actually developed in 2019, just published this past World Stroke Day, which is a white paper on building thrombectomy capacity, why and how, which is directed towards health policymakers. So it's written in a language that is non-technical, non-medical, and it really informs health policymakers and ministries of health why thrombectomy capacity building is important. We have a regional thrombectomy capacity baseline survey that's ongoing in each region that the regional committees are carrying out. We are asking the regional committees, and they're working very hard to develop and have an implementation plan for top 5 public health interventions customized to their region for 2021. And then we have a very exciting smartphone app that's called a Global Thrombectomy Tracking app that we want to increase adoption for, because what it allows us is to enter a case in about 30 seconds that's de-identified, and that case gets geotagged with the smartphone technology to the institution that the case was done in. And so you can zoom in and zoom out to see in real time, as long as that case is entered, how many thrombectomies were done in the last day, in the last hour, and even in the last minute, both regionally as well as globally. And so this is a app that the regional committees are working on. Now, coming back to the white paper, this white paper is for policymakers, as I said, and there is going to be customization to high income, low income, and very low income countries, as well as translation of these of this paper. Going forward, the core committee is developing patient education materials. It's developing new payment methods new infrastructure and payment methods. We are increasing certification programs that can be adopted quickly in low and middle income countries, and then develop innovative payment methods that can facilitate reimbursement. This is an example of a self-attestation certification that has been developed in India for thrombectomy centers, and we have several white papers in the pipeline for rural access with SNIS and a global demand and supply of workforce with WFITN. So in conclusion, and I hope I didn't exceed my time by much, MT 2020, and it should be plus because we're going beyond 2020, so the name has been changed to MT 2020 plus, is a global multi-stakeholder public health campaign to accelerate access to LVO stroke patients with the ultimate goal to lower death and disability from acute ischemic stroke. The campaign aims to see a successful goal of 202,000 thrombectomies by the end of 2020, which is a feasible goal of the near doubling of thrombectomies from 2016 to 2018 of 100,000. So we do hope to see, because 2019 we had almost reached 200,000, that most likely we're going to exceed 202,000 thrombectomies in 2020. But really, it's a forward-looking goal that every 2 years in this decade we're going to double numbers that will close the gap. And I talked to you about, I've shared with you the interventions that we've already done and what we are in planning for the future. So thank you so much for your attention. I'm really thankful and happy to take questions.
Well, thank you very much. That was a fantastic end of our stroke meeting in Buenos Aires. I think we really thought that will help really for the initiative. Will be help also in every single country, not only in Latin America and around the world. So congratulations for initiative. We're going to help and push a lot from Buenos Aires and from Argentina and from Latin America. Unfortunately, we are running out of time as usually. So we're going to close the day. That has been a very productive day. Thank you for all of you. Thank you for people who were connected in Argentina, Buenos Aires, Latin America. We're going to end it up with the industry symposium. So looking forward to see you tomorrow with us in the morning. I will pass to the guys that will announce the symposium, the evening symposium, actually very late evening symposium. Thank you. See you tomorrow. See you tomorrow. Bye. See you tomorrow.
Bueno, terminando, como decía, hablaba el doctor Lylyk, vamos a presentar el simposio.
To conclude, as Dr. Lylyk said, we're going to present the industry symposium divided into two parts. We're going to start initially with Philips, who will speak. Alexandra Carr is one of the engineers. She's one of the scientists in the United States for geography. And in the second segment, it will be the Medtronics Symposium, where Dr. Lylyk will speak about the experience of, Pedro Lylyk will speak about the experience with pipeline. So we'll start with Alexandra Hag in a few seconds.
Okay, Alex. Okay, we will start with the symposium. Alex, are you? I think you are ready.
Yes, I'm ready. Thank you, Carlos. Thank you, Dr. Lylyk and team, for having me here. It's a pleasure and honor to be here. And, you know, like I have been listening to all the talks for the past 2 days, and yeah, a very impressive program. So congratulations to that. I want to talk about like our innovations and what we are working on within Philips, but I figured it would be also good to talk about our missions and where we came from and where we want to go. So Philips, you know, like changed quite a bit in the recent years. You know, like we are focusing solely on healthcare. You know, like we don't sell light bulbs or TVs anymore, and basically the health continuum is, you know, like our main focus. You know, like from healthy living to prevention of diseases to diagnostic treatment, and, you know, like also to the home care. And within Philips we have different clusters which, you know, like span or which handle, you know, like different parts of the healthcare continuum. However, you know, like I'm part of image-guided therapies, you know, like the business unit that develops angiographic systems. And we overall in Philips, you know, like we want to achieve a quadruple aim, which is basically improving patient experience, better outcomes, improve staff experience, and also lower the healthcare costs. And if you look at image-guided therapies, you know, like from the early beginnings, you know, like from developing X-ray tubes and angio systems and reducing dose, we also switched in this business unit gears, and, you know, like focused also on the treatment of patients, which, you know, like started by acquisitions around 2015. IGT system, you know, like one of our pillars that we are working on is really, you know, like improving the workflow. So, you know, like we want to basically improve our systems in a way that they are not, you know, like that you don't have to work around them, that the system works around you. So you can see this, for instance, here with our flex arm systems, which is flexible, you know, like in the position where it is, so that you can work from everywhere, and that the system moves out of the way. The same, you know, like from our, you know, like from the technician or from using our systems, you know, like we have parallel working from the workstation, and then also with our latest Azerion release, you know, like the focus is really, you know, like how do we improve workflow, you know, like to have the best experience for the physicians, for the people who use the system, but also, you know, like the best experience from a patient perspective. So, you know, like we integrate our you know, like intra-arterial imaging, you know, like we use more and more the touch screen, you know, like to do measurements or to mark certain landmarks. So workflow is, you know, like really one of the things that we have been focusing on a lot. If we, you know, like look at these improvements, you know, like we have been conducting studies where we show, you know, like that, you know, like in the preparation or during the procedure, we can save quite some time, you know, like making the system, you know, like work for you, you know, like easy to use, which actually resulted in a 17% reduction in procedure time, you know, like just by you know, like working on the usability of the system. However, you're like looking at workflow also means actually looking at workflow for certain disease areas, and, you know, like stroke is certainly a disease area where we have been looking a lot. I mean, I don't have to explain anybody here, you know, like about you know, like the implication of stroke in terms of, you know, like disability, cause of death, and, you know, like how many cases there are, you know, like worldwide. And, you know, like since 2015, you know, like since all those thrombectomy studies came out, you know, like it's pretty well established that, you know, like an effective reperfusion for ischemic stroke is a very effective treatment. And the earlier a patient can receive that treatment, the better it is for the outcome of that patient. And we as Philips, you know, like we look at this overall stroke pathway, you know, like holistically, and you know, like from emergency care to diagnostic to treatment, how can we improve that? And you're like, there certainly several things where you can improve. You know, like if you look at the stroke pathway, you know, like from onset of the stroke, you're usually picked up by an ambulance, and you know, like there you can certainly do improvements, you know, like to basically get the patients into the right hospital, you know, like to a comprehensive stroke center or to primary stroke centers. And you're like doing this conference, we have seen, you know, like several approaches and technologies that can help. And you know, like even if you're once in a primary stroke center, you know, like the decision making, you know, like, or the workup in the primary stroke center to get to comprehensive stroke centers, you know, like there's a lot that you can gain. However, you know, like we as IGT systems who, you know, like work on the, you know, like angio system, we focused on, you know, like how can we make the workflow better in the comprehensive stroke center. And, you know, like as already Mark Rebo or Raul Nogueira pointed out, you know, like if you skip the CT imaging, the diagnostic imaging, and you go directly to the angio suite, you can save quite some time. And with saving that time, you're like you may be able to improve outcome. And you're like the preliminary studies, you know, like pointed all in that direction. And we as Philips, you know, like sponsored a direct to angio study, which, you know, like we call VTrust, which we are actually very proud of. And so why do we think we can do, you know, like a direct to angio study? And that also has to do with technology and especially with innovation in the how we acquire cone beam CTs and what image quality we can expect. So we have like a new image acquisition, which we call a butterfly acquisition, which basically doesn't just have a circular movement, it also has a cranial caudal component to this. And together with a new reconstructor, we are basically able to improve the image quality by a lot. So there are less beam hardening effects. So here on the left-hand side, you see a standard cone beam CT. In the middle, you see the new cone beam CT. On the right-hand side, you see a multi-detector CT. You have less bleeding of the skull into the soft tissue, but you also have like less artifacts from the skull base, which you can actually see here where we slide in truth the volume in axial fashion. So we have done extensive, you know, like studies clinically, you know, like these images you see here, courtesy from Vitor Pereira from Toronto, and we are using, you know, like this type of technology in the direct to angio study, you know, like to exclude hemorrhage. So if we look at all the imaging and you know, like the non-contrast CT where we exclude hemorrhage, you know, like you also want to give the physician tools to assess, you know, like the vascular anatomy and also, you know, like the, you know, like parenchyma and the salvable tissue that you may have. So the idea is basically that you acquire your non-contrast cone beam CT, and then that you inject IV contrast and you watch it with on fluoro until the contrast arrives, and that you then acquire an early phase cone beam CT contrast enhanced and a late phase, and basically with the early phase, like you can assess, like the healthy tissue and the blood clot, and with the late phase, you can assess collaterals and the penumbra. So how does it work? So basically you have a mask, you have an early phase cone beam CT and a late phase cone beam CT. And if you subtract the mask minus your early phase, like you get an idea of, like what's your core volume. If you use the mask, if you use the late phase, sorry, and the early phase, like you can get an idea about your penumbra. And in Toronto, like where we ran studies, like we had actually nice correlation between like these penumbra estimates and actually rapid scoring from standard CT. So with this, I would like to, like we feel that we, like can run this direct to end use study. And now I actually would like to, talk a bit about the study design. So as I already said, or was said before, like the 16 centers are participating in that study. So Sagrada Familia in Buenos Aires with Dr. Lylyk's team is one of the centers. And we are fortunate to have, like the Dr. Noguera and Dr. Rebo as PI and co-PI respectively. 16 centers over 3 continents will participate, and you're basically almost ready to enroll the first patients. So hopefully beginning of next year, we will have enrolled in the first patients. Here again, like an overview of the sites that are participating. And if you look at the study design itself, so we have a stroke patient, like we have certain inclusion criteria. So very important is here the NIH-SS score greater than 10. And also, like time last seen well less than 6 hours. So it's basically we are focusing on the population where we expect, like high eligibility for thrombectomy, and also, like high benefit from thrombectomy. These patients will be randomized at the door based on this on these inclusion criteria, and we have variables that we track, such as age, NIH-SS score. We do include mothership and transfer patients. So mothership, basically patients that come directly to the thrombectomy center, or like as well drip and chip patients. We distinguish between the early, so 0 to 3 hours and 3 to 6 hours, and we also track thrombolytics given yes or no, basically to be able to balance those 2 arms. Then after randomization, 1-to-1 randomization, the patient goes either to conventional triage, which is CT-MR, or they go directly to the angio suite. All these patients will be part of our safety population, and then after basically the diagnostic imaging, we rule out intracranial hemorrhage or a large vessel occlusion with the intention to treat, and then those patients will receive a thrombectomy, and we will track at 90 days their MRS score. Additionally to that, to our primary endpoint, we are also measuring quite a bit of time points, which I'm just showing here. Probably the most important point here is like the door to arterial puncture that we are tracking, but we are also looking in all these other measures. We're also utilizing a core lab, which will assess, like the diagnostic imaging, either if it is cone beam CT or conventional CTs or MR, and then also the follow-up imaging at 24 hours, as well as the 90 days MRS assessment. And with this, like we hope to provide evidence that like a direct to angio approach is feasible and is the way to treat these type of patients. we just launched a website where we, show the progress of the study. So we are really almost ready to have like the first site up and running, and that will be hopefully a great opportunity, to help stroke patients and to treat those patients in a most optimal way. With that, I'm at the end of my presentation, and I'm happy to take any questions. Thank you. I cannot hear you. We're very faint. Sorry.
Right now, okay. Okay, Alex, thank you for your presentation. It's wonderful, great experience, and of course we are getting into the class protocol, so we don't have time. So I want to say again thank you to you. We will go forward
Vamos a continuar con el programa.
We're going to continue with the program. So now we have the Medtronic Symposium. I'd like to let you know that tomorrow, please don't forget, tomorrow we are going to begin the cardiology segment at 8 a.m. No, at 9 a.m. and we will be closing at 1 p.m. And then we have the SILAN segment, and they will also be doing it from 9 to 1 p.m. Alexander.
Yeah, now I can hear you.
Now you can hear me. Sorry, Alex, because the microphone were off. So sorry for this. Thank you again for your support and for the support from Philips. And we don't have so many time for the questions. If we have some questions online, we will give it to you afterwards. But again, thanks for your support and for Philips. Okay.
Thank you very much. Pleasure.
Okay. Seguiremos adelante entonces con Medtronic.
We will continue with the Medtronic Symposium. We will hear Dr. Pedro Lylyk, who will refer on his experience 13 years with the registry, with the pedestrian experience in Buenos Aires.
Hola, buenas noches. Bienvenidos al simposio.
Good evening and welcome to the Medtronic Symposium, closing this very long day. We're going to share not just our screen, we're going to share 13 years of an incredible experience in the city of Buenos Aires. These are my disclosures. I am consultant for the company. Obviously, we have a link. This was the curative experience of the endovascular reconstruction experience in Buenos Aires at our international center. First, I have to thank my team, all my team, an incredible group, all these years that constantly renewed, and also with very solid pillars. The overview is the history, the evidence, when we went from classic to flex and shield, the difficulties that we had. We're going to review some cases, complications, and we will try to talk about how we manage complications, always focusing on the patient. Aside from the aneurysm, aside of the device, the most important thing is the patient. There's still a lot of hemorrhagic stroke in the city of Buenos Aires. We continue to use coils. However, more and more these years, we are using stents, flow diverter. In 1996, we used our first intracranial stent with coils at the time, a dissecting aneurysm. And from then on, we learned a great deal. First, I want to thank Dr. Wakalu's idea. They had the vision of thinking of the stent as a flow modifier. This idea we worked on very intensely here with Tim Nelson, Makoto Orta in Geneva, where we created the intracranial stent group, and then Nelson, Peter Kim, and Aaron Perez through the company that they founded, and which made us think that many of the non-treatable patients could perhaps be transformed into treatable patients. The early primary evidence that we began to see of all this in 2010. How? Modifying flow. Just as you can modify the flow in this fountain, we can modify the flow also in the intra and extracerebral area. This development of the company, Chestnut did it first, Covidian thought that it was important, and Medtronic accompanied the whole process. And we are very grateful as physicians because they gave support to the technology. In 2005, we started out with our first animal lab studies, and then we received the benefit of all the trials, and we did our own trials also in the city of Buenos Aires. We can say now that we're at this stage. We are changing the surface of flow diverters, repairing arteries within the brain to treat intracerebral aneurysms. We started with the classic, and now we are working clearly with the shield. We use several generations, as you see. The experience is extensive in Buenos Aires with other devices as well. Why? Why did we have to change? Because we had to improve and innovate. It's a complex problem that we treat, not just the formation, the growth we know little about, and we are learning more and more about the rupture. Endovascular technicians, for us, the internal conditions are very, very important. For microsurgery, neurosurgery, the external conditions are also important. Both of us, however, have a common problem of the wall. We have to learn biology of the wall. When do we use flow diverters in Buenos Aires? Obviously, in the unruptured. Last option for rupture. It's not the first indication for the ruptured ones. And obviously, we have different sizes, different diameters, different lengths for different segments. In the aneurysms, the open flow, we treat the segmental defect. When there is a long defect, very extensive, affecting more than a fourth of the circumference or the same length in these aneurysms, like this is like a train, several wagons. In these segments, therefore, it's when we use a flow diverter to revert this. What do we do? Well, ultimately, we modulate flow. We do flow modulation. So I'll show you a case. Here, 4 aneurysms along the same segment. The most proximal is at the arising of the ophthalmic. What do we do here? We need to work here to modify the flow. What we have to do is make the flow go through this channel that's put together. What does the channel do? What the channel achieves is that the aneurysm becomes smaller and smaller because of the pressure gradient towards the ophthalmic artery. What have we done? We've modified the flow in the ophthalmic, and we can do it in bifurcation aneurysms too. This one bled, we put in coils, it recanalized, and we put a very small flow diverter in, which after 15 months, see how it remodeled the artery. And this is how we learned. We learned to reconstruct these arteries and to consolidate the thrombus formation so that there could be circulation exclusion of the aneurysm. And then the With different flow diverters, we're always trying to exclude the thrombus. What have we learned? We learned a great deal. What are the indications? What diameters? What lengths? How far we could go? What would happen regarding the durability of the treatment? A question we need to answer on a daily basis with the new devices that come to the market. We learned the complications. That could be early, could be late. We learned what happened with the jailed arteries, the ones that we passed through or threaded, and we were able to rule out the stenosis. The wide neck aneurysm, large and giant aneurysm were the first indications of the fusiforms, and particularly the dissecting ones. We also tried to recount them with coils on occasion. There was also, as an explosion, significant new development and improvement in the imaging and the visualization of the devices. The bioinformatics came to our aid, and we had the benefits of the research. See how we can see the devices today. If the distal end is open, is closed, or it is good apposition all along or not. We went learning about all of these things with time, and we received a lot of help from Juan Sebral and his working group, not just to learn how the grid was formed and what happened with the arteries that we jailed. We had to jail more than 90% as we learned to occlude the artery. And the most important thing was what happened with the occlusion. We were able to see whether there was risk of rupture or not. These are all working lines of the Dr. Sebral and his Church Patient Center, which helped us a lot. We had pilot studies first carried out in Buenos Aires. We worked with Peter with several trials, and we also started out our own experience, which we include in a prospective register, which is the pedestrian registry that I'm going to present the evidence of today. We have over 1,000. We are almost at 2,000 almost treated aneurysms, and we've used, of course, more than 2,000 devices in these 13 years of our experience in Buenos Aires. The numbers correspond to our experience between March 2006 and July 2019. Of course, we had of the anterior more aneurysm than the posterior, and much more saccular than dissecting or fusive. More than 80% were saccular aneurysms. More than 1/3, more than 30% were large or giant, and our percentage in this sample of 1,000 aneurysms, we use more than one flow diverter. See the number here on average. We show our persons in neurosurgery. Now we're at 6% morbidity mortality on this learning curve, which we have had throughout these years. And of course, the morbidity relates to thromboembolic events. Mortality was linked more to hemorrhagic phenomena. The flow diverter today in Argentina and in most of the world is almost a routine practice. The flow diverters have also been used in our city, in Buenos Aires. I can't give details. I don't have time. But what we did learn is that they were safe, very efficacious, and we have long-term follow-up now. I'm going to show you our first case. Patient had an AV malformation, and aneurysm treated with coils compacted in the fundus. We treated the malformation, and we treated the aneurysms. And 6 years of follow-up, we see the remodeling. Complete remodeling of the artery after 6 years. More follow-up. Everybody asks about durability. Every meeting we have to pass exams on this question. Proximal lines and more distal ones with time. This more distal one, here a one sign of a tenting. This is what remains of the aneurysm. See what happens with time, how there's remodeling of the artery with time, and how there is a decrease of the mass effect on the angiogram. This is after 7 years of follow-up. So we've had constant follow-up. I'll show you more. Aneurysm, more 9 years follow-up, 7 years follow-up here, 6 years follow-up. So the experience is similar to that of the South African, no, the Australian group, similar conclusions, very stable treatment result. We learned that we could put much more than one aneurysm. Here, 2 giant aneurysms in the siphon, another dissecting aneurysm in the vertebral circulation. And this is the 6-year control showing a stable occlusion. Many of the aneurysms that we treated were complex aneurysms. Why do we call them complex? Because they were difficult to treat. I'll show you one. Large MAC effect, more on the left than on the right side. Difficult passage distally. We attempted to rechannel the left carotid artery, which was compressed. One of the most important limitations of this case and other cases, which I'm sure you've all had experience on, is to find the exit orifice. Sometimes we have to open a solitaire device, sometimes a balloon for anchoring, put a coil in and use them as scaffold or support. Here, what we used were 2 guide wires, one on the middle cerebral on the left and one on the anterior cerebral on the right side, and this allowed us to put 3 devices of pipeline in a telescopic fashion. As you see here, there was vasospasm. So we loosen the system, and here we show the immediate control after embolization. And in follow-up, see what happens 4 months later. We see how there is a significant decrease of the aneurysm, and after 1 year, the artery has complete remodeling and no mass effect. At the beginning, as everyone is, we were concerned with the in-stent stenosis, which we felt there might be. This was a case where the aneurysm disappears, practically, and the stenosis at 3 months, at 6 months was less, and after 1 year, it had completely gone. So we only had improvements. Flex was better than Classic, and Shield is even better than Classic too. So we gained experience with all of these years. Now we routinely use the Shield. We found that the improvements are significant. The distal curve, the distal opening is more systematic, although we can sometimes revert the distal plug on occasion. However, the improvements have been considerable in this regard. The conclusions that we have regarding Flex, the improvements, Flex has been the most important, but much better than that even is the Shield technology. The hydrophilic cover makes it slide very much inside the microcatheter, and we therefore have the benefit of the phospholine. I'm going to show you some cases where we totally reconstruct the arteries. This is a paper that I want to share with you. It is from Matthew Goonis, their group, where they showed that they used it in rabbits, and they showed that the modification with phosphorylcholine was linked to less thrombus formation in the surface of the aneurysm. And they saw this with intravascular imaging, spectacular intravascular images of high resolution, which will become the rule for us all, surely, in the near future. Some groups, this is an Australian group, Venderoth, Nathan, they use single antiplatelet therapy. This is their experience. It's not been very consistent. We, in some cases, do use monotherapy. And this is a reconstruction of the carotid. An Ehlers-Danlos loss, an aneurysm of the intercavernous carotid with dissection all the way up to the origin of the internal carotid. So we did a full metal jacket. We reconstructed the whole artery, and look at the artery 1 year later with entire reconstruction with 5 flow diverters. This is pre and post reconstruction. Much, much simpler. And we thought, giant aneurysms like this one, severe mass effect in a young girl. She was a dancer. prior to treatment. This is 1 year later, before, after, how the mass effect disappears. Not just the cross-section images, MR, CT, but also on the angiogram. And she could go back to dancing ballet. Clearly, in the cases of the giant and large angiogram, we'll come back. The management of blood pressure and of steroids is very important, particularly if the patient presents symptoms or symptoms worsen. In those cases, we give deposit steroids. With time, we pushed our boundaries and we started treating smaller aneurysms, where safety was recently proven in the premier study with a long 3-year follow-up. Our experience is similar. Not only do we treat small aneurysms de novo, but some remnants, like one you see here after 6 months follow-up, or here where there is remodeling, just using the flow diverter in the carotid. See how the aneurysm disappears and it becomes a normal PCOM. Posterior circulation aneurysms, we have some experience with them too, little more than 10% only. The best indication are these aneurysms where the artery is dissected. We reconstruct entirely one of the arteries. Here we chose the right one, and we see how there's compression, there is decrease in size of the dissection, which disappears after 7 months entirely. This is a new artery practically, and this is the patient, how he's grown and how he's done so well. The jailed cerebral branches, many of these, not just the small ones, but also larger size, 1,000, 2,000, and smaller ones too. And here is where we've had a couple of complications that I also want to share with you. If there was a prior stent, particular with bad apposition against the wall, that's when we had these problems. So here we put a flow diverter inside in telescope way, the aneurysm disappeared entirely. But what happened? We had a pontine infarct in follow-up. I mentioned at the beginning that this was not designed for rupture cases. It's only the final or last resource. We've only used it, like in this blister-like one, pre-treatment, 6 months after, you see the lesion has disappeared. Another at the origin of the pica, where there was a dissection before the choroid point. We were lucky. We were able to reach the vertebral and we covered it entirely. This is another use in blister-like with a severe bleed. This is an aneurysm patient that bled day 0, the angiogram. The patient re-bled day 3, second angiogram. Look at the blister-like growth. We did a jailing, we put coils in, and we placed 3 pipelines in. We gave antiplatelet with agrostat in acute, and then we carried out with ticagrelor. This is a 3-month follow-up and 6-month follow-up, showing the complete remodeling of the artery. The bifurcation aneurysms, limited in our series, under 5%. We didn't know what was going to happen with the lateral branches, whether we had to use adjuvant coils or not. I'm going to use some cases. PET 3x14. This is a left MCA, coils rechanneling. You see here how we place the flow diverter. And this is after 2 years follow-up. The pressure gradient remains an open vessel at 26 months as shown here. And now the case, patient that bled, put the coils, re-bled, coils again, and finally we were able to stabilize it with the flow diverter in the distal MCA. Look how the flow goes through, and this is the 14-month control image. The second treatment, and for vasospasm, we did the dual treatment. The patient had a very good outcome. Distal aneurysms. like this one, dissecting distal, good indication, also 7 months follow-up. Limitations, problems that we had, access, as I mentioned, to find the exit can be a problem. In some of them, we didn't have the adequate length. Now we have up to 50 length. We have 30, we have 35. Some, when the diameter is not in good relation, they can shorten. When we deploy the device, as you show here, they can be shortening. And so what happens is the bridge can break, as occurred in this case. So here we put in 4 device, and device. The bridge broke. So we had to remove the 2 distal, 1 and 2, and we had to reconstruct, start over. We removed the distal ones and the proximal ones. You see, we use these old device to remove them. We went through here and we reconstructed up to the middle cerebral artery using another 2 devices, and this is the final reconstruction. And after 1 year, we see how this decrease in the artery improved, as I showed before. Stents that are prior have been a problem. This is our experience. We reported this very early on. This is a mass effect, imported edema around the aneurysm here. We treated and retreated. First, there was a stent and coils. We put a PET, a second PET, and look, it continues to open. It's still open in spite of time. We maintain the patient with dual antiplatelet therapy. So we've had limitations, we've had difficulties, we have had our complications throughout all of these years. I'm going to show is bleeding is our main complication. It's not common. Fortunately, 1.5% only of our series. The mechanism can be of 2 types. This has been very well explained by Dr. Wakalu in this review. It's the sum of the hemodynamic mechanisms and the intra-aneurysmatic thrombus, which eats away at the wall when there is a release of inflammatory markers. However, if on top of this we treat a complex aneurysm in patients with antiplatelet therapy, it becomes a big problem. We try to solve it, though. We can use coils, more than 1 flow diverter, but I think we have to be, in particular, very careful with the antiplatelet treatment. Antiplatelet tests we have been using. We use Verify Now and controlling the blood pressure in the large and giant aneurysms, and probably with new devices in the future. Complications can be hyperacute, I'll show one, but they can also be acute at 24 hours. And here we can control blood pressure very, very well, or they can be subacute after 1 week, or chronic. We call them chronic after 1 month. Here it's not a hemodynamic mechanism at all. These are the proteolytic enzymes that eat away at the wall. So I'm going to show a case. This is an ophthalmic case. We place the device. We are super happy with the device, the way it looked, the way it was placed. And in the waiting, while we were changing the incidents and we were talking amongst each other, we had this hemorrhage. And the 360 maneuver that we conducted inside the aneurysm was probably what caused dissection of the aneurysm in this case. And this is the CT scan of that patient. When this happened to us, we reported it immediately with Dr. Several, and we attempted in 2011, we tried to find a hemodynamic explanation for this. But with time, we saw that it wasn't just a hemodynamic. Because other groups that were using additional coils taught us this was a case that had been treated previously with coils. We put the coils in, and we were able to put coils in a flow diverter, and the patient bled anyway after we put the flow diverter in, immediately after the treatment, 10 days after we put the flow diverter.
The solution was not with the coils. The problem is very complex, and actually, you have to very carefully plan treatment and be prepared. You have to learn a lot, and we have learned a lot in the use and the control of antiplatelet therapy. We have been using clopidogrel for 2 years. We use prasugrel, and I believe that controlling hypertension is crucial. This is a very good paper from the Japanese, clearly showing that hypertension is correlated with rebleeding. So what are we doing now? We are working intensely on the wall of the aneurysm, trying to find an improvement, particularly in those cases where the wall is reinforced. We use coils, and when it doesn't, we only use flow diverters checked by MRI. We continue seeking for the Holy Grail. The company has used all possible resources, and we have more devices, and the shield technology has arrived here to stay. But for us, these 15 years have been extraordinary, rewarding experience. For the first time, we can see that we are curative in treatment, more than 90% cure. And when you achieve cure, we haven't had recanalizations, we've been quick, we receive less radiation dose, we radiate the patient much less, and we continue to look for the magic wand. We have to improve our understanding of the wall and thrombosis, but this has been an amazing experience, very well summarized in the last paper we published together with Dr. Fiorella. Before thanking you for staying this extra 30 minutes with me, I'd like to invite you that together to see what's new in October 2021 in Shanghai, together with SIMI. Thank you for having stayed this long. Remember, tomorrow we'll be back with you with SIMI from Buenos Aires. Thank you.